Hello.
Good morning, everyone. So we are come to the last day of our Trendo session. I would like to invite Dr. Felix on the stage. He's going to be moderating the first case discussion. This is going to be on hyperplanemia, case-based discussion, and he will be introducing the speakers. Thank you.
So good morning, ladies and gentlemen, and warm welcome to Trendo 2022. And on the outset, I like to thank the organizers for organizing such a wonderful academic feast over the last 1.5 days, and it's going to be much more for the next 1 day. And let's go into straight to our topic for today. It's about case-based discussion on hyperprolactinemia. So we are going to have 4 panelists here. I would request a panelist to come on stage, please. Dr. Sundaraman sir, Dr. Anandakumar Annamalai, Dr. Adeline Rina Asirvadam, and Dr. Senthil Raja. So I welcome the panelists again. Thanks for coming. Our discussion would be like this. We are going to have 4 case-based discussions, and it will be a discussion between the panelists, and there will be an educational point and subsequently on that. And if there is any questions, we are happy to take up those questions in the last few minutes of the presentation so that we can have a lively discussion furthermore. So I'm starting with the first case. This is a lady of 29 years who has come to endocrinology OPD with a history of Galactoria over the last 1 year, and she's married and eager to conceive, and she had irregular cycles with amenorrhea over the last 1 year, 2 years, and had weight gain, and she's not on any other medication for her current illness. When we examined, she had dull face with dry skin and slow ankle reflex, no other hypercalcemic signs or any other sign, but she was having Galactoria, had a clinically palpable goiter with a slightly high diastolic blood pressure and pulse around 66, and a cardiovascular system a little muffled hot zone. So I would like to ask the panelists, Dr. P.G. Sundaraman sir, so what is the mechanism for a Galactoria in patients with hypothyroidism? Because this is very clinically a patient with hypothyroidism. So what is the mechanism of Galactoria in patients with hypothyroidism?
Once again, I must thank the Trendo 2022 for giving me this opportunity. In fact, it's quite interesting that prolactin is a very primitive hormone. In fact, a small introduction about it. It was actually the molecule was isolated in non-humans by Oscar Riddle. And in fact, that was initially for the electrolytes, ion exchange, and for milk production. Now, prolactin is a very unique hormone in the sense that it is not only produced in the pituitary gland, but it's also produced from various tissues. In fact, the decidua also produces prolactin, the breast produces prolactin. And unlike the other pituitary hormones, the feedback mechanisms, the axis, is not full-fledged, and it is always under the inhibitory mode. And it has got a lot of functions, including immunological function. And if you find the major inhibitory hormones are the dopamine, the GABA, and the somatostatin, and which stimulates the prolactin secretion is the TRH. And also, it is being stimulated by oxytocin, BIP hormone, vasopressin, estrogen, norepinephrine. So, TRH in hypothyroidism is elevated because when there is a low secretion of T3 and T4, there is a feedback axis that stimulates the TRH production, and TRH, which is a stimulant of prolactin hormone, stimulates the prolactin secretion. So in turn, this prolactin gives rise to the signs and symptoms of hyperprolactinemia that causes galactoria. So that is the basic mechanism of the TRH causing elevated levels of prolactin.
Thank you, sir, for the well explanation. As we further proceed into the investigation, this lady had a slightly high normal creatinine with prolactin in dilution around 122 nanogram per ml. It's important that we need to look up the reference range for that particular lab because there are at least two different values, and even sometimes in molar values also they tend to give the values. And TSH is high, and as expected, the total T4 and free T4 were low. So I would like to ask Dr. Senthil Raja, so how does this prolactin causes an ovarian dysfunction, especially in this patient?
Yeah, good morning all. This prolactin is how it causes the reproductive dysfunction is mainly it inhibits kisspeptin neurons in the hypothalamus, so thereby GnRH pulsatile secretion will be less in patients with hyperprolactinemia. At the same time, it inhibits FSH and as well as LH secretion at the level of pituitary. Third thing is, at the level of ovulation, it inhibits folliculogenesis as well as it causes luteal phase defect. And in patients with pituitary adenoma, macroadenoma, because of mass effect also, the gonadotroph will be suppressed. So these are the mechanisms where it can cause infertility.
Thank you, Dr. Senthil. And Dr. Anand, can you just mention how does the high prolactin, what is the line of management for this patient?
So as reiterated by my colleagues, so here the increased prolactin is because of the increased TRH. So the importance is we need to reduce the TRH. And how are we going to reduce the TRH is by treating the hypothyroidism. So we need to initiate levothyroxine for this patient, and by doing so, that would decrease the TRH and that would decrease the prolactin. So we would need to initiate levothyroxine for this patient as the line of management. The important issue obviously is to titrate as per the TSH, and that would result in a normalization of the prolactin.
Thank you, Dr. Anand. So the learning objectives
I
is
just
that
want to add one more line because it's for the practical aspect of the obstetrician. Many times you find that the people add on dopamine agonists like bromocriptine. Now here it is not essential to add on the dopamine agonist along with the thyroxine. So many times they combine both thyroxine and bromocriptine. So that must be avoided because sometimes it takes time for the prolactin to decrease. So that must be kept in mind.
And would you like to add up any more information on this particular topic we are having? In terms of, you want to add on anything on subclinical hypothyroidism and a mild rise in prolactin?
The hyperprolactinemia in this case seems to be secondary to the overt hypothyroidism, as already mentioned, due to an increase in TRH. But subclinical hypothyroidism can present or can have hyperprolactinemia, but it's usually very mild. And many times it goes unnoticed because the borderline elevation of prolactin doesn't have a clinical impact. But having said that, even some case series are there to show that even treating subclinical hypothyroidism can bring down the prolactin. Now, just wanted to mention that the mild raised creatinine seen in this patient is also secondary to the overt hypothyroidism, possibly due to the low eGFR that happens because of hypothyroidism. So treating the hypothyroidism will be the bottom line for the anovulation and also for the raised creatinine in this case.
Yeah, thank you, Dr. Adler.
I'll just add one more, Felix.
Yes, sir.
So
Please.
the other important thing also is in terms of management, because many times, people get a scan without a need in this kind of a situation. And because of what has been discussed, because of the lactotroph hyperplasia, you would actually find that actually the pituitary is enlarged. And this must not be mistaken for a pituitary adenoma and wrongly sent for surgery. I think that is a very vital thing which needs to be understood, that we should not be scanning this patient. And for anyone with a high prolactin, doing a baseline TSH is very, very important.
Yeah. Pituitary pseudotumors can be missed out and might be thought about like a non-functioning or any other pituitary macroadenoma and probably been referred for the surgery. Yes, sir.
Sorry, am I allowed?
Yes, sir, please.
In addition to the other, one more academic point is since reproduction is discussed, PCOS kind of situation can get aggravated both by hypothyroidism and by hyperprolactinemia, and that also need to be after treating all this, that may get unmasked from below.
Yes, sir. Thank you for the added point. So the learning objectives is that when a patient with hypothyroidism comes, if they have a mildly raised prolactin or maybe a frank prolactin, it's important to look for hypothyroidism as part of the investigation. So that's what been evident in this particular patient, where we had overt hypothyroidism with mild hyperprolactinemia, wherein the patient has been planned for thyroxine therapy. So going on to the second case, this is a lady who came with history of Galactoria and been married for the last 4 years, has irregular cycles, and this lady had no features to suggest hypothyroidism clinically. However, she had weight gain of around 6 kgs over the last 2 years, and on probing, she was taking domperidone for her abdomen pain over the last 1 year. So the clinical findings were suggestive of Galactoria, and her investigation was suggesting a mild prolactinemia when was done prolactin dilution, and the TSH was normal. So I would like to ask Dr. Anand, what is the reason for the high prolactin levels?
The most common reason in this particular situation is going to be probably drug-induced. So if you look at the history, this particular person was on medications which included antiemetics. And as P.G. Sundaraman sir said, initially, we need to understand that how the prolactin is basically under the control of dopamine. So we have the arcuate nucleus in the hypothalamus, and then we have the connection from the hypothalamus to the pituitary through the dopamine, which basically exerts its effect through the D2 receptors. And that basically inhibits the prolactin. And with agents which actually act on this pathway, whether it is a pharmacological aspect or it's a kind of compression, this would alter this pathway. And specifically with some agent like domperidone, which basically is a D2 receptor and D2 receptor blocker, you basically would get an elevation of prolactin because of this. And generally with drug-induced hyperprolactinemias, we would expect ranges around 100. With some agents, like risperidone, you could even reach up to 200. So it is important to identify a drug-induced hyperprolactinemia.
Thank you, Dr. Anand. I'll just ask Dr. P.G. Sundaraman sir, so how do you address this problem? Because we know that quite a lot of drugs cause this problem of hyperprolactinemia.
Yeah, it's quite interesting that as Dr. Anand has highlighted, that if you have a deficiency of the dopamine in form of secretion or in the form of metabolism or in the form of receptivity, then definitely the prolactin will be elevated. So they have listed down the causes of the medications that will cause hyperprolactinemia. One is that to understand it, we can stop the drug for about 2 weeks, then the prolactin decreases if it is going to be a drug-induced one. So that is one form. Or if it is due to a drug-induced, we can change the medication. For example, antipsychotics, lesser psychotic medications like risperidone can cause an increase of prolactin elevation. Then that can be substituted by ariprazole or olanzapine or quetiapine, like these drugs, which does not have much effect on this dopamine axis. Third is that we can reduce the dose of the medication and see whether this dose of medication reduction causes a decrease in the levels of prolactin. The third possibility, where you cannot avoid that medication, you can add on a dopamine agonist. But the problem with the dopamine agonist addition is sometimes can precipitate the original symptoms. So we must get in confidence with the psychiatrist that the patient is already on antipsychotics to know whether if you add on this medication, it will exaggerate the clinical symptoms. So these are some of the possibilities that we can think of when you know that it is going to be a drug-induced one. Another interesting one, some of the cases I've seen that as soon as they find a high prolactin, they do an MRI scan. And sometimes you find a small incidentallomas. Then they think that it is due to the tumor, they start treating it. So that must never be as a reason for starting the dopamine agonist. You must stop the drug for 2 weeks and see whether it is a drug-induced or not.
It's very important to get the clinical history first before going for the next step of investigation, because if a patient is having history of psychosis in the past or schizophrenia, the risperidone can increase the prolactin multifold and even more than 500 nanogram per deciliter for your lab also. So it's very important that before going for the investigation such that of an MRI, it's important to go for the good clinical history, because it's very, very important to have that.
Just
So
to add on, many times patients don't reveal the history of antipsychotics and antidepressants. They may come out with the PPA use. So maybe repeated questioning may bring out that they are on drugs, and that will help us to help.
Yeah, exactly, because many times patients say that I'm taking pantoprazole, but when you ask them to bring the prescription slips, it says pantoprazole, and the patient may be taking pantoprazole plus domperidone combination for many years unknowingly. So that's actually, it's a very, very important clue. We just need to probe in to get the history in detail.
Another interesting phenomena is that if you find the prolactin is more than 250 to 300, it is likely. If you find something less than that, then you must think of secondary causes. That's very important.
Dr. Sandil, would you like to add up some more on the solution for this particular problem?
Yes, sir. Along with for dyspepsia, this domperidone, levosulfurate is also commonly prescribed. So most of the time when we are asking, patients will be taking either pantoprazole with domperidone combination or pantoprazole with levosulfurate. So we should avoid domperidone and levosulfurate to extent possible, and at the same time, if patient is taking antipsychiatric medications, we should have a discussion with the psychiatrist. The antipsychotic medications which can cause least elevation of prolactin levels, like aripiprazole, qutipin, these also can cause mild elevation, but not to extent of risperidone like that. So we should have a discussion with the psychiatrist also. So we should avoid commonly this nowadays, like multivitamin and calcium, this domperidone and levosulfurate is commonly prescribed. So we should avoid these medications.
Yes, sir. Please add on, sir.
List is alternative medicines. We have seen quite a few occasions. We have reported also, like Pankaja Kasturi. Recently, I think my PG is here. We had a patient where this green tea was taken specifically, this Lipton green tea was containing something, and after stopping it, it is coming down. So there are many things which, you have to probe.
Yes.
And prolactin, very sensitive hormone, I think. It is affected by many things, and some of the herbal and other products, we don't know what they contain.
Yeah.
So best to stop everything and reassess.
Yeah. Any kasayam, maybe we don't know the content, might be a cause for prolactin elevation in any of our patients. So it boils down to the point that history is the foremost important for a patient before going for the next investigation if they have a high prolactin levels. So I just summarize that the first and foremost thing in patient with, if they come with a Galactoria, is history. go for a detailed history, probably back and forth in their old reports is very important, because many times patients tend to forget or mask their past history that they might be going for antipsychotic therapies, or they may be unknowingly taking a medication which has an added liver sulfide or domperidone. And it's important to liaise with a physician or an psychiatrist to make sure that medication is changed, because particularly in this patient is having primary infertility and probably multifactorial, but this hyperprolactinemia also could be a cause for the problem. So going on to the next patient, this is a 24 lady married for the last 1 year, and on primary infertility therapy she was gained weight but no hypothyroid symptom, and she had Galactoria. So the investigation showed that the physician mentioned that to do a prolactin, and it came as 34 nanogram. For that particular lab, it's slightly high. So I would like to ask Dr. PGS, so that, so what are the other reasons for high prolactin levels other than whatever we have mentioned?
Yeah, the prolactin elevation can be of physiological or it's going to be pathological. Now, there is also physiological elevation like pregnancy, lactation, stress, and those are basically physiological. Even wearing a tight garment over the chest, that has been one of the inciting causes for elevation of prolactin, or a repeated nipple stimulation or sexual intercourse. All this can increase the physiological elevation of prolactin. Apart from that, the pathological are, it can be due to a prolactin secreting adenoma, or it can be any other lesion in the hypothalamo-pituitary region which is causing stalk compression, or the entry of dopamine is going to be curtailed. Then apart from that, we must think also of renal failure and hepatic failure. Many times chronic kidney disease, there can be an elevation of prolactin. So that must be taken into account. And sometimes you find an analytical problem with, in the case of a macroprolactinemia. So these are things that must be kept in mind. So whenever you see a Galactoria, and you must think of the physiological, rule out physiological causes, then go for a pathological causes. And in case when there is a very mild elevation, you must also think of a polycystic ovarian disease. That's also into, that is one of the important issues that is cause a elevation of prolactin.
Thank you, sir. Dr. Anand, would you like to elaborate much more on this particular problem, because we had here the prolactin of 34, and the patient is having a Galactoria. There is kind of a slight discordance there here, and so can you please elaborate on this?
Yeah, as PJ sir said, I think it is important to understand whether this is physiological or pathological. Now here we have a patient with a high clinical pre-test probability. So you have a patient who has Galactoria and who is actually presenting with basically a prolactin which is borderline high. So we are very dependent on the laboratory to kind of assess whether this is a true rise or this is just a false rise. So it is important to understand that prolactin is measured through immunoassays. And immunoassays, can be, fooled. So immunoassay is dependent on antigen-antibody complex formations. So you have a particular antigen, which obviously in this case is going to be prolactin, and you have something called the capture antibody and the detection antibody. And you would expect that these actually sandwich, and then it will show up as a luminescence. So here, if suppose, just in case, you have a very large amount of prolactin circulating in the system, if you basically saturate the capturing and also the detecting antibody, you will get a low readout, which actually is a laboratory analytical error. And this is called the high dose hook effect. So to eliminate this, nowadays, we have better assays, so that is important. The other important thing is to understand is to eliminate this, you have to basically, dilute the sample. The dilution is important. The recommendation is dilution of at least 1 in 100 is very important, because 1 in 50 sometimes is not enough. and you have to dilute it to 1 in 100. And if you dilute it, it may show up as a very high level, and it may actually prove to be, a good point to diagnose. So this is an important thing to consider. So the laboratory is key in making the diagnosis. And also when you take the sample, if there's repeated venipunctures, as Sir mentioned, sometimes physiological causes, that could also basically, cause a rise. So that needs to be, looked at. But normally, if it's a good laboratory, it should be good.
The only thing that I want to add is that it must be taken in a fasting state. The prolactin sampling must be taken in a fasting state, and it is always better, even though it has got a long shelf life, you must take a pooled sample also, or repeat the prolactin again, as Dr. Anand has highlighted, that whenever you have a doubt, you must repeat or you must talk with the laboratory. What is the problem? Then we can sort out the differences.
So yeah, it's very important that when you order a prolactin in any lab, it's important to do it in dilution, because high dose effect can predominantly affect lab estimation, as already been discussed. So if you don't mention it, the lab is likely to miss it, and there is likely that we our diagnosis might be delayed also. Dr. Senthil, what are the pituitary specific causes for high prolactin? Because we know that this lady has prolactin in dilution of 300 nanogram.
Yeah, the most common cause is prolactin secreting pituitary microadenoma, followed by pituitary macroadenoma. Sometimes this GH secreting pituitary adenoma can co-secrete prolactin. Non-functioning pituitary adenoma also can cause, because of the stalk effect, it can cause mild elevation of prolactin. So these are the pituitary causes. Apart from adenomas, hypophysitis, lymphocytic hypophysitis can also cause elevation of prolactin. Sometimes patient will present with Galactoria as initial manifestation, and supracellular mass like Rathke's cleft cyst, craniopharyngioma. So any supracellular mass by compression stalk effect, it can cause elevation of prolactin level.
PG sir, can you just elaborate on the signs and symptoms of prolactinoma?
Yeah, it's quite interesting that there was a study in Massachusetts Children's Hospital. In fact, I thought prolactin elevation is unlikely in children, and that can be due to kidney failure or hypothyroidism, those or a tumor situation. Normally, the symptoms start from the adolescent period. There I have seen people presenting with primary amenorrhea. Higher prolactin can cause the primary amenorrhea as one of the important reasons, or a polycystic ovarian disease, where it can cause acne or minimal hirsutism. And in cases where in adolescent population they can have, after the menarche, menstrual irregularity, and also they can have amenorrheas. Many times they have amenorrhea, and in the reproductive period they have higher chance of infertility and ovulation. It's quite interesting that sometimes even a minimal elevation of prolactin can suppress the GnRH rhythm, and that can cause anovulation and it lead on to infertility. And in cases where if the hyperprolactinemia is present, it can also lead to bone changes, and it has been shown that it can cause osteopenia and osteoporosis. Now, whether this has an affection on the males, yes, definitely they have erectile dysfunction. They also have the changes in the semen quality, and sometimes very elevated prolactin levels sometimes can cause galactoria even in males, and it can also result in the reduction in the size of the testes also. So these are some of the finer points. So whenever a male is complaining of erectile dysfunction, then definitely you must look out for prolactin. And what are the signs, symptoms I told you for women? Definitely you must go into and probe and do a prolactin estimation.
So, Dr. Adlin, this is the MRI was done for this patient, and would you like to add a few points on this particular patient where he has microadenoma?
This MRI shows an hypodense lesion on the left side of the pituitary gland, suggestive of pituitary adenoma, and in this case, possibly a prolactinoma. And on the right hand, we can see the contrast uptake of the adenoma. Usually, what we need to understand is, just to add a point on the hook effect also. So usually, the prolactin will be not very normal. So you have an hook effect. You tend to, what I'm trying to say is the prolactin will not be normal. The prolactin will be high, but not as high as what you would expect in terms of a macroprolactinoma or a microprolactinoma. Instead of being in thousands, it would rather be around 100 or 80 or so. So that way, you will never miss a prolactinoma. But many times when you have an MRI showing a pituitary lesion like this, and when you see the prolactin levels not as high as you would expect, probably a dilution is mandatory. Now, prolactinoma is the most common functioning pituitary adenoma, and we have very good agents, the dopamine agonists, as has been discussed. And what we predominantly use is cabergoline, and they do respond very well, unless for rare occasions. So we generally start with 0.25 milligrams or 0.5 milligrams more commonly once a week, and we often follow them up with repeat prolactin levels, maybe at the end of 2 to 4 weeks. And then the cabergoline, mainly what it does is not just reducing the prolactin level, but also offers a shrinkage of the tumor. So that is the only medical management that is possible for any pituitary lesion for that matter.
Yeah, thank you, Adeline. And we know that cabergoline is the therapy for this problem and not the surgery, because this particular lady is planning for pregnancy. Would you like to give any specific instructions in this patient when they plan for the pregnancy? Because the primary problem is infertility in this patient. So,
I think one such rewarding thing is when you treat prolactinoma very well, the chances of spontaneous conception is very high. So we have had patients who on cabergoline therapy do conceive. Many times we'll be wondering why the prolactin is normal, patients are still having amenorrhea. It might be pregnancy. We have had instances like that. So one of the rewarding causes of prolactinoma, of treating hyperplastinemia, is to have a prolactinoma with infertility. The moment you initiate them on cabergoline, they do respond well, and spontaneous conceptions also happen.
Yeah. Dr. PG, sir, can you just elaborate that this lady is, consider that she is pregnant now. What about the cabergoline subsequently? Shall we continue? How do we take it further from there?
Yeah, there are studies of the tumor growth during pregnancy. In fact, for microadenoma, it's around 3 to 4%. And for macroadenomas, it can be about more than really about 30%. So microadenoma, the increase in size is not very great. And in fact, when you have a definite shrinkage of the tumor and the normalization of prolactin before the pregnancy, it's definitely we can stop the cabergoline. You know that the two important medications available in the market, one is the bromocriptine and cabergoline. The bromocriptine must be given daily because of the short half-life. Cabergoline is given about 2 times a week or maximum 3 times a week. The maximum dose of bromocriptine is 15, and for cabergoline is 3. So whenever they enter the pregnancy, it's better to stop it. Now, there are conditions where you cannot assay a prolactin level during pregnancy because it tends to be increased, because pregnancy is a physiological cause for elevation of prolactin. So we cannot assay a prolactin. The only thing that we can assess by the visual field or very rarely by an MRI scan. So I think as we proceed with the discussion, we'll be having more discussion on it.
Other panelists, would you like to add any on how to follow up this patient subsequently in the next trimester and postpartum? Would you like to add up?
See, I think pregnancy is a very important and interesting aspect. I think the question basically addresses 2 things. What does pregnancy do to the pituitary, and what does the drug do during pregnancy? I think these are the two things which needs to be addressed. Now, if you look at pregnancy per se, leave alone, a person with prolactinoma, you take someone, a normal person, you would expect that the pituitary increases in size gradually with each trimester. And even postpartum, the first week or so, the rise is very big. And this is contributed with two things. One, because the pituitary is very vascular, so you're going to get an increased blood flow. And also the estrogenic effect of the pregnancy is going to stimulate the lactotroph, so this is going to happen. And this is what Pijasa was saying, that along with this, the adenoma rise can also be there. Generally, it is purported to be not very high. And if someone is pre-treated well, this is not there. So the principle is, if you pre-treat and you plan the pregnancy, you can stop the dopamine agonist therapy at the point of when you know that they have conceived. Now, looking at drug trials, so cabergoline and bromocriptine in pregnancy, the widely studied drug is actually bromocriptine. You've got at least 6,000 odd patients studied, and they've been followed up, even infants, children have been followed up close to 9 to 10 years, and people have done well. So with pregnancy, the maximum data is with bromocriptine. However, as mentioned, cabergoline is more specific. It is very important in terms of its very rapid resolution in terms of the tumor size, prolactin normalization, symptoms, and also fertility. So that is why we prefer cabergoline. And in terms of cabergoline, again, this has been studied, although not to that numbers in terms of pregnancy, but again, we would do the same. With microprolactinoma, yes, it needs to be stopped. Macroprolactinoma pre-treated too, it needs to be stopped. However, if you have someone with progressive compressive symptoms, you may consider therapy with careful clinical monitoring and also visual field assessments based on how they are doing during pregnancy. So it is a very fluid area depending on what the patient is having.
Yeah, few more points to add. We should educate the patients in case of macroprolactinoma. In case of any diminished vision, they should consult the endocrinologist or physician immediately. So proper visual field, in case of macroprolactinoma, at least once in 1 or 2 months, visual field examination is mandatory. If the visual field examination, if there is any decline in visual acuity, then only imaging is indicated. Unnecessarily, MRI is not advised in pregnancy. So close follow-up clinically and with visual field examinations.
Suppose this same lady has a macroprolactinoma of this particular dimensions in this MRI. How do you approach this patient? Can you please elaborate on this? Because when we look at an MRI like this, and the patient tend to say that, how can you start with medication? Probably I need a surgery and come for an opinion. Arlene, would you like to elaborate on that?
I think with such a macroprolactinoma, I'm not sure whether patients can have spontaneous pregnancy pre-treatment. So, as I said, the prolactinomas generally respond very well to dopamine agonist therapy. So even for a macroprolactinoma, the therapeutic option is only dopamine agonist, unless you have a significant visual field effects, which is very, very rare and which very rarely needs a surgical approach. So even in patients who have macroprolactinoma with visual field effects, we still go ahead and give dopamine agonist therapy. The precautions that we need to take is that whenever you have a macroprolactinoma that responds very well to cabergoline therapy, the risk of Csf leak is common because of the erosion of the cellular floor. So therefore, whenever we treat macroprolactinoma, we are very careful and instruct the patient that patient may have a Csf leak. So we start them on a low dose and probably follow them up more closely than we would for a microprolactinoma.
No, it's quite interesting that any elevation of prolactin will cause anovulation, and they will have more incidence of infertility. So conceiving is a problem. So at that point of juncture itself, one must evaluate the patient. So it is actually, these type of macroadenomas must be managed before the pregnancy itself. So if it is not subsiding with the medication, surgery is very important. So where you remove the adenoma, so that the probability of its going to be increasing is less. It is around 5%. So it is better these patients, when they come to us with infertility issues, then we are investigating, finding a high prolactin, or by doing an MRI scan, you have a macroadenoma. You must definitely pre-treat them with surgery if they are not subsiding with the adequate suppression with the medication, definitely you must proceed with the surgery and do this. In case if they become pregnant with a macroadenoma, the possible methods are only by visual field examination and if required MRI scan. So these are all subject to the patient evaluation. They have shown that people with the tumor abetting near the optic chiasm are a major risk factor. So they are supposed to increase in size much, and that may cause various other defects on the pathology. And they have shown that multiple studies have been shown that bromocriptine, lot of studies are there where it has been used during pregnancy. Even though cabergoline, they have done recent studies, they have not shown any pregnancy loss or preterm birth in these subjects. So it is also being used. But once again, it is very important and pertinent that whenever a patient comes with anovulation infertility, we must investigate for prolactin levels and do the proper treatment before the pregnancy. So counsel them. So before the pregnancy itself, they get treated properly, then you allow the pregnancy to occur. And even in very rare cases when there's a macroadenoma, they do a surgery in the second trimester, but the morbidity and mortality is very high.
So, yeah, as Peter sir said, I think it is very important that, pre-pregnancy counseling is, is given for these patients, and they have to have the pregnancy planning accordingly. So we have wonderful drugs to actually, normalize prolactin, actually reduce the size. So, we actually we should ask them to be patient and wait for normalization of prolactin and at least a 50% reduction in huge macroprolactinomas, as in this case, because, during pregnancy, it otherwise would be a nightmare. If obviously they are in a hurry, then you could offer transfemoral surgery, but with the caveat again that they could have hypopituitarism, which obviously would impair their fertility. So that is another issue. Another important aspect during pregnancy is someone who's a macroprolactinoma, even a microprolactinoma, rarely this occurs. Someone who's stable suddenly gets symptomatic, very severe headaches, splitting headaches. That is an alarm bell. So we need to sometimes warn our patients, say, if you're going to get these symptoms, you need to report to us immediately, because you could have a pituitary apoplexy, which could happen during pregnancy. And during the therapies, as Dr. Adeline mentioned, if there is a leak down the nose, that is important, because people will not understand what a CSF leak is. So we say that you have something like a nasal drip, which basically doesn't sound like a cold, or if you have a nasal drip which is on one side, that is something which you need to report. These are practical aspects which we need to tell our patients.
Yeah.
Another interesting point that I've noticed is some of these patients, especially coming from morning sickness, they consume the prokinetic drugs. So that must also be kept in mind, because the prokinetic drugs can increase the prolactin levels. So that must also, even though it's a very minor issue, one must keep in mind that adding this prokinetic or antiemetics can elevate the prolactin levels.
Yeah, it's very important that education is a foremost, because educating our patient, especially when they, we have discussed a couple of patients, micro and macroprolactinoma. It's important to educate them that come for a yearly physician intervention or treating doctor's intervention, because many times they do not know about the Csf leak or an apoplexy symptoms, because it's very easy to teach them, because if the patient bend forward or a unilateral nostril having a leakage, or a simple test is where they put their kerchief and take that, it does not stick like a mucus. So it's called kerchief test. So you can have a simple educating your patient to come for an early follow-up if they have a macroprolactinemia on treatment and conceived, because many times this particular drug cabergoline, we have seen in patients where when we give cabergoline in the morning, they tend to have some giddiness because of the postural hypotension, which is common in Parkinsonism. So this is one of the drugs which was given for Parkinson, anti-Parkinson treatment. So giving the cabergoline towards evening actually nullify this effect of mild postural hypotension also. So, so you mentioned, yes sir, you want to add up one?
No, another important point, just even though this dosage does not cause cardiac changes, because in higher doses of the bromocriptine, they have shown cardiac valvular or defects or fibrosis, but this is uncommon. The only thing that I want to add is, it's quite interesting that the postpartum remission of microadenoma is very high. Sometimes they can have a complete remission after the pregnancy with a microadenoma.
Yeah. So I would like to summarize here that mild prolactin elevation could be because of multiple reasons. One is hypothyroidism is a common denominator for that. Secondly, drugs is a very, very important cause for prolactin elevation, and as we discussed that there are products which is called as Pativaithyam and Kashayam, all may be having a, could be a stimulant for that or an inhibition for the inhibitory pathway which is suppressing the prolactin. So it's very important to get a good clinical history to probably even stop whatever the medication, unknown medication. And thirdly, this patient, they have a micro or macroprolactinoma. Generally, they are not fully an infertile because it's because of the prolactin elevation causing ovarian dysfunction. So treating them with cabergoline make them having a normal menstrual cycle and subsequently can have a normal fertility period also. And especially in macroprolactinoma, it's important that we need to aware that these patients, when we start on cabergoline, the tumor shrinks, and if once they become pregnant, there is a chance for increase in the size of the tumor because of the normal physiological change. So those patients, we need to keep them on close follow-up, especially with frequent visual field assessment, because that simple visual field assessment will give a clue that whether the patient has an if there is already an pre-existing field defect, that you can look for an worsening of field defect, and subsequently a MRI may be indicated if required and treat accordingly. So thank you panelists for the wonderful discussion here, and I move across audience for any questions, queries, or clarification if you want to put forward. Thank you for the patient listening.
Any questions from the audience? So I think, thanks so much.
Only thing that whether we can stop bromocriptine or cabergoline in a microadenoma where there's a complete remission, with a minimal dose after 2 years, definitely there are chances of stopping the medication and reassessing the patient. So it is not like that in a microadenoma they must be taking the bromocriptine or cabergoline for lifelong. We can definitely reassess these patients, and henceforth, so that we can also stop the medicine, and if the minimal dose that is for 2 years, then we can definitely stop the medication.
Thank you, sir, for the
Thanks, Dr. Felix and the panelists for excellent discussion. May I request Dr. Sriram, sir, to come on dais to give the mementos and certificates to Dr. Felix and the panelists. Dr. P.G. Sundaraman, sir. Dr. Felix. Dr. Adeline. Dr. Anand Kumar. And Dr. Sendil Raja. So moving on. So thanks so much, Felix and the panelists for the excellent presentation and discussion. Moving on to the next symposia. So can I ask the chairpersons to come on stage, Dr. Jyoti, Madam, and Dr. Kalpana, Madam.
So sorry, so can I request Dr. Jyoti and Dr. Anandi, professors of obstetrics and gynecology, to chair the session?
Good morning to all. First of all, I wish to thank the organizers for giving us this opportunity to chair this session. The first topic is on PCOS. The PCOS is an endocrine disorder. It affects all the women. Of course, 30% of the women in reproductive age group, causing menstrual irregularities, difficulty in conception, hirsutism, and more. It is also complicated with some metabolic abnormalities like glucose intolerance, obesity, and whatnot. So the treatment for this one is still suboptimal. So regarding the drug therapy, I welcome Dr. Jayashree Gopal from Chennai, and she is MBBS diplomat of the American Board of Internal Medicine, Endocrinology and Diabetes. Her present designation is Director, Diabetic Endocrinology of India, Associate Dean for Teaching and Research, MVDRC, Chennai. And she is having excellent achievements, Vocational Excellence Award, Rotary Club, Dr. Sam GP Moses Oration Award, API Chennai chapter. She had published many research papers, and her, particularly this one, altered kinetics of circulating progenitor cells in cardiopulmonary bypass associated vasoplegic patients. This is a pilot study. I welcome you, ma'am.
Good morning, everyone, and thanks to the organizers. So today my topic is what is actually the evidence for the medications that we use in PCOS, and there have been a lot of meta-analysis performed, particularly with use of metformin. So I'll be focusing on some of the larger meta-analysis mainly when I put together this presentation. So at the very core, I think like the chairperson said in the beginning, the PCOS is still a little bit of a mystery. We know some of the things that occur in the pathogenesis, which is an imbalance in the hypothalamic pituitary ovarian signals, which causes a excess ovarian and adrenal androgen production. There is always an additional burden of insulin resistance. So as endocrinologists, we tend to look at the insulin resistance. There is also some lipotoxicity. Definitely there is a lot of oxidative stress because of the excess adiposity. It can be caused by a combination of genetic, environmental, and epigenetic factors, and it leads to not only reproductive but metabolic and psychological consequences also. And depending on what we are trying to treat, so whether we are dealing with just irregular periods or hirsutism, or whether we are looking at infertility treatment, or later down the line, whether they are coming to us with diabetes, I think the implications and prognostication of PCOS is becoming more important. In elderly, then we are starting to think about increased risk of cardiovascular disease and certain malignancies. There are different phenotypes in PCOS, And I just wanted to put this up to say that currently I think in India the most common phenotype that we see is probably phenotype D, which is a combination of ovulatory dysfunction with a polycystic ovarian morphology and ultrasound. We generally do not tend to see excess androgen levels, at least most often in the Indian phenotype. Maybe the clinical androgen excess, but we do not generally see the biochemical androgen excess. So when we come back to what are we exactly trying to treat, I think that determines what type of therapy we're going to do. Are we just trying to regularize the menstrual cycles? If it's for pregnancy, then we need to make sure that they're ovulatory menstrual cycles. If it's not for pregnancy, then it doesn't really matter. We can just do like a withdrawal bleed or contraceptive type bleed. Are we trying to treat skin manifestations, hirsutism, acne, or the frontal thinning of hair? Are we trying to deal with the metabolic consequences, not only the dysglycemia, but also obesity, dyslipidemia, hypertension, fatty liver, sleep apnea? These are all some of the things we need to be assessing for and treating. And there is also a significant emotional component in PCOS, which we sometimes tend to miss or we do not address generally, particularly depression and anxiety, which is being sort of looked at more commonly nowadays. These are the medications that are used commonly, and I'll talk a little bit in more detail mainly about the metformin among the insulin sensitizers, and among the anti-androgens more about the estrogen, progesterone, or anti-androgen combinations, and what is the data regarding the couple of ovulation induction medications we use, which is clomiphene and letrozole, and I've sort of classified steroids under others. I will not be talking about the therapies with really not very well proven indications like inositol and other supplements. So this is what I looked at when we looked at the medications. What is it primarily used for? And what is the effect on reproductive outcomes? What is the effect on metabolic parameters? So for example, when we are looking at oral contraceptives, our concern is what is the effect on BMI and metabolic parameters. And when you look at metformin, what is the effect on reproductive outcomes? So I was just trying to see what is the effect on each other's sort of outcomes, and if there has been any significant impact on psychological parameters, and there isn't really much data regarding this, and I'll touch upon it as we go through the talks. So if you look at metformin, currently it is used mainly for the insulin resistance parameters, so for pre-diabetes, diabetes, for reduction of, for example, acanthosis, and of course for weight reduction, though its sort of utility in weight reduction in the absence of diet and exercise is very, very modest at best. We also use it for its effect on regularizing the menstrual cycles and also to improve ovulation and pregnancy. So if you look at the data regarding the metformin versus various other modifications that we use, various parameters, what is the evidence regarding metformin versus lifestyle modification alone, contraceptive use alone, ovulation induction versus clomiphene or letrozole, other weight loss medications, which I'll touch upon, and other insulin sensitizers. If you look at the evidence regarding metformin versus lifestyle modification, there was a good sort of systematic review and meta-analysis which was published just a couple of years ago. So what is the effect of lifestyle modification alone in PCOS compared to metformin alone or addition of metformin? And this was the result of all the various studies put together. And I think the most important takeaway message from me from this meta-analysis was that lifestyle modification alone was good at regularizing cycles in up to 2/3 of patients. Metformin alone or with lifestyle modification also improved menstrual cycles in about 50 to 60%, so similar numbers. Weight reduction tended to be the best with diet. Metformin may help to a modest degree. Metformin addition probably causes about a 2 to 3 kilo weight reduction. And diet actually promoted weight reduction much better. So dietary manipulations are very important for weight reduction. Just adding metformin is not going to cause weight reduction unless we also add dietary modification. And there was a suggestion that diet alone may be better than diet with exercise for weight reduction. So I just put this because sometimes, particularly young girls, they get very frustrated, because they're pushing the exercise and they're not losing weight. And, there are many reasons for that. But there was a suggestion that diet actually works better as compared to intensive exercise for weight reduction. But certainly metformin alone is not going to be helpful. And most of these studies define lifestyle modification exercise component as a 150 minutes of aerobic activity per week. And the dietary restriction was reducing the caloric intake to 1,200 to 1,400 calories per day, or a 500 kilocalorie reduction from their baseline. So this was the definition of dietary or lifestyle modifications. What is the evidence of regarding metformin versus CC or letrozole for ovulation induction? Again, this was a good Cochrane review done about 2 to 3 years back. And as compared to placebo, yes, metformin does better. If you don't give any treatment or you give a placebo, metformin fares better. But if you compare it with clomiphene citrate alone, then metformin does not do as well. So obviously clomiphene citrate does better. I think the most important take home from that meta-analysis is that obese women do worse with any form of ovulation induction. Metformin is less effective than or as effective as clomiphene citrate, depending on the parameter. So it doesn't really, if you actually look at the meta-analysis, it is not very effective in terms of ovulation induction by itself. When you combine it with clomiphene citrate, it improves ovulation and pregnancy rate. But interestingly, the meta-analysis did not show any change in miscarriage rate. Though we all have a perception that metformin may reduce the chances of miscarriage, the meta-analysis did not show any difference. All of the study consistently show that up to a third of people have significant GI side effects with metformin, whether it is versus just the CC or in addition to CC. So this is something we need to keep in mind, because I think it impacts upon the sort of compliance with the medication. So if they are going to have significant GI side effects, they do not tend to persist with taking the metformin. Letrozole, I think, is what is being used commonly nowadays. This was again a recent meta-analysis which showed that letrozole actually does better than clomiphene citrate. So though all of the meta-analysis comparing metformin is more the older studies which have compared it with clomiphene, we don't have a large number of studies, but overall I think currently letrozole does better as compared to clomiphene citrate. So probability of ovulation was higher in letrozole as compared to CC cycles, and we do not know whether addition of metformin in a letrozole group does better, like we have the data regarding addition of metformin to clomiphene. We don't yet have the data. How about the use of metformin versus oral contraceptives with respect to skin manifestation? So this is where we would be looking at how does metformin help, for example, with hirsutism. So metformin may perform as well as contraceptive tablets in reducing hirsutism. There is some difference in effect depending upon the BMI, and the data is all over the place. I'm not going into great detail, but definitely metformin tends to have more GI side effects. Usage of OCPs with metformin may actually help to reduce GI side effects, an interesting correlation of or fallout of the meta-analysis which have been done. I think the reverse question was more important for me. What about the effect of oral contraceptives? Does it affect the BMI? And actually the newer oral contraceptives does not increase the BMI or does not lead to much difference in the metabolic parameters. And metformin, again, in the absence of diet, does not really do a whole lot in reducing weight. This was an older study. This is almost like, 15 years old. And what this showed was that metformin versus OCPs both seem to do well in terms of reducing hirsutism. In terms of acne, the oral contraceptive type tablets in this particular case were not the oral contraceptives, but the combination of ethinyl estradiol with the supraterone acetate. It did better with respect to acne improvement. Obviously, the estrogen-containing medicines do better in improving the menstrual pattern and in terms of reducing testosterone levels, whereas metformin will do better in terms of the other metabolic parameters like fasting insulin or glucose or cholesterol or triglycerides. So depending on which parameter we look at, obviously the medication that is used for that did better. But just to point out that in terms of hirsutism reduction, probably there is no big difference between the two if we are trying to decide what it is. But if you're looking at acne, then probably the contraceptive type tablets would do better. There is no long-term data as yet on its effects in reducing risk of cardiovascular disease or malignancies in the long term. And again, another sort of question that is often in our minds is which contraceptive tablet, which sort of combination of estrogen, progesterone, or estrogen and anti-androgen would we like to use? Again, I think it really comes down to as a personal preference. Each one of us has sort of a personal preference and we think that it works well, and ease of use and what the patient tolerates. So certain sort of progesterones patients do not tolerate because of nausea. The ethinyl estradiol and cyproterone combination may work better at a younger age, and certainly the younger girls seem to find it more preferable in terms of reduction of hirsutism. But we need to keep in mind that it is not approved as a contraceptive in our country, so we cannot use this as a contraceptive, though it does have a contraceptive effect, of course. So these are all some things we need to keep in mind. This was actually a very recent meta-analysis, again published a few months back, which was a network meta-analysis. And this is some very, very complicated statistical manipulation that was done. But basically, the conclusion of this particular meta-analysis was that flutamide actually did better both in metabolic and hormonal parameters. We generally do not use flutamide in our country. I've seen very, very few doctors using it because of a very high incidence of hepatotoxicity, but it seems to do well in improving both metabolic and hormonal parameters. And the cyproterone and ethinyl estradiol combination type of combination did better in improving hormonal parameters. What about metformin versus other weight loss medications? There was a very, very few studies comparing metformin with orlistat, and again, because of the heterogeneity, I don't think we can really compare. I think some physicians still like to use orlistat, but it showed, some of the studies showed more weight loss with orlistat, 2 showed no difference. All of them showed a significant drop in testosterone and rise in SHBG. So any which way we can get them to lose weight, there will be an improvement in the androgen levels and definitely an improvement in the metabolic parameters. And this was the dosage of the orlistat, 120 mg twice a day or 3 times a day, and metformin dose ranged from 1 gram to 2 grams per day. What about other insulin sensitizers like pioglitazone particularly? No recent analysis. The only one that I could come up with, a meta-analysis, was about 10 years back. And what that showed was that thiazolidinediones are better than placebo, definitely for improving markers of insulin resistance. But by itself, the TZD does not reduce the FG score or androgen levels compared to placebo. Again, this is in contrast to metformin, which does help to reduce hirsutism. And of course, we are all aware that by itself, TZDs may cause some weight gain. But one interesting point that I found in that meta-analysis was that the studies which looked at a combination of pioglitazone with a contraceptive type tablets or anti-androgens, the extent of weight gain was not that much. For some reason, it seemed to retard the weight gain. So just one little takeaway, if at all we are going to consider using pioglitazone because metformin is not tolerated or because they have significant insulin resistance, sometimes we have to consider using it. We can consider using it with some other anti-androgenic measure to limit the amount of weight gain. If you compare metformin versus thiazolidinedione, again, an older meta-analysis, more than about 10-12 years back, I would say there is no really difference between the two groups with respect to the ovulation rates, pregnancy rates. However, thiazolidinediones tend to be better tolerated with lesser GI side effects. I think that's the only sort of takeaway. Again, very uncommonly do we use it. I know some centers use it mainly for ovulation induction with good effects. What about newer anti-diabetes medications in PCOS? Very, very limited data, not really, no meta-analysis, no proven studies. SGLT2 inhibitors currently only approved as an anti-diabetes patient. In small studies done in PCOS with IFG or IGT, it shows only a very neutral effect. It doesn't really cause much by way of weight reduction in this group of pre-diabetes patients. GLP-1RA, again, it is approved for management for diabetes, but liraglutide at a dosage of 3 mg is approved for weight reduction even in the absence of diabetes, and definitely helpful in reducing weight and improving metabolic parameters when used along with metformin in PCOS. Again, small studies, and I think its cost and gastrointestinal tolerability will limit its use, but certainly it definitely has a place in people who are finding it very difficult to lose weight with just diet and exercise alone. One other question that I was interested in looking at was, how do the contraceptive tablets, quite often when we put young girls on contraceptive tablets, they complain a lot about both tolerability issue, and they have a lot of mood disturbances. But in terms of, I think one thing we can take away is contraceptive tablets do not affect the metabolic parameters too much. So they don't They don't affect the lipid profile, they don't affect the weight or the insulin resistance. So we don't need to worry. For example, we see somebody with diabetes or dyslipidemia, unless they have very high triglycerides, that's the only group in which we have to be careful about using estrogen. Apart from that, we don't need to worry about using the contraceptive tablets in terms of worsening metabolic control. Very quickly about the other anti-androgens that we use. Spironolactone, again, no large-scale trials. However, when combined with a COC, definitely better reduction in hirsutism and androgen levels. Very, very short-term trials. Most of these studies have only been done for a year, maximum maybe 18 months. When used alone, without contraceptive tablet, up to 1/3 experience troublesome intermenstrual spotting. So always in our country, when we use spironolactone, it has to be combined with some sort of a regular withdrawal bleed, preferably a contraceptive tablet. Because no matter what we say, women on spironolactone sometimes do get pregnant, and that becomes an issue. Similarly with finasteride. Finasteride is a competitive inhibitor of the type 2 5-alpha reductase, which converts the testosterone to dihydrotestosterone inside the cell. So one thing we need to keep in mind when we put finasteride is that the testosterone and estradiol levels will tend to rise by 15% compared to the baseline, but they still remain within the normal range while the DHT levels will fall. But there won't be any effect on LH-FSH. Finasteride does not affect metabolic parameters. It may improve hirsutism. Dermatologists generally tend to use it for male pattern androgenic alopecia or frontal hair thinning, and it may help to some extent. However, some of the side effects are breast tenderness, reduction in libido, skin dryness, so higher doses may limit its effect. It's relatively contraindicated because in pregnancy, it's pregnancy category X. Male fetuses develop hypospadias, female fetuses remain normal. One thing we need to keep in mind is that once you stop the finasteride, the effect of the medication on inhibiting the enzyme complex takes about 2 weeks to reverse. So ideally, I would say stop the medication at least 2 months or 3 months before they are even planning pregnancy. And again, it cannot be used by lactating mothers, particularly if the offspring is male. And there was some suggestion that it may also increase the risk of breast cancer if there is a strong family history. This, I'm just putting it up because in case we are trying to think about using it long term, these are all some of the things we need to keep in mind before we consider long-term use of finasteride in women. So let me just go through. Dexamethasone, I find it helpful in reducing hirsutism if there is adrenal hyperandrogenism. It also helps in thinning of hair. It makes the hair thicker. It helps to regularize the cycles. Very, very minimal doses can be helpful. No large-scale studies have been done. We can get away with using like 0.125 or 0.25 mg per day. It's got a very long half-life, so using it even once in 24 to 48 hours also gives a good effect. And when used at minimal doses, really no impact on weight gain or blood sugars. Very helpful, particularly when there is adrenal hyperandrogenism, if the regular anti-androgens do not help. So the treatment options for hirsutism, as you can see, are very varied. Depending on what it is we are trying to treat, we have various options available. If you're just trying to restore the periodic menstrual cyclicity, we can use either progesterone withdrawal or contraceptive or ethinyl estradiol or cyproterone or ethinyl estradiol and drospirenone combination. We can consider using insulin sensitizers alone, but they would be a second choice. When we are looking at reducing androgen excess, particularly with respect to its effect on hirsutism and acne, first choice always remains anti-androgens. Finasteride can be used, spironolactone can be used, flutamide generally we do not use. Insulin sensitizers, metformin has been shown to reduce hirsutism. Improving insulin sensitivity, very definitely insulin sensitizers help. Anti-androgens do not hurt, they do not make it worse. Ovulation induction, the shift is towards using letrozole in general, combined with insulin sensitizers, particularly if there is pre-diabetes. So finally, the treatment of PCOS is personalized, and I think it depends on the most pressing issue that the woman has at that point. Lifestyle modification, good diet and exercise always necessary, and no one medicine is a cure for PCOS. Thank you.
It was an excellent talk. You almost covered everything. Thank you. Thank you.
Thank you, madam. Thank you very much for your insight view on the drugs which can endocrinologist in male infertility. Today we are pleased to welcome Dr. Anjali Satya, a very special guest from Chennai. Anjali Satya, she is a MD DNB. Present designation is Consultant Endocrinologist, Vijaya Group of Hospitals, Apollo Specialty Hospital, Vanagaram. Her interest is on diabetes, thyroid disorders, reproductive endocrinology, achievements in clinical practice for more than 15 years, and many publications in the national and international papers. And today she will be sharing with us her expert opinion on male infertility as an endocrinologist. We know the sperm is the most brilliant cell in the body because it has to leave the male partner, enter into the female partner genital tract, where it has to survive the hostile environment, hopefully reaching the ovary and fertilizing to form a baby. So as an endocrinologist, how madam is going to help us to improve the count and motility we can see. Over to you, madam.
Thank you, chairpersons. At the outset, let me thank my Trendo team for inviting me here. It's a great opportunity and honor to be on this platform and to present this topic on male infertility and what is the role of an endocrinologist in male infertility. So this is the male reproductive system. The spermatogenesis occurs in the testis, and then the sperms go to epididymis where they undergo maturation, and the sperms acquire motility and fertilizing capacity in the epididymis. So they spend some time there. Finally, the sperms are transported via the vas deferens and they go on to the ejaculatory duct. So let us familiarize with the hypothalamo-pituitary testicular axis. The GnRH neurons secrete GnRH from the hypothalamus, which acts on the anterior pituitary gland that secretes the gonadotropins. The FSH acts via FSH receptor onto the Sertoli cells and initiates spermatogenesis. The LH hormone, the luteinizing hormone, it acts via the LH receptor, works on the Leydig cells and leads to testosterone production from androstenedione. Now, as in any endocrine axis, the target organs and the hormones secreted exert a negative feedback both on the pituitary and the hypothalamus. So when we look at infertility as a problem, almost 1 in 6 or 7 couples face this. 40 to 50% could be attributed to the woman, and 30 to 40% can be attributed to male factors, and about 10 to 11% could be combined. Both men and female may contribute to the fertility issues, and there is a significant number with unexplained infertility. Now, what do we define infertility as? Infertility is usually defined as the inability to conceive in spite of 1 year of unprotected sex. And this duration is reduced to 6 months if the woman is older than 35 years. So if the wife is older, you don't wait for 1 year. You can start evaluating even much earlier. Now, what are the 3 basic elements of male fertility? One is the ability to produce normal sperms in the testis. And that would depend on the presence of normal germ cells. It would also depend on intact Leydig cell and intact Sertoli cell function. The Leydig cell secretes testosterone that leads to high testosterone level within the testis. It's almost 100 times more than the serum levels of testosterone. And this high intratesticular testosterone is required for normal spermatogenesis. FSH, the Sertoli cells acts as a nourishing cell. It gives the correct milieu for spermatogenesis. So you need normal LH-FSH or normal hormonal stimulation for an intact spermatogenesis. And the third important factor is, after spermatogenesis is over, you need a patent functional transportation system from the testis to the ejaculatory duct. So if you have a pathology there, again, infertility. So an infertile man with an abnormal semen analysis will have these reports. So I'm just familiarizing with the terms. Oligospermia is a low number of sperm cells in the ejaculate. Azoospermia is absence of sperms. And whenever we document azoospermia, it is important to repeat one more sample within few weeks, not months later, because the spermatogenesis cycle is about roughly 2 months. Asthenozoospermia is where you have abnormal sperm motility, and teratozoospermia is where you have abnormal morphology in sperms. So you may come across these terms in semen analysis reports. Some infertile men have normal sperm counts. Now I've put up this table to basically say where the role of endocrinologist comes. So we can divide these causes of male infertility as pre-testicular causes, which would be essentially the signals coming from the hypothalamus and pituitary. So any pathology there is dealt with by an endocrinologist. The testicular causes would include varicocele, genetic factors, cryptorchidism, and exposure to gonadotoxins. This would also involve chemotherapy and radiotherapy-induced damage. Post-testicular is pathology that is involved in the transportation system, in the obstruction in the duct, vas deferens, or absence of vas deferens, or ejaculatory duct obstruction. And disorders of ejaculation and erectile dysfunction also comes in this category. So the role of an endocrinologist is mainly in the pre-testicular causes and also in erectile dysfunction and some disorders of ejaculation. So let me go in detail. The pre-testicular causes, mainly what I would discuss is the hypogonadotrophic hypogonadism. This could be congenital, as in Kallmann syndrome, where there is congenital GnRH deficiency, iron overload syndromes. This is one very important cause for hypogonadotrophic hypogonadism. This could be following recurrent transfusions or hemochromatosis. Multiple genetic syndromes like Prader-Willi, Lawrence-Moon Beadle, all these syndromes are associated with congenital hypogonadotrophic hypogonadism. Acquired disorders would involve tumors. It could be infiltrative disorders. It could be a trauma. It could be a hypophysitis. It could be vascular causes like pituitary infarction or aneurysm, or hormonal. We had a very extensive session on hyperprolactinemia, and hyperprolactinemia is one very important cause for secondary hypogonadism. Drugs, very, very important. We need to take a very detailed history to elicit this. And systemic disorders like severe systemic illness. That is why we say that we should never evaluate a very sick person for sex hormone levels, because that's a time when the GnRH is suppressed. Nutritional deficiencies and morbid obesity. Primary testicular defects, we do not have much role. In Klinefelter syndrome, which is the commonest congenital cause for hypogonadism, cryptorchidism, myotonic dystrophy, you can have androgen insensitivity syndromes, 5-alpha reductase deficiency, and estrogen receptor or synthesis disorders, where the scope for medical treatment is not very great. Other acquired causes can be varicocele, infections, drugs again. The importance here in drug-induced testicular injuries that before we administer chemo or radiation, there is a scope for fertility preservation. I'll come to that later. Immunologic disorders, trauma, or testicular torsion. I would also like to stress on systemic illness. Somebody who is very sick or who has systemic disease like renal failure, chronic liver disease, sickle cell anemia, vasculitis, celiac disease, all these can be associated with suppressed spermatogenesis. Genetic causes of spermatogenesis, again, have to be evaluated in any man with infertility, especially Y chromosome microdeletions and related disorders, and some mutations can cause severe defects in even sperm morphology. Transport disorders, you can encounter either absence of vascular vas deferens or epididymal dysfunction, or you can have ejaculatory duct obstruction. Sexual dysfunction is a very common etiology in regular practice. Many men, they do not report erectile dysfunction until they come to the fertility clinic. Till that time, they sort of, they go through it and they don't take treatment for the same. And that can be a very major cause for infertility. Infrequent sex, erectile dysfunction, and premature ejaculation. And certain factors are still unknown. So that is classified as idiopathic. So the essential components of evaluation of an infertile man would be a good history, physical examination, and the most important thing is a semen analysis. The additional components would involve endocrine testing in a select group of cases, imaging of the accessory glands and ducts, which would include a transrectal ultrasound for ejaculatory duct visualization, or a plain ultrasound scrotum for scrotal and vasculature of the testis. Genetic testing is mainly to rule out Y chromosome microdeletions. Now, how do we triage and refer to an endocrinologist? History itself may give us some clue. Especially we need to look at the sexual developmental history, whether they have had cryptok, is it undescended testis as a child, whether they had undergone a surgery for the same, delayed puberty, loss of body hair, or decrease in shaving frequency. The clinical manifestations of androgen deficiency depends on the age of onset. So if you're dealing it in early childhood or infancy, it would present as ambiguous genitalia, or in late gestation as micropenis. In childhood, it is present as delayed puberty. In adulthood, as decreased sexual function, poor libido, infertility, and loss of secondary sex characters. Physical examination, one must look at the skin. Sometimes that may give us a clue. So a man who comes with, say, generalized hyperpigmentation, it may be an underlying clue for an iron overload syndrome like hemochromatosis, which can cause hypopituitarism. They can have thin bruising skin, and if they have Cushingoid features, we must evaluate them for Cushing syndrome, which again is a cause for secondary hypogonadism. Loss of pubic, axillary, facial hair, decreased oiliness of the skin, fine facial wrinkling could suggest a long-standing androgen deficiency. Now, most of this time, what we find is many men with androgen deficiency do not report to physicians. They come only at the time of fertility evaluation. External genitalia examination is a very important aspect of physical examination, where one needs to examine the phallus size, the testicular volume. We use a Prader orchidometer for the same. In an adult man, if you have a testicular volume less than 15 ml, or a testicular length measured on the longest axis less than 3.5 is considered small. So let us familiarize with the basic semen analysis parameters. The patient is asked to masturbate in the clinic, or even a home collection is fine, but it should be analyzed within 1 hour. So it should not be transported to a laboratory that takes a longer period of time, which may sort of cause a lot of gross changes in the results. So you look at the semen volume and pH. A low volume and a low pH, acidic pH, may actually indicate obstructive cause. Microscopy for sperm concentration, count, motility, morphology. One also looks at the agglutination. Agglutination may actually give a clue to presence of sperm antibodies. Leukocyte count, which is suggestive of infection, or immature germ cells. So these are the lower limits of normal. So if you have a volume less than 1.5 ml, abnormal. Sperm concentration less than 15 is considered very, very low. Total sperm numbers, 39 million. The bracket mentions the confidence intervals. Morphology, at least 4% should be normal forms. They should be motile. Motility should be at least 40%, 50%, and progressive motility to at least 32%. And the total progressive and non-progressive motility put together should be at least 40% in a sample. Endocrine testing is usually offered to men who have very, very low counts, less than 10 million, or severe SOT. It's called severe oligoasthenozoospermia. In those individuals, we have to ask for a fasting total testosterone levels, FSH, LH, prolactin, and others as indicated depending on what we are suspecting after a clinical examination. Now, total testosterone should be always tested in a fasting sample, and if we document a value less than 3, it's considered abnormal, but we should always repeat a second sample for testosterone before declaring that individual to have testosterone deficiency, which can be collected a week or 2 apart. If you have low testosterone and high gonadotropins, high FSH and LH, which means that the testis is not responding. This is what we see classically in a primary hypergonadotrophic hypogonadism. And here we think of the commonest cause, which is a genetic cause, Klinefelters, or it could be also due to a testicular injury. So here we have to ask for karyotype, especially when we see low testosterone and high FSH and LH. If we find normal testosterone and normal LH with only high FSH, it is suggestive of primary hypergonadotrophic hypogonadism, but without Leydig cell dysfunction. Here we have a normal LH, that means the Leydig cell function is normal. If we find a low testosterone but FSH and LH not elevated, if they are normal or low, this is what we classically see in hypogonadotrophic hypogonadism. We should think of hypothalamic or pituitary cause for hypogonadism. And we always look for secondary causes, and hyperprolactemia is a very common cause for secondary hypogonadism. We should also assess them for their thyroid functions, do the other anterior pituitary functions. If prolactin is elevated, we also ask for cortisol, and do a cellular imaging. Cellular imaging is offered to all men with documented hypogonadotrophic hypogonadism to rule out tumors or empty cella, etc. If you have a high testosterone and LH but normal FSH, this could mean that the individual may have a partial androgen resistance. If you have all parameters normal but the man is infertile, then a further decision would depend on the semen analysis findings. And if azoospermia is present, we have to classify them either do they have obstructive azoospermia or a non-obstructive azoospermia. So let us go through some case scenarios which will throw more light on an endocrinologist's role or where we cannot offer them help. So I thought I would present both the cases scenarios. The first case is a 30-year-old man who comes with severe headaches and was on analgesics for same, married for 1 year. He has had erectile dysfunction but has not consulted any doctor. He has been experiencing weight gain, severe fatigue, and always felt less energetic. He was asked to do imaging because he had headaches, and the MRI brain revealed a cellular mass. Now, retrospectively, after finding that he had an cellular mass, the hormone evaluation was done. On examination, he was obese, reduced facial and body hair, he had no gynecomastia, and external genitalia examination showed a normal penile length, testes were normally positioned, normal consistency and normal size. There were no evident abnormalities of the epididymis or the vas difference. On evaluation, he was found to have anemia, hemoglobin of 11 grams. His free T4 was low, 0.6, and TSH was 2. His cortisol was also low, and prolactin was more than 200. Now, we had, in the first discussion, I think they had spoken about high-dose hook effect. Whenever we see a very high prolactin level, we think of about 200, we have to think of tumoral cause for hyperprolactinemia, and in dilution, the titers were found to be 3,300. Testosterone was suppressed because of the hyperprolactinemia, because high prolactin suppresses the GnRH hormone secretion, and that leads to secondary hypogonadism. This slide, previous slides. Next slide. Yeah, this slide. So I'll go on with the presentation. So this individual had a high prolactin and he had a low testosterone. And when we checked the FSH and LH, they were also found to be suppressed. The FSH was 2 and LH was only 1.8. The semen analysis revealed azoospermia. So here we have a young man who had erectile dysfunction for a very long time. Because of his headaches, went for an MRI imaging, found a cellular mass. Retrospectively, he was diagnosed to have a macroprolactinoma. The MRI showed the following findings. So I think I'll just display the image. So this individual was diagnosed to have macroprolactinoma and he was started on cabergoline. Now we do not know how long this macroprolactinoma was sitting. So cabergoline was initiated and after 6 weeks his prolactin dropped down to almost like 30 nanogram per ml, but his testosterone remained suppressed. So in this individual, cabergoline therapy alone is not going to restore his fertility because we do not know how long was the duration of the macroprolactinoma. So the MRI shows a macroprolactinoma. He was offered cabergoline therapy. The prolactin levels dropped to 30 within about 6 weeks' time. So the values crashed from 3,000. That's the kind of response we see with cabergoline. And sometimes these patients, due to rapid shrinkage of the tumor, sometimes can develop CSF rhinorrhea, which was discussed in the morning. Now, this individual had resolution in prolactin levels, but the repeat MRI after 2 months did not show much decrease in size. And he also had visual field defects on visual field charting, and hence he was offered surgery. After surgery, he was started on full hormone replacement therapy, both thyroxine, hydrocortisone. He was put on injection Hcg 5,000 units twice a week. This was added to stimulate spermatogenesis. He was married only for 1 year, and this was important because cabergoline therapy alone here will not restore spermatogenesis, so he was started on gonadotropin therapy also. The second case is an 18-year-old young man who was recently diagnosed to have Klinefelter syndrome. He had 4 ml testis bilaterally, and the karyotype revealed 47XXY. He had eunuchoid body proportions on clinical examination, where the arm span is greater than the height. He had gynecomastia, but he had mild facial hair, axillary and pubic hair. His testosterone was on the lower limit of normal, 3.06. LH was elevated and FSH was elevated. So this shows that this individual had hypergonadotrophic hypogonadism, and they wanted to mainly discuss his fertility potential. Now, what is notable is his testis is only 4 ml, and in Klinefelter syndrome, the small testis usually undergoes hyalization, and the retrieval of sperms can become very difficult. So small testis and azoospermia is seen in more than 95% of patients with XXY, and only in certain select cases, especially Klinefelter mosaic, where you have both XY and XXY, there is a chance that they may have sperms in the semen, and there is a scope for microtessa, or microdissection of testicular sperm extraction, and ICSI can be offered. The fear for aneuploidy in the infant is not there, because only those germ cells will produce sperms which are euploid in this mosaic scenario. So microtessa can be offered in a select scenario. This may not be useful if testicular volumes are low. So here the parents had to be counseled, and he was put on testosterone replacement. The third case is a 35-year-old pharmacist who was referred from a fertility clinic. He already had a 10-year-old son, but no children from second marriage. He reports decreasing libido, decreasing energy levels, and found to have low testosterone levels. He also used to do regular workouts at gym, and he has been having mild arthralgias. Other than that, he never had any other systemic complaints. He denies taking alcohol, anabolic steroids, or other drugs. On examination, he was a muscular man with normal secondary sexual characters, BMI of 24, not Cushingoid, skin was normal. Genitourinary examination revealed a testis of 15 ml, otherwise there was no other remarkable features. Biochemistry showed low testosterone, 1.5, prolactin was normal, thyroid functions were normal, gonadotropins were on the lower side, 3 IU, both for FSH and LH. Cellular MRI did not reveal any cellular mass lesion. Because of the arthralgias, X-ray hands were asked for, and that showed chondrocalcinosis, which is seen in this image, basically calcification of the chondrocartilage, which is seen along the edges of the bones, and this is classically seen in hemochromatosis. This individual had his ferritin checked, it was found to be more than 1,000. So he had not had a skin manifestation. Normally in hemochromatosis, these people can come with diffuse hyperpigmentation, which can be a clinching factor for diagnosing hemochromatosis or iron overload state. But he had chondrocalcinosis, which is very important, especially in a younger man. You see chondrocalcinosis, you have to think of hemochromatosis. So final diagnosis was a hereditary hemochromatosis with hypogonadotropic hypogonadism. Even other hormone axes can be involved in hemochromatosis. They can also present later with diabetes or liver damage. But this individual had presented early, so his other organs were relatively normal. Fourth case is, again, a 27-year-old married for 1.5 years. He came with his wife, reported erectile dysfunction. This had affected their marital relationship. He had occasional headaches, gained more than 10 kilos in last 2 years, led a sedentary lifestyle. He was an IT professional. BMI was in obesity range. He had strong family history of autoimmune thyroid disease. Both his mother and sister had thyroid problems. Otherwise, he had no specific complaints. On lab investigation, he was found to have anemia with a high MCV. The red blood cells are usually large in hypothyroidism. Sugars were in the impaired fasting range. Lipids revealed a mixed dyslipidemia, showing high total cholesterol of 245 and even high triglycerides of 350 and low HDL, which is classically seen in sedentary individuals. TSH was asked for because he had a strong family history of autoimmune thyroid disease, and also he reported erectile dysfunction. So men with erectile dysfunction, we should evaluate them for thyroid function and prolactin. That is what I want to, as this is the carry-home message from this slide. The TSH was found to be more than 150 and free T4 was low. Prolactin was also found to be elevated, but here we consider it to be a secondary hyperprolactinemia, which is encountered in severe hypothyroidism. But if you notice, the prolactin is elevated to a moderate degree. He got his MRI done because he has been having headaches also, and the MRI revealed a cellular mass. So here we have a young individual with severe hypothyroidism, has moderate degree of prolactin elevation, and MRI shows a cellular mass. But here we have to be careful because severe hypothyroidism, when TSH, when T3, T4 are very low in the blood, as I said, there will be an elevation in TSH as well as TRH. So there is thyrotrope hyperplasia, and the pituitary undergoes enlargement because of the thyrotrope hyperplasia. Once we treat this individual with thyroxine, this cellular mass can actually reduce in size. So here we should not offer surgery. So this is known as a pituitary pseudotumor, which is commonly seen in people with severe hypothyroidism. I just wanted to discuss this slide for, he also had erectile dysfunction. The commonest cause for erectile dysfunction is stress and psychogenic. The endocrine causes are hypogonadism of any cause, low testosterone, diabetes mellitus, hyperprolactinemia, and hypothyroidism. So that is where our role is. And this is how we treat. The treatment of erectile dysfunction, we have to assess and modify the lifestyle risk factors, especially sedentary lifestyle. They should be advised to exercise and lose weight, avoid heat exposure. The hormone disorders I had already mentioned in the slides, and we have to counsel the patients and the partner. The medical therapy is limited to offering them phosphodiesterase E inhibitors, 5 inhibitors, especially sildenafil and tadalafil. Some of them get relief. Now, if a man comes with infertility and severe erectile dysfunction, offer them treatment for erectile dysfunction first, because that itself may cure his fertility issues. And if in spite of correcting erectile dysfunction, he does not achieve pregnancy, the couple do not achieve pregnancy, then we have to go further in further evaluation. So treat the erectile dysfunction first before treating the subsequent problems. The fifth case is a 35-year-old man evaluated for infertility. He had normal libido, erections, not on any medication or drugs. His wife has regular cycles, so normal people, but they were infertile. He had normal secondary sexual characters, no gynecomastia, testicular volume was normal. Labs revealed normal testosterone levels and normal gonadotropin levels. So here is a normal man who has come with infertility issues. Semen analysis showed a low volume and an acidic pH. It showed azoospermia. Azoospermia, as I mentioned earlier, should be confirmed on a repeat analysis. So the low volume and low pH indicate obstructive etiology here. And this patient on clinical examination was found to have bilateral absence of vas difference, which was confirmed on an ultrasound. And when we get bilateral absence of vas difference, which is congenital, we have to do genetic testing for the cystic fibrosis, transmembrane conductance gene, and other organs may also be involved in this case. But bilateral absence of vas difference is a very important cause for obstructive azoospermia. Now this table demonstrates various causes for non-obstructive azoospermia and obstructive azoospermia, and one endocrine test which can sort of help to differentiate the two is estimation of FSH. If FSH is normal and patient is azoospermic, we are dealing with obstructive in most cases. If FSH is elevated, we are dealing with testicular cause. Y chromosome microdeletion, again a very important cause for non-obstructive azoospermia, where the man may have low testicular size due to disruption of spermatogenesis, high FSH, and they can present, and there is a factor called azoospermia factor, which is localized on long arm of Y chromosome, and there are different subsections. AZF-A factor deletion leads to complete tubular atrophy, so low testicular volume. AZF-B leads to only Sertoli cell only syndrome. Leydig cells are lost. AZFC causes 80% of Y microdeletions. Here again, endocrinologists do not have a role to play. And the last case is a 32-year-old man with already diagnosed panhypopituitarism because he had a resection of non-functioning pituitary macroadenoma at the age of 28 years. He comes to the fertility clinic. He has been on testosterone replacement from the time of surgery. He's also on hydrocortisone and thyroxine. His wife has regular cycles. So here we know that it's a man who is on having hypogonadotrophic hypogonadism, but he's on testosterone replacement. On examination, his BMI was 30 and BP was normal, well androgenized because of the exogenous replacement therapy, and testis was 15 ml bilateral. Testosterone levels were fairly good, 4.4 nanogram per ml. Thyroid functions were normal, but the semen showed azoospermia. The diagnosis was post-pubertal acquired hypogonadotrophic hypogonadism, and the azoospermia here is because of the testosterone replacement therapy. So once someone is put on testosterone, it's like a contraceptive effect. The spermatogenesis is suppressed because of testosterone, and when such an individual desires fertility, we have to switch over from testosterone to gonadotropin therapy. So that is a message from this slide. In fact, any man who has hypogonadotrophic hypogonadism, if he is desiring fertility, never put them on testosterone, rather start them on Hcg therapy. Now, exogenous testosterone therapy suppresses the FSH and therefore spermatogenesis, but that is important to achieve high intratesticular testosterone levels. So once we stop the testosterone, we put them on Hcg, which is a long-acting LH analog. The dosage that we normally start off is 2,000 units, can be given sub-Q or IM thrice a week. And then we have to repeat the semen analysis of every 2 months and repeat the testosterone levels. If the testosterone levels are achieved between 4 to 8, the dosage can be maintained, or if it is not maintained between 4 to 8, then we step up the dose further to something like even 10,000 units per week. So monotherapy with LH may suffice for people who have acquired hypogonadotrophic hypogonadism because their testicular volumes are good. Testicular volume normal means seminiferous tubal compartment is intact. If they have very low testicular volume or lesser or lower testicular volume, we may have to add FSH in the beginning itself. So we have to add Hmg that is offered as starting dose is around 75 IU. That may not suffice thrice a week. We may have to step it up to 150 units thrice a week. So sometimes dual therapy is offered in men to get faster resolution of spermatogenesis. Once Hcg is started after switching over from testosterone, it takes roughly 6 to 9 months for spermatogenesis to happen. So we have to tell the patients that it will take time. Otherwise, when they are about to get married, I think the role of endocrinologist is to counsel them ahead of time. We start them on testosterone replacement when the diagnosis is made, and once they get married, we switch them over to Hcg. So it may take 6 months for spermatogenesis to resume, and if we give dual therapy with Hcg and Hmg, the results can be faster. So testicular size is a very important surrogate of fertility potential. Men with congenital hypogonadotrophic hypogonadism, like in Kallman syndrome, with lower testicular volumes, they need Hcg and Hmg from the beginning. But very low, less than 4, prognosis is very poor, and that should be explained to them, and fertility is not possible. To summarize, male factor as cause for infertility is very common in clinical practice. Role of endocrinologist is limited to evaluation of men with hypogonadotrophic hypogonadism, both primary and secondary. Secondary causes, we treat the underlying cause. Erectile dysfunction or some men with premature ejaculation. Medical therapy is successful in patients with hypogonadotrophic hypogonadism with reasonable testicular volumes. Those who have hypergonadotrophic hypogonadism, they have to go for a donor sperm program. People who are obese and have lifestyle issues, they have to be counseled for weight loss. Drug or substance abuse is a very important cause. So if they have history of alcohol intake, smoking, all that can affect fertility potential. They are important reversible causes for subfertility. One important thing which I want to highlight is fertility preservation, though it's beyond the scope of presentation, but people who are going to go for chemotherapy or they're undergoing radiation for lymphomas which are diagnosed early in life, we can offer them fertility preservation. Now we have people with gender dysphoria who are wanting to undergo hormone therapy for gender change. Even they have to be counseled for fertility preservation before, so their eggs or sperms can be cryopreserved before they undergo a permanent irreversible hormone therapy to So in transgenders also, I think that is a very important role to play. So endocrinologists have to counsel them ahead of time so that we achieve, we are able to preserve their fertility. With that, I conclude, and questions are welcome. Thank you.
Thank you, madam. Thank you very much for your expert opinion. We have had 2 topics from our distinguished expert persons. As we are already late, 1 or 2 questions from audience, please.
We can ask on the previous topic also, no? Dr. Jayashree, your comments on this myo-inositol thing. I don't know whether you mentioned it to me.
So I said in the beginning itself, I'm not going to address myo-inositol. So therapies which of limited benefit, but interestingly, I think one of the papers that was presented, there was a study done from Madurai Medical College. I think somebody presented a study where they were looking at, it's a small short-term study, and we have to see. In that, it seemed like the metformin with the myo-inositol, a proper placebo-controlled trial, in which, so all of these are very short studies, absolutely no meta-analysis. The way I look at myo-inositol is, it won't hurt, it may help. So if you want to use it, I don't think there is any, it doesn't cause any adverse effects.
Madam, what is the role of eflornithine in the treatment of hirsutism?
I know the skin doctors like to use it. I find it, I don't know, at least from patients who use it, they say as long as they are using it, there is some reduction. But I've not found it to be a permanent effect. So permanent reduction in hirsutism has to be achieved with laser plus medical therapy for a few months. But laser is the only permanent benefit. Eflornithine, once you stop, it will come back.
Excuse me, madam. Thanks for your informative lecture, madam. If I mention about pseudomass, pituitary mass, we have found out in so many patients that TSH, apart from elevated very high TSH level, differentiating points between the real tumor and pseudotumor clinically and investigation-wise. Because the patient, all the patients need not say other endocrine problems, because they will be coming only for thyroid problem or repeated examination. When they are on failure treatment or they are stopping treatment for few months or few years, when we are accidentally finding or repeating the thyroid level, it will be more than 150. Those time we are doing the CT that shows mass. How to differentiate clinical mass, as pseudomass problem, and also the real mass problem. If the patient asks the question, sir, you are saying that mass is there, then whether it's due to real TSH only elevation or due to some other problem, shall we wait for another 6 months or 3 months till the TSH has to come down? Please, ma'am.
Yeah, the message from the slide was, do not refer this patient to the neurosurgeon. The pituitary must be, normally do not image pituitary for a person with severe hypothyroidism. This individual had done his MRI brain because of his constant headaches that he had. He is an IT professional. I told you he also had erectile dysfunction. So he had come with his MRI. So he had severe hypothyroidism, and here, because of the severe hypothyroidism and TRH hyperplasia, or pituitary hyperplasia, because of the high TRH levels, the lesion will actually resolve. It will shrink. So here we should not rush to surgery. Treat the person with hypothyroidism and repeat an MRI later. In case of pseudotumor, the mass will vanish. If it is not a pseudotumor, it will remain so. So I think that's the way we differentiate.
Madam, one question for the practitioners. Whether you are ordering the genetic test for all the cases of azoospermia, ma'am?
Non-obstructive cases. But even in some obstructive cases, micro deletions have been documented. So any azoospermia, yes.
We have to go for genetic tests. And what is your opinion about the DNA fragmentation index?
Ma'am, I'm not a reproductive medicine specialist. I'm a general endocrinologist. But I think if there is a higher DNA fragmentation index, the fertility issue, then they have to go for donor sperm program.
So what is the dose when you are treating the hypogonadotrophic hypogonadism, the FSH and LH doses, ma'am? You told that
if you have a good testicular volume, we can start with Hcg therapy. Hcg is like a long-acting LH analog. We start with 2,000 units thrice a week, and then we have to repeat their testosterone levels in 8 weeks' time. Semen analysis also has to be repeated often, every 3 months, and if the testosterone levels are not getting elevated with 2,000 thrice a week, we step up the dose. We can go up to 10,000 units, and even higher doses as 10,000 thrice a week.
If still not getting up,
No, we have to add HMG.
HMG.
Yes. So we wait for at least 6 months.
Okay.
But if they have a lower volume of testis, it's better to start with a dual therapy. HMG started as 75 IU thrice a week, stepped up to 150 IU thrice a week. So you can give it combined along with HCG in patients with lower testicular volumes. And that will, they say that spermatogenesis occurs a little earlier compared to Hcg therapy, monotherapy alone.
So only when the testosterone level is low, you will be going for the testosterone treatment.
Yes.
So the basic is for the rebound phenomena to occur.
Yeah. So if somebody is desiring fertility or paternity, we should not offer them testosterone. Straight away go for Hcg therapy because of the cost factor. Testosterone replacement treats androgen deficiency and it's a cheaper and a convenient way. We have to give only once in 4 weeks. So we give intramuscular depot preparations, testosterone and then theta or cypionate. We give adult doses 250 milligrams every 4 weeks or every 3rd week. So that is given for men for androgen deficiency. But the moment they get married and paternity is desired, switch over to HCG. Because HCG is very expensive, HMG is even more expensive. So HCG monotherapy can be started off for men with reasonable testicular volumes, and if response is not seen, then we can add FSH or HMG.
When we are seeing a azoospermia case, first you go for the ultrasound, you look for volume, then we have to proceed.
Yeah, we have to differentiate between obstructive cause
and
because the treatment is totally different.
Okay.
And endocrinologists don't have much role in azoospermia.
Okay, madam.
Except in cases of hyperprolactinemia. As I mentioned earlier, man with macroprolactinemia, he had azoospermia because of high prolactin. There again we offered Hcg therapy because he had reasonably good testicular volumes. We gave him cabergoline as well as Hcg and spermatogenesis. Now he is a father of a child.
Thank you very much, madam. Madam, one question from Jayashree, madam. Before starting metformin, routinely you will be going for HbA1c level?
Yes,
madam?
very definitely.
Okay. What's the preconceptional level of the HbA1c you will be advising, madam?
Usually less than 7, if possible less than 6.5 is ideal.
Preconceptional means it's it must be around 5.8, no madam, or it's okay when it is?
You mean planning for a pregnancy, right?
Yeah,
so if they're non-diabetic, in general, if it's 6.5 or 7 and less, that will be safe enough for a good pregnancy.
Okay. Thank you, madam. Thank you. Thank you very much.
May I comment?
Sorry, sir.
Regarding that last point on that hypo treatment, there was a nice paper from KEM Bombay. I think Anjali would be definitely aware of that. They have done on straight away starting with HMG, HCG when they are diagnosed at 17, 18 years. The traditional conventional thing is what we are all following till today, and it works well. And
it
most
is
of the
only
guidelines
because of the
mention.
cost factor. HMG is
What they
very
are saying
expensive.
is just like how you start in a type 1 diabetic, you start on insulin. Here there is a deficiency of the gonadotropins. You give gonadotropins right from word go, pubertal induction, and many of them respond well. And once they start spermatogenesis, preserve the sperm. Then go back to testosterone therapy and you may use it later.
But that will not prevent the azoospermia. Again, the spermatogenesis
it's not like you are restoring fertility naturally, but the response of that is seemingly better than a patient who has been on testo for more than 10 years. He comes at the age of 30, 32 for therapy.
Thank you, madam. Thank you, organizers, for this.
Thank you very much for that session. So sorry for the technical glitch. So I think we will move on to the next session. But before that, can I request Dr. Muthukumaran to felicitate our chairpersons and speakers? Thank you very much. We'll move on to the next session. We're already half an hour behind schedule, but we'll hope to catch up as we move forward. So the next session is also proving to be very interesting. This is on thyroid. So may I request our chairpersons, Dr. Senduru Ramachandran and Dr. Sumati Ma'am, professors of obstetrics and gynecology, to take the stage, please.
A warm good morning. I feel privileged and I thank the organizers for this nice opportunity. The topic is hypothyroidism in pregnancy and update. We all know that thyroid gland during pregnancy undergoes changes in structure as well as in functions because of increased levels of human chorionic gonadotrophin, increased levels of estrogens, and altered iodine metabolism. If not properly diagnosed and managed, hypothyroidism, both overt as well as subclinical hypothyroidism, may lead to complications in the mother, fetus, and in the newborn. In pregnancy, it may cause spontaneous abortions, maternal anemia, preeclampsia, gestational hypertension, placental abruption, and preterm labor, low birth weight infants, as well postpartum hemorrhage. In the fetus, it causes neurocognitive disorders, congenital hypothyroidism, and after birth, neonatal hyperbilirubinemia and respiratory distress. So now I request Dr. Muthukumaran Jayapal onto the dais to deliver his lecture. He is graduated his MBBS, MD in UK, MRCP UK, CCT, Endocrinology and Internal Medicine, present designation, Consultant Endocrinologist and Managing Director, ARCA Center of Hormonal Health Private Limited, Chennai. Affiliations, postgraduate training in the United Kingdom, internationally accredited training in internal medicine and endocrinology. He did his research degree MD UK in diabetes and genetics. His achievements: Honorary Treasurer, Endocrine Society of India, 2015 to 18. Honorary Secretary, Endocrine Society of Tamilnadu and Puducherry, 2019 onwards. Had several publications in national and international journals. Over to you, Dr. Muthukumaran.
Thank you, ma'am. Thank you for the warm introduction. Thank you, Madurai team, for the opportunity. I'm just going to give you a broad overview this morning about hypothyroidism in pregnancy. And there's been a few confusions regarding our TSH values, when to treat and when not to treat. And that's my task cut out for this morning. It's not moving. Thank you. So what we're going to look at is the background behind this topic is hypothyroidism is really easy to diagnose, but accurate assessment during pregnancy becomes a challenge because of various reasons. And the interpretation of thyroid function test is also different from what you do in a non-pregnant patient. And that then comes the Hcg effect, which puts us into question about changing Hcg, changing TSH concentrations, especially in early pregnancy. You try to catch up with the increased dose. And to complicate matters, the TSH reference ranges, both in the population and in pregnancy, have been discussed, debated all over the world. And I'm going to give you reasons why this has been done. So, and then the controversy about pregnancy is, should we screen everybody or should we just screen the targeted population? And there's been arguments on both sides for this. Some of the organizations have gone for targeted screening. Some of them have gone for universal screening, and the data behind this is, again, multiple studies, even larger studies have just failed to decide on this matter. The current advice from the international bodies is targeted screening, but we know when you do targeted screening, you can miss up to 30% of your patients. The ACE recommends, the only international body which recommends universal screening is ACE. The ACOG, the American Thyroid Association, the BTA, everybody recommends targeted screening. What do we do for detection of thyroid dysfunction? Both in pregnancy and normally, TSH is our most important test. And the TSH is the best test because it's more accurate, it's reproducible, and we've got sensitivities up to 0.01. And it is much more reproducible than your free T3 and free T4 or total T3 and T4. And we have a log linear relationship between your free T4 and TSH. I'll just skip one slide back. So this is what we mean by a log linear relationship between your TSH and free T4. There is a small change in your free T4, like for example, it moves from 0.6 to 1.2. There is a significant 100-fold difference in your TSH. So your TSH will move from 2.5 to basically above 100. So that's what. So it's very, very sensitive. It's very reproducible, and the current assays are very, very accurate. So we bank more on the TSH than your free T4 or total T3. And as you're all aware, the hypothalamic pituitary axis should be intact to make sense out of this using a TSH. So if you have a problem with the pituitary gland, then you might have to screen your T4 and TSH together. And going back, the TSH has got two subunits, which is alpha and beta subunit, which confers specificity. And there are multiple hormones which have got a common alpha subunit, and this is one of the reasons why we have pregnancy-induced first trimester changes as well. And the TSH secretion is regulated by negative feedback by the circulating thyroid hormone, and it's also got in other interactions with somatostatin and dopamine. The TSH then stimulates the thyroid gland to produce your free T3 and free T4. So where do we stand with the normal TSH? We've been discussing this for some time, but the current advice is in patients with hypothyroidism, we want to keep the TSH to less than 2.5, and sometimes organizations have given us trimester-specific ranges as well. We'll come back to this in more detail. So in anybody who's attempting to be fertile, then we would like the TSH to be less than 2.5 on patients with thyroxine. We will look at it for patients who are not on treatment in the next few slides, and Dr. Sriram will also be discussing about patients who are normal thyroid levels with antibody positivity. But before you interpret the TSH gets influenced by multiple factors like age, gender. Your body mass index is a main marker. Even in young children, if they are very, very obese, their TSH can go up. Ethnicity is a common problem because various populations have been noted to have different TSH ranges, and my next slide will tell you that. If you look at the Caucasian populations here, these are normal patients. These studies the data has been taken from multiple studies, multiple different studies, and if you look at the Caucasian reference ranges, they are much, much different than what you would look into the Chinese or the Indian data. So here, the upper limit of normal is certainly very, very high. If you look at the first trimester ranges, if you look at here, your upper limit on the first trimester would be 2.5 in the white Caucasian people, whereas we have got like around 5 is our upper limit of normal. And this is one of the reasons why organizations have, are debating to start whether to treatment on lower TSH ranges. So this is what we are going to look at. There are instances where you need to be cautious. I've given you the physiological thing. These are the pathological areas where you need to think twice before just depending on your TSH. If somebody has got pituitary dysfunction, then you cannot use TSH just alone. Some diurnal variation is there. Patients who are on drugs like glucocorticoids, dopaminergic agents, metformin can also have a smaller effect on your TSH. There are other rare combinations like TSH receptor polymorphisms, heterophilic antibodies. They all alter your TSH. The last but most important out of this lot is your undetected adrenal insufficiency. A person with undetected Addison's disease may also have a TSH, but the most important thing is in these patients, we endocrinologists would like to start the patient on steroids prior to starting thyroxine therapy. So this is very, very important clinically. So how does hypothyroidism work? In general terms, your TSH starts going up gradually and slowly prior to your dip in your total T4 and T3 hormones. So if somebody has got mild thyroid dysfunction, then that's when the TSH starts to go up. The T3 and T4 levels will be in the normal range for a couple of years at least prior to dropping down. So these are the number of years when you move from mild to moderate to severe hypothyroidism. So moving on, that is a broad overview of the TSH and the test what we use, but thyroid physiology in pregnancy changes all these things. So the increased estrogen level in your pregnancy will cause the thyroid binding globulin to go up. This reduces your free thyroid hormone availability, causing stimulation of hypothalamo-pituitary axis. So this is kind of in normal physiology. Your Hcg, which gets secreted between and reaches a peak between 8 to 12 weeks, stimulates the TSH receptor because these have the alpha units of Hcg and TSH are very, very similar to one another. So the Hcg has a TSH-like activity which increases the thyroid to produce more thyroid hormone. And this is primarily related to Hcg-related thyroid receptor stimulation. And then last but not the least, type 3 deiodinase increases thyroid dehydration, increases glomerular filtration rate, and there is also increased T4 placental transport. So these are all multiple changes which gives us a broad overview of the physiology in pregnancy. And then the fetal effects also are there. The source of iodine for the fetus is primarily the mother in all trimesters. Thyroxine is partially converted to T3, which is responsible for fetal brain development as early on. Up to 12 weeks, the fetus is primarily dependent on the mother's thyroxine level, and this becomes important to treat it more actively and acutely as well. And after the 12 weeks, the fetal pituitary thyroid axis starts functioning. And this is what I meant by your Hcg. This primarily happens in the first trimester, so the Hcg peak happens around the 8 to 12 week mark, where the Hcg stimulates the TSH receptor, and there is a surge in thyroid hormone activity leading to a marginal increase in free T3 and free T4. with the dip in TSH. And some of these patients may have even up to less 0.01 levels of TSH, which might surprise us sometimes. These patients have to be examined thoroughly, do a good clinical history, and that's what would differentiate. If in doubt, a thyroid TSH receptor antibody can also help you, but that's not needed in most patients. I would say a good clinical history and examination is all is enough for these patients, and a repeat test at 4 weeks would be just sufficient to confirm this. What happens with maternal hypothyroidism? There is no doubt that overt hypothyroidism causes a lot of damage. And I've put on various studies. These are data from different studies. It uses, these data varies for spontaneous abortion between 10 to 70% in subclinical disease, and spontaneous abortion happens in 60% of individuals with overt hypothyroidism, which means you've got significant hypothyroidism with raised TSH more than 10. Preeclampsia, abruption, stillbirth, anemia, postpartum hemorrhage, and preterm birth are all problems due to hypothyroidism, maternal hypothyroidism that is. And looking into more detail, pregnancy loss is very, very difficult because most of the pregnancy losses we have is in the first trimester or even before the patient themselves recognize, and they may have raised TSH. And it's, there is a continuous relationship between your TSH and pregnancy loss. So the higher the TSH, the higher the likelihood that you're going to lose the pregnancy. But we do not recommend MTP as a therapy for this. We try to normalize thyroid function tests as soon as possible or as soon as the diagnosis is made. So premature delivery is another complication leading to infant mortality or even pregnancy losses, and there is a substantial morbidity even in later in life. So again, this is also a continuum-based therapy, so the higher the TSH, the higher the chances of premature delivery, and patients who have ATPO antibody positive are at a higher risk. Patients are also at a higher risk of hypertensive disorders, low birth weight babies, and then last but not the least, the IQ loss which was detected by the NEJM paper, which is put off to, this was a paper, retrospective paper, where they compared with hypothyroid mothers with normal mothers and children who were untreated, who had subclinical disease, had an average IQ loss about 6 to 8 units in comparison to patients who had been appropriately managed with thyroxine doses. So when compared to the patients who are not on treatment, if you compare two scores, when you compare the IQ scores of children of untreated mothers, there is 7 points lower than the control. The children of the women who were born with a higher TSH, again, had a higher percentage who were running into this problem. So this was the primary aim of treating subclinical hypothyroidism in individuals. Who should we screen for this? And there are a particular group of individuals who are at risk. Patients who had a history of thyroid abnormalities in the past, patients greater than age of 30 years as such in diabetes, family history of thyroid abnormalities, patients who have goiter. We assume most goiters are autoimmune unless or until the patients are on a low iodine diet. Symptoms, signs, and suggestive of thyroid disease. Anybody who has got type 1 diabetes, anybody who has got a history of other autoimmune conditions like rheumatoid arthritis, subfertility, previous head and neck radiation, and history of miscarriage or preterm delivery. So these are the individuals who should be ideally screened mandatorily. There is various guidelines which have been advising us about when to screen and what to screen, and there are too many guidelines, but as I said earlier, the Indian national guidelines, mainly endorsed by the Indian Thyroid Society, recommends measuring TSH levels in all pregnant women at the first visit, because most of our population are ideally have not had a thyroid test in the past. So ideally, in the first pregnancy visit, they should be screened with a free T4 and TSH or a total hormone check, whichever is available. Evidence for this is limited, but as I said, universal screening has been advocated only in our country because of the differences between our Caucasian counterparts and us. Again, there is a high-risk group here who needs more particular care, and these should include, these patients are people with history of thyroid autoimmune disorders, family history of thyroid disease, women with goiter or with a history of miscarriage or preterm delivery. So I'll just skip this. There's been, we've been discussing hypothyroidism is not an issue at all, but there has been a couple of studies who have complicated matters or confused us, and these two studies, which were the Negro et al. Paper for universal screening and case finding, and the John Lazarus paper, which was the CAT study, which was controlled antenatal thyroid screening. And I'm just putting it just for information here. And the maternal outcomes in these universal screens and case finding studies did not offer any benefit, and this was the basis of the recommendation of the Western guidelines not offering universal screening. This is another study which showed that people who have got autoimmunity and at the risk of miscarriage or a previous history of miscarriage do benefit a lot from therapy with thyroxine, even whether it's a 25 microgram dose or your low thyroxine. I'm sure Dr. Sriram will touch upon this more, but patients who have got subclinical disease may benefit and can reduce their pregnancy loss or their risk of pregnancy complications just by taking a small dose of thyroxine. I'll just skip this due to time. So the other thing is we find a lot of women at the end of pregnancy or in the second trimester with isolated low free T4 values or even total T4 values. And universally, it has been agreed that these are due to, I would say, variations in measurements, and there is no study. If the patient has got a normal TSH and a low free T4, these patients don't need any treatment on its own. So this will be addressed by Dr. Sriram. Our next part of the talk would be on the current guidelines of management of thyroid dysfunction in pregnancy and postpartum. And there are specific recommendations given by these organizations, especially the American Thyroid Association. Oral thyroxine therapy is not debated anywhere. Oral thyroxine therapy for people with hypothyroidism is mandatory, which negates all risk of fetal loss, premature birth, and this is more appropriate even for patients with positive antibodies. So women who are already receiving thyroid replacement therapy should increase their therapy by 25 to 30% while they're pregnant. And people who are, you think are a higher risk and have got autoimmunity should be monitored closely. In the first trimester, most of the reference ranges, we would like to keep it at less than 2.5 and up to 3 in the second trimester and the third trimester. As I said, treatment is not needed with isolated free T4 levels, and a minimum suggested iodine intake is around 250 micrograms per patient. Data currently, according to the American Thyroid Association, is insufficient for universal screening, but during the postpartum phase, people have to be monitored more closely. So if you've got antibody positivity, then they are at a high risk. If they've got levels above 10, they need to be treated. If they've got negative antibodies, then they don't need to be treated. So how do we adjust levothyroxine treatment? If the TSH is greater than 10, then increase the dose by 50 micrograms. If the TSH is more than 20, you might need a further increase, and if the TSH is greater than 20, you might want to put it further. Still, there is a significant proportion of people who are not well treated in pregnancy, about 40% who are above target, so we need to address that. And people who have had surgery will need up to a 50% increase in dosage for patients who have had thyroidectomy, for thyroid cancers, or any other surgery in the thyroid. One word of caution is if you're giving iron, please do not give it within 4 hours with your thyroxine. The absorption will go down. The same applies to calcium, so preferably calcium at lunchtime and iron at bedtime. And people with postpartum, you can certainly stop after, if somebody is on a very low dose of thyroxine, 25 or 50 micrograms, it's very safe to stop as long as they do not have risk factors post-pregnancy. One word of caution about iodine status, a lot of people have started following the Himalayan salt, pink salts and things, and pregnancy is one time where you are at a highly increased risk of iodine insufficiency, and make sure that your patient is taking iodized salt. So that's the answer, because iodine is an important mineral, and it is one of the most common causes of mental retardation and short stature elsewhere as well. So in summary, pre-conception, we want to optimize the therapy if possible and if there is an opportunity. Once the pregnancy is confirmed, there will be certainly an increase of 30 to 50% from the pre-conception dose. Our target levels for TSH is less than 2.5 in the first trimester, less than 3 later in the pregnancy. The reason being that is we do not have pregnancy-specific reference ranges in our country for most laboratory testing. So this is where we stick to the reference ranges, and after delivery, go back to your pre-pregnancy dosage and assess your thyroid function in 6 weeks postpartum. Patients who have had surgery or post-radiation, which is primarily radioactive iodine, will need higher doses of therapy. Thank you so much for listening.
Thank you, sir, for your excellent, crystal clear lecture on this subject. The take-home points: we have to screen and manage hypothyroidism in pregnancy, which is trimester specific. The dosage has to be adjusted accordingly. During the first half of pregnancy, the TSH values has to be monitored every 4 weeks, and in the second half, every 2 months, the TSH values to be screened according to the FOXI guidelines, or at least in the second trimester, once in 28 weeks, we have to screen. And we routinely screen the newborn for congenital hypothyroidism on day 4 of delivery. Routinely, we do the thyroid profile on day 4 after birth. And regarding the universal screening and targeted screening, we, in our setup, routinely screen the woman for thyroid profile at the first antenatal visit or as soon as the pregnancy is confirmed. Thank you, sir.
Pleasant morning to all. And it is really a great privilege to introduce Dr. Sriram Mahadevan. He graduated from Stanley Medical College and is postgraduate Institute of Medical Education and Research, Chandigarh, and presently professor and head of the Department of Endocrinology, Sri Ramachandra Institute of Higher Education, and consultant endocrinologist, Sundaram Medical Foundation. And affiliations to the postgraduate training in the UK and internationally accredited training in internal medicine and endocrinology.
Sorry
and
to
achievements.
interrupt. That's a copy-paste problem.
Okay, sir. So
I think
that is the executive
many
committee.
of our colleagues know me.
Yes.
I think you, Muthukumaran naduvula paste maatanga. You just leave it there.
So really it is
Thank you.
regarding this anti-TPO antibody positivity in youth-bridal women.
Thanks,
really
madam.
it is management issues. We are having really a lot of doubts.
Yeah.
So over to you, sir.
I'm really thankful to you, but the problem is the organizer is staring at me again and again. We are already learning too late, and already Muthukumaran previous speaker has given some points which are really controversial and needs a lot of discussion, and I'm going to add to that confusion and hopefully give some clarity, some take-home points which will be practical for our management tomorrow, based on what I understand from this literature. The review is heavily based on all guidelines and all articles related to the guidelines, and original studies from India, especially on this issue of euthyroid antibody positivity, is literally lacking. And so I will give you some background on the thyroid antibodies and the link between the positivity or elevated titers of these antibodies and pregnancy outcomes. And very important question is, does intervention in some form benefit in the outcome? And how do we take the guidelines? So we know there are basically 3 main antibodies. For our discussion today, it will hover around only the thyroperoxidase antibody. And these antibodies are polyclonal, predominantly IgG. By that we mean that they will cross the placenta, A simple way to remember is these antibodies are thyroid inflammation specific, thyroid disorder specific illa. Something like prostate specific antigen is prostate specific, not prostate cancer specific. So don't use it for cancer screening, in that sense. And thyroglobulin also not a marker for thyroid cancer. It is thyroid, any follicular cell in thyroid producing thyroglobulin. Similarly, these antibodies, if your gland has undergone some damage during your childhood, some inflammation, or you have a genetic predisposition that has been mentioned here, you will form antibodies against various antigens in the thyroid, and one of the most common antigen against which this is formed is thyroperoxidase, also called thyroid microsomal antibody. And thyroglobulin antibody is also common, but by convention, and because a lot of studies have been done with TPO, we use TPO antibody. So some clarity? So don't use only TPO antibody. If you are using as a panel, do together, but go by TPO antibody. And whatever literature I went through, if the titer is above the limits of the lab, take it as positive. It is not like 1 in 1 lakh will have a higher prevalence of something versus 1 in 50,000. Do not check it again and again to see whether it is coming down. These are all common things we do many times. Patients get worried. The number comes as 1 in 1,30,000 and all. If you dilute and do it. So these antibodies, because they have been shown to have a link to the inflammation, which I already mentioned, and like TSH, it also has a lot of other factors which are controlling these antibodies. For example, here, extremes of ages, pregnancy is an enormous stress. So any postpartum lady will have more likely to have formed antibodies. So before second pregnancy, she may have. And other immunomodulating conditions, recovering from another immunosuppressive therapy, like the heart therapy will cause immune reconstitution. And whenever you lose the thyroid gland by radioiodine, your titers will come down. All these have to be kept in mind while interpreting. And in normal population, you see here, from the Wickham survey in the early 1970s, roughly around 6%. With changes in titers and the antibodies, it is up to anywhere from 10 to 15%. And recently, there are quite a few papers from India. So roughly around 10 to 15% of normal population will have antibody positivity, out of which a small subset will develop thyroid disorders. And in pregnancy, remember this mantra. In general, this is an immunotolerant environment. Otherwise, a female cannot have a XY chromosome male baby inside. No, it's a very simple way of remembering. How can she carry a fetus? So, immunosuppressive state. And that's why all autoimmune disorders actually go into some remission during at least the second half of pregnancy, and nicely exhibited even in this cartoon. You see the thyroid specific antibodies come down, and again, like immune reconstitution, it gets elevated. That's why the postpartum thyroid disorders have a immune based mechanism here. And IgG antibodies are most predominant. They traverse the placenta, and that's why they will have an impact. I am not discussing Graves' disease today. Most often I am discussing only TPO antibody positivity. And if there is a TSH receptor antibody, that can very well go inside and cause even fetal thyrotoxicosis. But they are a mixture of both stimulating and blocking antibodies, and TPO antibodies, predominantly IgG, can cross. To the extent that you will have these TSH functions. You see here, interestingly, is more in the first trimester in antibody positive people when compared. In the one concept discussion. What does this thyroid antibody positivity mean? Very oversimplified way of saying is there is some problem in the thyroid which makes a relative deficiency of thyroid in a normal person also probably. On the top of it, you become pregnant, your demand is more. So this already antibody positive lady with a minor, a first hit Mari, there is a problem in the thyroid, not able to produce enough thyroxine. First trimester, Hcg, stress, all these things have been told already. So the demand is more. Maybe this antibody positive thyroid is not able to cope up with the demand. So they may be subtly deficient in thyroxine. That's the whole logic behind why thyroxine is given and not steroids are given to suppress this. So any organ-specific antibody treater, you give immunosuppressive therapy, target antibody therapy, that's not thing. So in pregnancy also they have done antibody positivity studies, and anywhere from 10 to 15%. Most of them are Caucasian studies, and depending on which clinic you study, it may be more. And The whole idea is to tell you that you may have normal people getting pregnant with antibody positivity. That alone will not be a stress, a subset of them will have. So these are all the mechanisms proposed, taken up from various reviews. The first one I have put here is the most easiest way to understand. All other things are more of an animal-based informations which may or may not have clinical significance. So we assume, or there is enough reason to believe, and I have already shown you the TSH increasing when compared to TPO negative versus TPO antibody positive people. So mild thyroid hypothyroidism happens in many people. Mild means the TSH going within the normal reference range. That's why this all discussions on 2.5 to 4, whether antibody positivity, etc. are coming up. So does thyroid antibodies affect pregnancy outcomes? I think Dr. Muthukumaran showed enough paper on TSH elevation. Here I am discussing euthyroid. In this case, I have to already, a disclaimer I already say, for this discussion purpose, keep TSH as less than 2.5 as normal. Let us not go into that 4 discussion today. 2.5 is normal, most of them are Caucasian data. So less than 2.5 TPO antibody positivity, what will I do? That's what is the next few slides is going to tell you. Lot of information. These 2-3 names like Haddo et al., Glenor et al., Stagnaro, Green et al. Thiruppi avanga papers now. Everywhere they have done a lot of studies to tell us that there is a definite association between antibody and these people you see here, TSH getting elevated through more than 4 during the pregnancy. This Negro et al., they have done a lot of work on this. Again, TSH increasing more than limits of the thing. And we know the background biological basis also. So for every reason to believe that the antibody may interfere, especially during pregnancy in the thyroid and cause a mild thyroid dysfunction, and hence the recommendation very clearly, if you already have a patient who has got an antibody positivity, you know the report. We are not asking to do the report in every normal pregnant lady and find out that 10 to 15% of normal people having positivity. If you have a positive report, at least monitor the TSH. If less than 2.5 in the first trimester, which is the most sure short way of saying that the thyroid is functioning normally if it is less than 2.5, and if not, monitor at least. If you are not sure of the lab, etc., you repeat it. And please monitor it throughout pregnancy is the recommendation. And as has been discussed with TSH elevation, euthyroid positive people, TPO positive people have been shown to, in 2-3 meta-analysis of 3-4 studies put together, those small studies, that they have more chances of spontaneous pregnancy loss. First and second trimester losses are more. These are all observational studies. This is one large meta-analysis to show that the TPO antibody positivity people have more chances of miscarriages. This is one clear association. Premature delivery also, there is reasonable data, and again the same names you see here, Negro and other people. We will see that again there is a reasonable, strong basis to say that TPO antibody positive but euthyroid mothers have a relatively higher risk of these complications. In addition to that, there is some association between perinatal death, placental abruption, postpartum depression, etc. So what do we understand? இந்த மாதிரி ஸ்டடி போட்டாலே அதுவும் தலையை சுத்தம். These are all association studies, like TSH also. Proof of the pudding is in its eating. So that's because they are nicely pooled meta-analysis. We understand that there is a strong association between elevated thyroperoxidase antibody in euthyroid mothers causing problems. But is it the real cause? I already mentioned that they are not causative antibodies. They may be just there, but they are getting clearly associated, causing some dysfunction at the placental level, zona pellucida level, or at the thyroid level. So how to prove that they are actually causing? You treat with thyroxine and see whether these complications are improving. And that's where the problem starts. What are the studies showing? This is euthyroid. This is one of the largest study done. And this is called the tablet study. So for everything we have the gospel, this is a randomized control trial. Because miscarriages are the most important association of TPO antibody, these studies take the highest risk of TPO antibody people and show that in euthyroid TPO positive people who have an history of miscarriage and due to that an infertility, Around 476 women were treated. This is a UK study where a 50 microgram of thyroxine was a standard dose given to all these women. And what did they show? No big difference in the pregnancy outcomes. The p-values are not significant for miscarriages also, which was the primary aim of the study. Immediately we should not jump. Is it the final answer? There are a lot of flaws. See, every study will have limitation. What are the limitations? In UK, booking is done after 12 weeks. So that itself is a limitation. So our people, you all know, are our senior gynecologists sitting here. Many people will come at 7th week, 8th week itself. Starting thyroxine at 7th, 8th week, which is the most important period, mukyama, illa 13, 14 weeks kapram aarambicha in the study mukyama. Idha nama kekkanum. Then everybody was given 50 microgram thyroxine only as a standard dose, but we titrate. It's not like everybody will require only one dose. So these are also, and all other antibodies which are the other autoimmune conditions which are associated, they are not ruled out in this study. They presumed that thyroxine was the only antibody here. So limitations become the arena for further research in this, and the conclusion of this study is correct according to this study. In this study, they show that a standard dose of 50 microgram levothyroxine given to euthyroid, TPO positive to UK women with previous history of miscarriage and infertility did not show anything in that study for the 2 years time. Whether it will be the same thing repeated in India here, and when you have a given patient here, that's different. So lack of evidence is not a gospel equivalent to saying that it is evidence for lack of benefit. This is the other way of putting it. So then come the, so this fallacy has been addressed in the next study. This is published just 2 months back in Lancet and Diabetes Endocrinology, which is T4 Life trial. In the trial will be repeated in all thyroid talks everywhere. Phase 3 trial where 2 important things have been addressed which were the limitations in the previous study. And that is, this is also a big study in Belgium, Denmark, Netherlands. So it's a multi-centric international study. Women TPO positive with more than 2 pregnancy losses. So by our usual thyroidology definition, they are high-risk people. And they gave thyroxine to these people, and they ruled out, you see, so many other autoimmune conditions as cause of miscarriages, which was not done in the previous study, and they gave a titrated dose of 50 microgram, not only 50, they gave titrated doses, keep the TSH below the recommended doses in those hospitals, and again showed in these high-risk people that the live birth is the most important definition, not just conceiving around it. So they showed that again it was not significantly different between the treated and the other group. So now the problem, you had an association biologically proven by the previous association studies, pooled analysis. However, the prospective interventional studies are not showing big benefit. Does it mean to say that we will never give thyroxine to all our people? That's, you have to individualize. This is the Kaplan-Meier curve of live bleeding. So you see both are overlapping on one another, means there is no significant difference. And again to show that in people with high risk recurrent pregnancy loss, in spite of excluding all other causes, TPO antibody positive mothers with euthyroid mothers, we are not getting a good benefit out of thyroxine therapy. Then to add to more confusion, they said, okay, in spite of that, we will decide to give thyroxine. No harm, 25-50 microgram thyroxine. Usually we all know that may not harm the baby, and you should know. This is also an important parameter to remember. Thyroid hyperthyroid, the pregnancy is a mild thyrotoxic state, especially in the first trimester. You saw the TSH is always low. So putting all this together, to add to confusion, see, this is one paper again from the European people, 2015. Haddo et al., Dr. Muthukumaran showed that subclinical hypothyroid mothers not getting treated, the baby had an IQ point lower by 6 to 8 units or 7 units exactly. Here, people who had a TSH which is suppressed in the first and second trimester, brain volume morphology was different in these people as studied by MRI and other things. But that's how science goes, you know. You have to take these points together. So tomorrow, so don't over-treat also is what they are trying to convey from this. But this has to be replicated in number of other studies. This is not a clinical study. These are all the children who underwent MRI, and they went back and showed that they were all the mothers who had TSH less than 0.1 in the first trimester. So this is also just to remember that I will not treat everybody. That's another. So that is why the guidelines are varying. With so much of conflicting information coming from different guidelines, These ACOG people already in GDM, I'm sure we were all sitting in Hall B, in Hall A, the discussion was happening. I'm sure there would have been a lot of differences of opinion between the Indian. Similarly, we have the American College of Obstetric Gynecology and the American Thyroid Association, some discrepancy. Because 2017 was the last guideline published by ATA, and today it's almost 5 years. Guideline, there is so much of new information has happened. It's high time that the new guideline incorporating all the new information has to come, and that's why the ACOG, this Clinical Thyroid Journal, came up with this interesting final table information, which will be useful to go through for our final message from this talk. I have given you confusing information. First part I showed you that there is a clear association between TPO positivity and TSH normal people. When I say normal, in pregnancy and pre-pregnancy less than 2.5, still having adverse outcomes. You treated big randomized study, 2 major studies are not showing benefit in the high risk people. That means there is something we have to go more than this. Then should we treat or not treat? Be safe, and that's why you see the ACOG people are not agreeing to treat. TPO positive, TSH between 2.5 and reference range, TPO, but this is the place we are discussing here. They are not agreeing, but still ATA 2017, these are all not agreeing because they are incorporating some of the information of this tablet and other studies also into this. So my take-home message from this, whatever I understood is, you individualize. How do I individualize? Please, I will err on the ATA side. In spite of all this, we know that iodine deficiency will be a problem, obesity will be a problem. I will know that our TSH assays are not the best. I cannot be repeating every 4 weekly and all, it's not possible. They are saying that if your TPO is positive and TSH is in the normal range, you monitor. How many of us will monitor? Every trimester we will take free T4 TSH also. Then in the second trimester she comes with a TSH of 3.8, suppose, which is above the limit, but below 4. Will you leave her? Then they will say, no, sir, Ponavati in that area, Ponavati 2.6 in the 3, but the patient will ask you 100 questions. So my take-home practical message from all this is, that's what I personally feel. I'm opening a Pandora's box. I know I will treat these people, especially people with high risk, people with goiter, background autoimmunity, TPO positivity, even if TSH normal. There seems to be some logic somewhere. Just because 2 big trials done specifically in special subgroup of high-risk people did not show benefit, will not be my take on this. And I back up on ATA, and I agree with them, at least on this thing, that maybe we should consider treatment in many of our women. This ACOGs, they are too strict here. In fact, see here, they are not treating even TSH above the limits of normal, only if free T4 is low. This we don't do. Free T4 assays are highly unreliable. If TSH above 4, you have to treat first trimester. So the guidelines are formed by few people, like many of us sitting here, and sometimes we have to take with a pinch of salt. So guidelines are guiding us in a manner, but treatment is what I will consider in most of these people, in high-risk people. Thank you very much for your kind attention, and if there are any questions, I'll take up.
Thank you, sir, for enlightening on TPO antibody. So once it is becoming positive, the titer, it will be always positive or any chance to be low?
Yeah. If your antigenic stimulation is less, for example, if I undergo total thyroidectomy, and suppose I am a TPO antibody positive person, if I undergo radiation ablation or my gland is removed for some reason, my antigenic stimulation goes almost nil. So TPO antibody will come down. So it's not like that. Or, for example, answering in a more practical way, the immunoinflammatory damage in Hashimoto's thyroiditis, which is the most common thing we all see, will also make the gland totally atrophic over a period of time. So again, the antigenic expression will come down, due to which it will come down. So it's possible that it will come down also. Okay. Or if you have recurrent thyroiditis, it will go up also. Positive.
Positive. The topic is open for discussion. So any relation to the diet, if some patients will come and ask if they are hypothyroid, whether I can take any specific?
At least we are, this is like yesterday the other doctor, senior doctor there mentioned, is evidence-based, scientific, trial-based, that's the answer. So many public forums we are mentioning the same. முட்டைக்கோசு, முள்ளங்கி, காலிஃப்ளவர், நூற்கோல். இப்போ இந்த சிறுதானியம் வேறு வந்துருச்சு இதில். மில்லட்டு, எல்லாரும் gluten free. இப்போ எல்லாரும் சவுத் இந்தியாலையும் gluten free ஆகின்னு வரா எல்லாரும். So the thing is, these are all conjectural things, more of hearsay. There is no clear association. See, a logical thing it's like I was trained in North India. We were exposed to celiac disease so commonly there. You have a person with celiac disease, obviously he will have hypothyroidism. He will have absorption problem. There you will take all the precautions to treat him correctly. இங்கே போய் உட்காந்து தைராய்டு சரியாயிடும்னு சொல்கிறது. See, these are all the autoimmune diseases which have remissions and exacerbations in their natural history. So how will you prove that it is due to dietary intervention? So we should not recommend anything in a forceful. அவங்களுக்கு பிடிக்கல, அவங்க சாப்பிடல, அது வேறு விஷயம். தைராய்டுக்காக சொல்கிறேன்னு சொல்லக்கூடாது.
Thank you, sir.
Thank you. டைம் இருக்கான்னு கேட்டுக்கோங்க. Organizer.
As we are running short of time, we can conclude our session.
Thank you very much for that fantastic session, and can I request Dr. Usha Ayagri to felicitate our speakers and chairpersons. Thank you very much once again. So as we are running late, and we're actually running 45 minutes late, so we're not going to have a tea break. We're going to have a working tea. So if someone wants tea, please step outside. We're actually going to go on further. So the next symposium is again very interesting. As from the previous symposium, if people do have questions, speakers are available. You can please contact them during this time to ask them questions. So can I invite our chairpersons for the next event, Professor Dr. Revati Janakiraman and Professor Padma Ma'am, Professors of Obstetrics and Gynecology, to chair the next sessions.
Good morning, dear friends. Thanks to the organizers for giving us this opportunity to be here to correct the menstrual irregularities or infertility, but hirsutism poses a great challenge. And here is Dr. Chitra Selvan, who is going to clear our doubts and how to manage difficult hirsutism. She is Associate Professor Endocrinology, Ramaya Medical College, Bangalore, and she graduated from Madras Medical College and DM Endocrinology in IPGMER, Kolkata. And he has received A.V. Gandhi Award for Excellence in Endocrinology in 2015, and she is a member of National Academy of Health Sciences, and he has got to her credit more than 40 publications in national and international journals. Over to you, Dr. Chitra.
Thank you so much, ma'am, for that kind introduction. My heartfelt gratitude to everybody on the organizing team of Trendos for this invite. I'd never miss up on an opportunity to visit Tamilnadu, especially Madurai. The chairperson has highlighted about how common hirsutism is and about how PCOS is probably the most common cause of hirsutism. I'm going to restrict my discussion to present maybe the sinister causes of hirsutism or the causes which could essentially portend something dangerous or serious but they present as hirsutism to our clinics. And this is an important thing for us to remember, because as PCOS is increasing, we are also noticing that hirsutism presentation is increasing in women, both in reproductive and non-reproductive ages. So a quick brush up about hirsutism. We all know that it is excessive hair, but the hair has certain characteristics. It usually has to be pigmented, thick, and coarse to differentiate it from another condition called hypertrichosis, which is usually like the baby hair which we see on newborn babies, but this is different. And the location of the hair growth which is significant is in areas where there is androgen dependency. So that includes a few areas, and I'll show you. So as you can see, it's pigmented, thick, and coarse. Now the connection between this increased hair growth on the face is that the androgen exposure to the hair follicle can cause the hair to grow in androgen dependent areas, but the variations of hirsutism could be acne, because in acne, in the same hair follicle, the pilosebaceous unit undergoes hypertrophy, or similar presentation could be that there is hair loss, or referred to as androgenic alopecia. So when somebody presents with hirsutism, that is one presentation of increased androgen in that person. We should also be looking for acne, also be looking for androgenic alopecia. That's important. Before we move on to evaluation, it makes sense to kind of quantify the hirsutism to kind of get an idea. And we will now learn about the fallacies of this scoring itself. I think this everybody knows. This is the modified Ferman-Galway hirsutism score. Essentially, there are 9 areas which are androgen dependent, and we score from 0 to 1, depending on whether there is, 1 to 4, depending on whether there is hair growth or no hair growth. It's a very visual, subjective score, but most times we are able to. But of course, it's important to make sure when was the last time they got hair removal done, and then to get a baseline assessment of this. There are a few limitations of the score. It doesn't include certain areas which are androgen dependent, like for example the sideburn. That's a very common area where women come and complain that there is increased hair growth, but it's not represented on the scale. Also, the other area is probably the buttocks. So apart from that, this is a scoring system which is fairly reasonable to use in clinical practice. If you're trying to ask how common is it, the prevalence studies are from various corners of the world. The prevalence ranges from, let us say, 10% to about 30 to 35% of people, depending on the population you're screening. But from India, looks like 10% is what we are looking at. And if you're trying to look at beyond what score of hirsutism did they use to say that it is a clinically significant hirsutism, Caucasians seem to have greater hair in androgen areas as compared to Asians. But in this context, when we talk about Asians, we're probably talking about people from Thailand or China. Not much data from India, but Asians overall tend to have lesser hair than Caucasians. So maybe the score of 8, which is considered as the cutoff for Caucasians, is probably slightly higher for us. Asian studies tend to use a score of 3. I don't think we'll find too many women who have a score less than 3, right? So that is something to be kept in mind as well. So the cutoff is not quite certain for our population. I'm going to begin with case presentations so that we can get into the habit of the evaluation of hirsutism and show you the various sinister or the dangerous causes alone. So this is a 19-year-old lady. She presented with increased hair growth on the face, also had secondary amenorrhea and a change in voice since the last 6 months, and this happened during the COVID pandemic. So on clinical examination, her score, which we just spoke about, was about 16 by 36, that's moderate. But since there was also deepening of voice, she received a full clinical examination which showed that there was enlargement of the clitoris as well. So she underwent evaluation for the same. Her TSH, prolactin, and 17-hydroxyprogesterone were normal. I'll come to why we did 17-hydroxyprogesterone. Total testosterone was at 759 nanogram per deciliter. Normal range for women is around less than 60 nanogram per deciliter. DHEAS was also found to be very high. I will come to what DHEA is, and her steroid levels were normal, and an ultrasound of the abdomen revealed a 10 centimeter into 8 centimeter mass in the right adrenal gland. So androgen production in women has predominantly 2 sources, ovary and the adrenal. right? So the adrenal produces testosterone, but it also produces DHEAS. DHEAS is almost specific for the adrenal. Although in some situations of an ovarian tumor or so, you can find elevated levels of DHEA and maybe also DHEAS. But if you find DHEAS elevated more than testosterone, probably you're looking at an adrenal source, and our patient did have a lesion. So we went ahead and did an adrenalectomy, and it showed an adrenocortical carcinoma, right? So this was a carcinoma in the adrenal gland, which presented as hirsutism, where the cortisol secretion was normal. This is very, very rare, but not so uncommon. So after the adrenalectomy, of course, we had normalization of the DHEAS and testosterone, both the androgens, and we also saw a reversal in the hirsutism, and her cycles resumed. So the point here is, when you're looking up a patient for hirsutism, while it's important to quantify hirsutism, we should also be looking out for signs of virilization, which is due to either a large exposure of androgen or a longer duration of exposure to high levels of androgen. The features of virilization include temporal balding, like you can see in the image, atrophy of the breast, clitoromegaly, like we said. So maybe indices are difficult for everybody to remember, but if the clitoral length is greater than, let us say, 1 centimeter, there is something to be evaluated further. A change in the body contour or the body habitus of the woman, and temporal balding. All of these are red flags which need further evaluation. So the duration and progression of symptoms are also important. If it is recent onset or rapid progression, it's likely to be an ominous condition underlying. And if you take a look at pure androgen secreting adrenal tumor like our patient did, the mean age of presentation is what I want the audience to notice. It's about 17 years. So this is an age group where they come, and we are very likely to say this is peripubertal onset PCOS and the Madurai. So this is something to remember, that there can be sinister causes as well. So the learning point is, if testosterone level is greater than per deciliter, suspect an androgen secreting tumor. If the DHEAS is elevated more than 800 microgram per deciliter, suspect an adrenal source. I hope that was clear. We move to another age group now. She is 66 years of age, postmenopausal. She was a choir singer. She was actually sent over to me by Dr. Lily John, who is a very astute clinician. She was in the same church, saying her voice has changed and her pitch is off in the choir. She came to us saying she's having temporal hair loss and just a few strands of hair under her chin. Nowhere else, nothing else. Just the 2 strands were growing too long. In fact, she had to go to the parlor to pluck it out almost every 2 weeks. So apart from that, on clinical examination, she looked muscular for a 66-year-old with obvious loss of hair in the temples. So we know now that we need to get a testosterone level done. So the testosterone was 530. So think tumors if levels are more than 200. DHEAS was normal, androstenedione normal, thyroid normal, and renal and liver functions normal. We went ahead to do an abdominal MRI to find out where the source was, and everything was normal. What do we do now? So we went ahead and did a GnRH suppression test. So now we don't know if the androgen is coming from the ovary or the adrenal. To try and differentiate, if you give GnRH, the ovarian source, if it is ovarian source, will get suppressed. And that's exactly what happened. After injection, about 4 weeks later, when we retested testosterone level, it came down, which meant that it was under GnRH control, partially at least. So we went ahead and got a bilateral salpingo-oophorectomy done, and the diagnosis was a granulosa cell tumor. This was quite a bit of a surprise. This was not the tumor we were expecting. In this age group, the most common lesion with this presentation is probably Hylas cell tumor, which is mostly benign. But granulosa cell tumor has about a 35% malignant potential. So, and mostly they don't secrete androgen, and this was one which was secreting androgen. So this is again a sinister cause of hirsutism in postmenopausal. And postmenopausal hirsutism is quite common because after menopause, the relative ratio of testosterone to estrogen is altered. So we do see new onset hirsutism, but it's important to tie it all together with the other features of virilization as well. So this got presented at a recent conference as well. So mild hirsutism also can have an underlying sinister cause. That's the point I'm making. The Ferriman-Galway score in this patient was just 3. Take it in with all the other clinical examinations. So moving further, this is a third person, 19-year-old, went to the dermatologist for laser therapy and not to any gynecologist from the hinterlands of Karnataka. Presented with amenorrhea, no breast development, deepening of voice, and maybe the mother says there was something abnormal around the clitoris, but we never evaluated it, right? So this was the clinical presentation. So here there are many, many red flags, right? That there is primary amenorrhea, no breast development, so definitely this requires detailed evaluation. So the testosterone level was found to be high again, but the 17-hydroxyprogesterone was also found to be high. So the diagnosis was classical congenital adrenal CA, which was simple virilizing form. Usually this is to be picked up just after birth or maybe a few years after birth, but we live in India where access to healthcare might be a challenge for many of us. So it's not uncommon for us to find women reach right up to the age of 17, 15, 16 and present with hirsutism, and all the other symptoms are forgotten. So this is a condition in which there's a block in one of the steroidogenic hormones, which means that the substrates above it get shunted into the production of testosterone. So there's increased androgen and hirsutism as well. Now, another variant which is likely to present is the non-classical CH, which is the same enzyme, but a lesser, probably a greater degree of enzyme activity is present. They might not present with such great hirsutism, might be milder versions, almost like PCOS that we see in clinical practice. But it's an important condition to recognize because it has repercussions in terms of, let's say, the child's risk of getting CAH in the future. We might need to offer genetic counseling, so we might need to pick this up in clinical practice. So I think while PCOS is the most common cause, there could be mimickers of PCOS which can present with just hirsutism. This is a case report published from Tamilnadu. This is from the SRMC team, Karthik and team. So she is around 16 to 17 years of age, secondary amenorrhea, facial hair, with a Ferriman-Galway score of 21, total testosterone of 464, again tumoral range, DHEAS normal, but 17-hydroxyprogesterone which they did was 11.2 nanogram per ml. Now, sometimes when you're thinking of ovarian sources of tumors, you can have an elevation of precursors, which doesn't necessarily mean that there is CAH underlying. So this was the thought process with the treating team. Went ahead and got an imaging done because we need to find out where the testosterone is coming from. They found a lesion in the ovary, underwent further evaluation with other markers, underwent a surgery, and the diagnosis was Sertoli Leydig cell tumor of the ovary. So this is also a rare cause of hirsutism in younger age group women. After surgery, many of the parameters settle down except for 17-hydroxyprogesterone. So they made a diagnosis of non-classical congenital CH along with an ovarian tumor. After this, when I went back and reviewed, there is an increased risk of ovarian tumors in women who have CAH treatment or who have NCCAH. So this is also something that we need to monitor. During CAH, we are replacing steroids and monitoring the testosterone levels. If there's a sudden spike or if there's sudden worsening of virilization, maybe we should consider this. So another woman, 23 years of age. Now the audience is very, I think, tuned to this. She presented with very minimal hair growth on the face, and this is how she looked. Okay, and then this was her photograph, let us say 2 years ago. Would you like to know any other information? Do we have any diagnosis? A full physical examination revealed Cushing's, right, very good, yeah. So Cushing's is an important cause of hyperandrogenemia and hirsutism as well. So that's exactly what happened here. So the complete examination was the only thing which revealed the diagnosis, and then we went on to biochemically confirm it. We also noticed that she had hyperglycemia and hypertension, and all of this was over 2 years, that's all. And investigations revealed that her 11 p.m. midnight cortisol is high. Normally, in the middle of the night, your cortisol levels dip, and then after you give exogenous steroids, your own steroid level should actually come down, but our patient was unsuppressed and the ACTH was high. We made a diagnosis of ACTH-dependent Cushing's, and she underwent a pituitary surgery, following which her hirsutism improved and her cycles resumed, and her hypertension and diabetes resolved. So this is, she had many features of Cushing's syndrome, but sometimes the presentation can be mild. This is a 37-year-old software engineer. She was very clear that she's having unprovoked weight gain. She's saying, nothing has altered in my life, but I'm gaining weight. And she noticed increased hair growth and pigmentation. All three were her observations. And she was really adamant about getting a full evaluation done. So although she had no other features of Cushing's at all, no striae, no diabetes, no hypertension, nothing at all, but the evaluation did reveal that she had ACTH-dependent Cushing's, and there was a very small lesion, a 4 mm lesion in the pituitary, and then post-surgery, we noticed that her hirsutism and pigmentation settled down, and then she became a eucortisol. So even a mild hirsutism can sometimes be the first presentation. Usually diagnosis of Cushing's is missed for years. So probably we need to keep our eyes open and listen to our patients a little more. This is another young girl who presented with oligoamenorrhea for 4 to 6 years with acne. Notice that she has acanthosis around the neck, but her BMI is only 20.6 kg per meter square. We don't expect acanthosis in a person whose BMI is normal, and the hirsutism score is also 16 by 36. So this is a red flag here, that there is acanthosis in the presence of normal BMI. So this is a rare condition in which you have an abnormality at the level of the insulin receptor, because of which you have insulin resistance and acanthosis, and they can also present with hyperandrogenemia with the same symptoms. It's important to identify this because they are at increased risk of metabolic conditions like diabetes, steatohepatitis, and fatty liver. So if you find acanthosis in a girl who's normal BMI, although lean PCOS is a common condition, this is also something that needs to be flagged off and maybe referred to your neighborhood endocrinologist. So quickly to summarize, all women with hirsutism need a detailed clinical evaluation, which includes a detailed menstrual history, acne, androgenic alopecia, body contour examination, breast, scoring of the hirsutism, and presence of clitoromegaly. Earlier, the older guidelines said only do a testosterone level when the hirsutism score is more than 8. That's what the previous guideline said. But there is evidence to show that the score on the modified Fermat-Galway does not correlate with clinical conditions. The severity of hirsutism does not correlate with the underlying cause either. And some women might not have hirsutism at all, although their testosterone levels are very high. That is because there is a difference in the level of the sensitivity of the androgen receptor at the level of the skin to the androgen. So all women who present with hirsutism, even if it is 2, 3, 4, I think for our population, we should get an 8 AM testosterone level done according to the new guidelines. And suspect an androgen secreting tumor if testosterone is greater than 200 nanogram per deciliter, suspect adrenal source of DHAs is greater than 800 microgram per deciliter, and onset and progression are important. So if you're taking a look at the overview of the causes of hirsutism, 80% of hirsutism is likely to be PCOS. And probably the next most common is idiopathic hyperandrogenemia, where we don't know the cause. This is my last slide. But the sinister causes are some ovarian tumors, some adrenal tumors, congenital adrenal hyperplasia, and maybe even Cushing's syndrome. And those are the things that we need to pick up because the treatment of it is completely life-altering. So in a few weeks from now, we are holding Endocrine Society Satellite Symposium in Mysore. It's a beautiful city and it's a great time of the year. I welcome all of you. The theme for the session is pragmatic endocrinology. And thank you so much, ma'am.
Thank you, Dr. Chitra, for nicely describing the various causes of hirsutism in a nutshell. Can I have one question? So, what is the best permanent remedy you will advise for an adolescent PCOS hirsutism?
Ma'am, this is completely outside the purview. The organizers will burn me with their eyes. He's burning me. Yeah, ma'am, we'll discuss it later maybe. Yeah, thank you, ma'am.
morning to all of you, and it gives me great pleasure, and I want to thank the organizers for this opportunity. And how do we assign a sex? When a baby is born, we just look at the external genitalia and we say this is sex of the baby. But I don't think for some it is that simple. And recently in the newspapers for the past 3-4 days, what you read is there is an international player which is fighting out for her rights, saying that she has to compete in the female group. So that is the complexity of the situation. And many a times we know about the genetic sex of the baby, we know about the genital sex of the baby, and sometimes even the psychological sex of the baby, now that the transgender group is a legal sexual group by itself. So now we have Dr. Shruti Chandrasekharan here to tell us what it means to be the endocrinological sex of an individual. And she's an American board, the previous slide. She's an American board certified endocrinologist and diabetologist and consultant endocrinologist at Rela Hospital and the IIT Hospital, and affiliated to the Endocrine Society of Tamilnadu and Puducherry, and as well as the American College of Physicians. And it's nice to note that she's been the best outgoing student from the Kilpatrick Medical College and also from the University of Maryland, Baltimore. Over to you, Shruti.
Thank you, ma'am. A very good morning to one and all, and thanks Trendo team for having me here this morning. What I'm going to be doing for the next 20 minutes or so is talk on the endocrinology. I'm going to talk about gender in a different perspective today and talk more on transgender care and what we do in our practice in the field of transgender medicine. I have no disclosures for this talk, no conflict of interest. The photos that I will be displaying are the photos of my patients. I have used them with their permission, so the photos are all used with permission, so please don't click photographs of that. I would probably request for that. So I'll start with, before I move to the transgender care, I want to start with 2 or 3 clinical scenarios to understand what we are actually discussing today. So we'll start with clinical scenario 1. So this is a 32-year-old girl. She's brought to her family physician. Most of the time they don't come to endocrinologist or gynecologist. They have a family physician whom they go to because she's not interested in marriage. So usually they listen to the family physician. So the family takes her to them. And no medical history, not on any other, nothing is normal examination. So on further questioning and talking to her, she says that she's interested in female partner and currently having a stable female partner, which the family is not aware, and she's not ready for the marriage. So the basic cause here is she has a stable female partner here. So here, this is not a transgender. So this is just a sexual orientation. She's a normal girl, identifies herself as a girl, and she has a female partner. So sexual orientation is about who you are attracted to and you feel drawn romantically, emotionally, or sexually. A lot of times this gets confused when the parents bring their children or, they get referred to family practice. So it is important for us to understand the sexual orientation of gay, lesbian, once you talk to them, you sort of get an idea of what the sexual orientation is. People can be bisexual. It is important to understand people can be asexual also. Even in transgender care, when we talk about the sexual history, a lot of them are not sexually active, right? It's okay to be asexual, which they call as an ace, no sexual attraction whatsoever. And some people would be just questioning or curious where they're unsure about their sexual orientation, or can be gender fluid as well. They could change from one gender attraction or the sexual orientation to the other. So when we see this, when we get the history from the patient, this is a very simple diagram that you can actually get it from online. I have this printed out and I explain it to the family because now a lot of these kids or, the adolescent group or college students are brought in by their families. So we generally explain that this is just a sexual orientation of what your girl is. It's either heterosexual, bisexual, or homosexual, and this has got nothing to do with transgender. So I want to start with a very basic case of sexual orientation before we go to gender identity or how you gender express yourself. So with this, I will move to the patient number 2. This is a 21-year-old Chennai student. Biological sex is female. Identifies as a boy. So this is completely different from the first case that I showed you. Boy, for as long as he remembers. So when we see this, using the right pronoun is important. I know the patient sitting in front of me is she. She could be she, but she identifies herself as a he, and I need to use the right pronoun. I need to go by whatever they want themselves to be called or how they want to be addressed and etc. So here, identifies as a boy for as long as he remembers. Not sexually active, no partner, but he's bisexual. No obvious medical or psychiatric illness. Family is based out of Trichy. Dad is a lawyer, quite influential person in Trichy. Clear treatment goals. She says he wants to transition to a male. That's all. That's why he has come to see me. So the question is, how do we proceed? So this is what is called as gender identity or transgender. A cisgender is biological sex, unidentified sex matches for most of us. Gender identity is a term used to describe the person's sense of being male, female. It could be neither. They will not identify themselves either sex or a combination of both. So you can go by the different names like transgender, transsexual, non-binary, eppadi vena kuppalam. Like transgender men is identify as men, recorded female as birth, like this patient that I showed you. Transgender women, I have another patient of mine I'm going to show in the next few slides, identifies as a woman, recorded male at birth. Male, but they want to be a female. So what do? First, they identify themselves as a different sex. They express or communicate. They could communicate to parents, they can communicate to friends, or they could communicate to their partner as well. So they come out with a gender identity. And what as clinicians or endocrinologists, what we try to do is align the physical characteristics with the expressed gender, transition, or whatever, what we call as a gender affirmation care. So we call it as a gender affirming hormone therapy or a sex reassignment surgery. So the question comes whether this is a mental health disease or an endocrine disorder. The simple answer is it's neither. Neither a mental health disorder nor an endocrine disorder. So we don't know what is going on. But it was initially called as a dysphoric condition, but it is not a mental health disorder. So I want that to be a very important take-home message. You know, we don't stigmatize these people. So we call them as a gender incongruent, and it's not gender dysphoria anymore. No endocrine or hormone causes are identified for transgender people. And we don't know why it happens. There's a lot of theories, but they think it's biological programming that happens at birth. Families' question is, from family's perspective, I can empathize from them, but I will not be able to answer, I don't think any endocrinologist can answer that to a point. So how do we diagnose? The desire to live and be accepted as a member of opposite sex, ready to accept hormone or surgical procedure. It should be at least present for 2 years, but most of these people that we see have been living this life for years together. The disorder is not a symptom of any. This is another important take-home message. It should not be a part of genetic disorder, or it should not be a part of DSD, like androgen insensitivity syndrome, 5-alpha reductase, and genetic problems. They're all normal biological people who identify to have a cross-sex hormone therapy. So what we see in practice is 25 to 30% of them are denied treatment. A lot of times, I also do some general medicine, primarily because of the reason I need to keep in touch, because a lot of times when they go and see doctors for even common cold, they get blamed for being on hormones for everything that happens in their life. So 25 to 30% of them are denied treatment, and they don't approach the doctor for the fear of discrimination, and there is a strict no for conversion therapy. Nariya parents, they will bring their kids and say, இவங்களை எப்படியாவது திருப்பியும் ஃபீமேலாகவே மாற்றிடுங்க, திருப்பியும் மேலாகவே மாற்றிடுங்க, எங்களால் எதுவுமே முடியாது. We cannot do that. And the Supreme Court is very clear, if you have seen the paper, the ruling last month which came out, very strictly against no for conversion therapy, and doctors who do conversion therapy in terms of hypnosis or whatever will be prosecuted according to the Supreme Court. They do have a higher percent of mental health disorders, suicidal ideas, substance abuse, metabolic disorders, malignancy, primarily because they don't get the necessary follow-up like the other people. So this is a patient who I showed you, biologically female. Or once you see them 2-3 years, you cannot distinguish. You cannot distinguish whether that person is transitioned or not. And a lot of times we see in both men to female and female to male. If we do the hormone therapy and follow them up and educate them on regular follow-up, the transition can be very beautiful. So this person was evaluated by a mental health professional. That's the first step. Most of the countries can have an informed consent and start treatment. But India, they have to be still evaluated by a mental health professional for the assessment of any other conditions. Family support is encouraging. Now we are seeing a lot of the social media is also helping in ways of, educating the family that, and kunja family members are coming forward to help people who are undergoing transition, which is a welcoming change that we see. We get a baseline investigations of testosterone, metabolic profiles, so that once we put them on testosterone therapy, we follow them up. So inga vande very simple. For a female to male, we put them on testosterone. Testosterone is a very potent hormone. Once you put them on testosterone, within like 3 to 6 months, the periods stop, the voice changes, you see a lot of changes like male. We don't really need anything else, right? And we follow them up every 3 months. So this is the changes that happens over, you can see the onset to maximum years of what happens, how in terms of voice change, vaginal atrophy, deepening of voice. As I told you, sometimes my receptionist will not be able to identify these people when they come 2-3 years, ma'am. Avangala ipdi aitanga. So it's very natural, the transition is. But this sort of duration will be educated to patients when they undergo the cross-sex hormone therapy or the gender-affirming therapy. And we also monitor them. It's not like I start them on testosterone and not monitor them. So we make them come every 3 to 4 months in the first year, monitor their hemoglobin, make sure the hematocrit does not go up. Polycythemia as a risk factor, is something that we see with testosterone preparation. We adjust that. And usually routine screening for osteoporosis is not required because most of them are hormone therapy. Only if they withdraw the hormones, I do evaluate for bone osteoporosis and other conditions. And these are some of the trans men, we call them men, who are in different phases of transition. So these are periodic groups that we do, educating them about, it's sort of easy to educate as a group to tell them what they can expect out of hormone therapy and when they should come and meet us. So Avangala, they've been on hormone therapy for 3 years. They are running a transgender activist group called Trans Masculine Foundation. They've been helping a lot of people. It's a very close-knit group. They help each other, even financially. One helps the other, supports them until they find a job or give them place to stay. Sometimes when the parents don't agree to this and when they run from the family, they have a place to stay and they're provided food and everything. So we do have these periodic groups where we do the education part as well. So I will move on to patient number 3. So that is a trans man, the case that I showed you. I'm not showing you the detailed process of testosterone therapy because that is something that would be beyond the talk for today. So this is a 22-year-old male, internship in a private medical college, gender incongruent, identifies as a girl. So she's in a final year medical college right now. She wants to have a slow transition. She wants to come out of the medical college and then, have the transition process complete. So that's the beauty of hormones. We can dose it according to how they want it, how soon the transition is required, how we will monitor the hormone transition in a way we give them the hormones accordingly. Normal pubertal development, no other. Again, similarly bisexual, no stable partner, occasional smoking, no alcohol or no drugs. So this is a patient, this is the patient who is currently 3 years of hormone therapy, the same patient that I showed you in the clinical case. As I told you, it's very hard to distinguish after transition. So all these 3 years, this lady has been only on anti-androgen therapy and estrogen. Only last week she went for an orchidectomy, right? Even without orchidectomy, and she was also on GnRH analog. So she did go through a couple of treatment, blocked the testosterone, and this is how she looks now. This photo was taken before the orchidectomy. And in trans women, the major thing that we use is anti-androgen. The most common thing is aldactone, which works very well, gives them this contour, the breast shape, gives them very nice skin and glow to the face and hair growth on the scalp. Along with that, they also meet dermatologists, go for laser therapy, whole body laser, or depending on where they want facial hair reduction. And this person who underwent the hormone therapy was also on GnRH injections, started monthly once to completely block the testosterone, and then later on switched to 3 monthly GnRH. Now, since she had orchidectomy, I would stop the GnRH and aldactone. I would only continue estrogen therapy. So she is also on estrogen. The usual dose of estrogen that we use in transgender care is up to 8 milligram, which is quite different from the normal premature ovarian failure or the other conditions of estrogen. Here we do a very graded upgradation of estrogen. We do educate them about the risk of venous thromboembolism. Even though luckily I have had some of my colleagues who have seen thromboembolism. So we go in a very graded manner. I usually ask them to avoid any over-the-counter estrogen supplements or anything that they could do other than the one that I'm prescribing them. And we usually ask them for a smoking cessation because that's also something we see a lot. Ask them to go for smoking cessation, educate them the danger signs for thromboembolism. But the maximum estrogen that I've used in her is about 6 milligram. I have not gone up to 8 milligrams of estrogen in any of my patients because I'm very scared of thromboembolism. But with 6 milligram is the transition that we see. And as the trans men, even in trans women, we do periodically monitor them in terms of the estrogen, prolactin levels, making sure that we're not doing over-toxicity or giving them a higher dose causing side effects. And we do have a published guideline from Journal of Endocrinology. Our guidelines are there from Endocrine Society of how to monitor them and what frequency. We do educate them during the follow-up. So this lady doctor now, she's on anti-androgen. She went for GnRH, estradiol. We do measure the estrogen level and total testosterone. Now that she has done orchidectomy, I don't have to worry about the total testosterone level. Voice treatment. In the transition, the voice will never change. She will look very feminine, but the voice will be still male. But in the other transition, the voice changes beautifully. After 3 months, when you talk to them over phone also, you will not know whether it's actually a she who has converted to a he. Here, the voice treatment has to be undergone. We need an ENT surgeon for vocal tracheal shaving and voice speech therapy for voice treatment. A lot of them undergo that procedure and go for a self-voice treatment. They will need a lot of other cosmetic procedure, but this person has not undergone any reconstructive surgery. All she has done is laser therapy for her face, and she was on anti-androgen and GnRH, but she has not even done breast augmentation surgery. Some of them go for silicone breast implant and also go for sexual reassignment surgery. So I have about 3 minutes more. So I have last few slides. With this, I'm done. So the treatment for transgender, as I told you, it's not everything for everybody. We don't throw in everything that I showed you in the slide. Like, for example, we don't offer all these things to a particular patient. It takes a lot of time from my perspective to actually talk to them and understand what they want. ஒரு சில பேருக்கு வெறும் ஐடென்டிட்டி சேஞ்ச் மட்டும்தான் வேணும். Just call me, like for example, don't call me Ovia, call me Ovian. That's all they want. They don't want hormones, they don't want sex reassignment surgery, எதுவுமே வேண்டாம். வெறும் ஐடென்டிட்டி சேஞ்ச் இருந்தால் போதும். So we respect that and we do only identity change. We don't put them on hormones or ask them to come for follow-ups and etc. Some transgenders want only hormone therapy and no surgery. So this person went orchidectomy, but a lot of them don't go for orchidectomy, right? So we are aware of what is left anatomically so that when that particular person crosses 40 or 45 years, I know I need to do cancer screening. None of these hormones increases the risk of cancer. We are just putting them on cross-sex hormones. But we start doing age-appropriate cancer screening, how we regularly do for men and women. And the madri, we do routinely screen with mammograms. If prostate is left, we do get a PSA. I don't have that old patients. I don't have much experience in terms of cancer screening. But I'm telling you, if the anatomical part is left, we do go for cancer screening as well. Even in surgery, they prefer what they want. Some trans men only want mastectomy because they get socially abused in the workplace. So adanal a lot of them go for mastectomy just to reduce the risk of abuse in the working condition. And some of them don't go for hysterectomy or oophorectomy. They don't go for any other procedures. Similarly, in SRS as well, in trans women, some only go for orchidectomy. They don't go for any other plastic procedures. So even in surgery, it's totally up to what they want. It's not like what we offer to them. And most of them are well educated. They know how to go for treatments, etc. So the question is how long to continue gender affirming treatment? Usually until the age of menopause. natural menopause or natural andropause. That's one way of looking into it. Somebody is around 50, I don't have that old patients. I would talk to them and say that now it's a time to actually stop, because you would go for anyway a natural biological menopause at this age. But again, if they are ready to continue, you can continue it. Some guidelines say even 55, 58 with close monitoring of the metabolic condition. So my overall experience with transgender medicine, with this I finish. There is an improvement in psychosocial measures after gender affirming treatment. A lot of them do very well in society. I have lawyers, I have police officers, I have activists. A lot of them do really well socially after they undergo transition. Psychologically, they do a lot better. Not all transgender people seek all interventions. Some may seek none. As I told you, they want only gender identity. In contrast to past practice, when I was in endocrine training in the university, we used to have 1 half a day dedicated for transgender care. We used to do psychological assessment, hormone surgery. That pathway is no longer there right now. They can pick and choose what they want. The current standard of care is to allow each transgender person to seek only the intervention which they desire to affirm their own gender identity. So with this, I finish with this quote. Usha also showed this quote yesterday. The 2 most important days in your life are the day that you're born and the day you find out why. I think the practice of transgender medicine is something that I really enjoy doing, even though it's a lot of work, and it probably probably tells me the reason of why I was born. Thank you.
That was a beautiful way of putting the thoughts of a transgender person and how you approach them clinically. Hats off to you, Dr. Shruti.
Thank you.
And I just have one question. See, halfway through the program, if somebody decides to undo that, is there a way they can come out of it? And second thing is, have people faced any medico-legal issues because the treatment didn't work or something like that?
I'll answer the first question first. Most of them are very clear of what they want, so the backing of the treatment is very rare. But if they do want to, with hormone treatment, yes, they can. Because I didn't talk about fertility preservation because I didn't have time. So I have a patient who went on hormone therapy, and after 6 months, she said, I want to store my ovum. So she actually went for a gender egg retrieval in Erode, in gynecologist in Erode did the egg retrieval for her. So him. So we stopped the testosterone for 3 to 6 months. The cycle resumed, the ovulation happened, and fertility preservation was done. So yes, with hormone therapy, you can reverse the changes that you have gone through. With surgery, we know it's irreversible change. So usually that's why we don't push for surgery. The guidelines say the surgery has to be stopped only after 2 years of being on hormone therapy, just because it's irreversible. With hormone therapy, it's reversible. If somebody says, I don't want to transition, we respect that and we stop that, and most of the changes would reverse back. Medico-legal, yes, we have heard in papers and stuff. Personally, I have not encountered, thankfully. But there is a lawyer. There are lawyers who work with the association. They do help them with medico-legal. You mean for the doctors or for the?
They wanted a particular level of identity for themselves, but medically it couldn't be achieved.
So you mean with the name change and everything?
No, physically. So they must have an image of themselves, like just how the plastic surgery people feel, like that kind of.
I have not come across, but we have read news about that. But that's where a lot of counseling is required. Even when we go put them on hormone transition, we tell them what to expect and how long to expect. And I usually tell them that I cannot promise this particular time. We do have all these conversations before. But yes, we have heard from the group that there are issues with medico-legal cases with surgery and even hormone treatment for that matter.
We are very cautious about using hormone therapy, especially estrogen in postmenopausal women, not even going up to 2 or 4 milligram. Now, have you encountered any complication with such a high dosage for a longer time?
Ma'am, longer time, I don't know because I don't have that long patience. So even Gavanda, she's been on, I have patients who are on 3 to 5 years of estrogen. The maximum that I've gone is 6 milligram. I don't go up to 8. But usual dose is 4. I don't go beyond 4 mg of estrogen. Thankfully, as I told you, I have not had any thromboembolism, but I've had colleagues from other states who do transgender care where they have experienced thromboembolism and stroke with estrogen. So, I mean, when they do get into this gender-affirming therapy, we do educate them about everything. We tell them there is so-and-so chance, this can happen, we need to follow you up, we need to get the estrogen level, any signs of discomfort you have to let us know. So it involves a lot of talking and educating them up front. But I'm not saying we don't have risk. There's certainly a risk of thromboembolism with estrogen.
But Shruti is again regarding usage of estrogen only. Which estrogen do you prefer?
I can tell you the brand name, Takkanjari. Progainova is what I use.
Okay, but thing is, if you are using a equine estrogen, we can measure it in the assay. We can assay estrogen. And in your talk, you were telling that we do measure estrogen.
I do measure,
but when
yeah.
Pregnova or when this one is given, it won't be detected in the assay, right?
It is detected.
Okay,
Yeah.
okay.
I have never used. I'm sorry, I can't tell the generic name Takkan. Don't mistake me. I have never used Premarin. I have used only Progainova all these years.
So
and I check estrogen and I see the detectable level in the female range. Levels on the 145, 150, and the mid-normal female range level. It's not like it's not detected. I titrate the Progainova dose looking into the estrogen only.
Okay. Is there any role for monitoring testosterone in such patient?
No, aldactone podumbodhu, there is no much of difference in testosterone levels. It doesn't come down. Only the changes happen. But with GnRH, if that person, the doctor patient I showed you, she was on GnRH. She had a very low level of testosterone even before she went for orchidectomy. I do measure the testosterone level not for the alter, just to let them know where they are and everything. So I do check the testosterone level also and keep it in the female range. If they're on GnRH, less than 70, as Chitra said, in the female range. But after orchidectomy, I stop aldactone GnRH and I don't check testosterone levels.
And regarding that estrogen, even for menopausal hormone therapy, we prefer 17-beta estradiol over this equine estrogen because of a lesser side effect on liver. That's the preferable one. Thank you very much, both the speakers, for excellent session.
Thank you very much.
Thank the audience also.
Ma'am, for the fantastic session. So actually we've gained 15 minutes. We're still 30 minutes behind schedule, but thank you very much for that fantastic session. So can I request the speakers and the chairpersons on stage, can I request Dr. Anjali Satya to felicitate them, please? Chairperson. So thank you very much. We move on to the next session, which is symposium number 13. Can I request chairpersons, Professor Dharmaraj, Professor of Medicine, and Dr. Ramanathan, consultant physician, onto the stage, please.
As we are running short of sessions and we have 3 speakers in this session, let me call Dr. Vignesh, endocrinologist from Trichy, to talk on pitfalls in hormone measurement. Over to you, sir.
Good afternoon, everyone. So let us move on to the most important session, that is pitfalls in the hormone measurement. People think it is a theoretical topic, but what I feel it is mostly a clinical topic. So most of the time we do use our clinical judgment and lab correlation for managing our patients. So when there is some errors in the lab, we need to be able to identify the errors and to change the clinical decision. So we all know the quality control labs use various quality parameters. There's internal QC or external QC, what we call as quality assurance schemes for routine testing to identify the errors. So any form of interference, either it can be external interference or internal interference in the lab assays that leads to incorrect values that can lead to incorrect decisions. So clinicians should be alert that all immunoassays, either it can be chemiluminescent immunoassay or it can be a radioimmunoassay, that can produce error in its reports. So we need to identify if it is not matching our clinical decisions. So lab errors can be classified as, it can be a pre-analytical error, that is before the test is done, or an analytical error, that is test in the assay, or post-analytical error, so it is in the manual entering of the reports. So coming to the pre-analytical error, so it is happens when this starts from the identifying the patient and collecting the sample. So wrong timing of the sample is very common in hormone samples. So most of the hormones undergo the circadian rhythm. So for example, cortisol, testosterone, these samples has to be collected early in the morning. Suppose if these samples are collected in the evening or in the afternoon, we may have a falsely low levels. So timing of the sample is very important in hormone assays, and timing of menstrual cycle. Most of the hormones, FSH, LH, 17-hydroxyprogesterone, all we do in the early follicular phase, first 5 days of menstrual period, because the reference ranges varies for both follicular and luteal phase. And incorrect specimen, interchanging plasma and serum can cause error reports. Unstable specimen or proper stability of the specimen. Most of the peptide hormones, for example, PTH, ACTH, C-peptide, which we do in clinical practice, are stable in the cold temperature. So if they are taken in the room temperature, they are prone for lysis. So I can show you the examples. The next comes is the analytic error. This error can happen with incorrect calibration. So every machine has a calibration with standard, and which is checked by the control. So when there is a error in the standard, and when there is an incorrect calibration, that leads to incorrect report. And there can be error can occur from imprecision or background interference, what we call as impurities, or endogenous drugs. Suppose somebody has drugs, that's what the earlier speaker described. Somebody taking estrogen, it will interfere with the estrogen assay. Somebody taking hydrocortisone or steroid, prednisolone, it will alter the values of cortisol. So we need to look at that. And high dose Cook effect, this happens with prolactin. I will describe with case examples. And post-analytical, so when the test is done, so the assay is performed in the machine. So what happens? The lab technician see the value in the report and enter into the software to produce the reports. So if they enter the wrong value or wrong unit, so this is what we call as post-analytical report. So nowadays these post-analytical reports are usually reduced by interfacing. So they directly connect the assay machine directly to the reporting software. So the manual entry is often avoided, so interfacing, because of the interfacing. So what are the outcomes? So abnormal reports or wrong reports, either it can be pre-analytical, analytical or post-analytical, all leads to either elevated value, low value, so which we based on the which we take clinical decision, so which will affect the health of the patient. So most importantly, in a pre-analytical error, so sample collection, this is very important in hormone patients. So when we do estimation of insulin, C-peptide, or ACTH, PTH, these are all peptide hormones. The peptide hormones, normally there is an enzyme called peptidases in our blood, plasma. So this peptidases is the lysis hormones, so the patient will get low levels. So for example, if you send a patient for a C-peptide, ACTH, PCH to a lab, so if they collect in the room temperature without maintaining the ambient temperature, we will get a low report, so instead of a normal value. I will show you with the example. So this is one of the young diabetics who was labeled as type 1 diabetes because she presented with severe hyperglycemia and ketosis, not acidosis. So she was started on basal bolus insulin. So multiple subcutaneous insulin, 3 units of regular and bedtime lantus. So what happens, so for etiological evaluation, she undergo C-peptide, fasting and postprandial, which came as low. So she was labeled as type 1 diabetes. So she was advised lifelong insulin, that to basal bolus. So, but clinically, she was obese. She doesn't so though she had ketosis, there was no acidosis. And she had clinical markers of insulin resistance, acanthosis nigricans. So I suspected there should be some clinical discrepancy between the lab and the clinical features. So I repeated the C-peptide in the standard precaution, in the fasting, in the cold chain. We have to we should take in the pre-chilled syringe, the ambient temperature, and put it in the ice and transport the sample in the ice. And if the laboratory, they are processing immediately, they can process, or if they are going to process once a week or twice a week like that, they have to store in -20 degree. Many of the small laboratories may not have -23, 20 degree deep freezer. So if any one of the steps is missed, the C-peptide will become 0 or low. So, and the diagnosis will change. So I repeated, it came as high, and this patient is probably a type 2 diabetes mellitus with clinical markers of insulin resistance. I tapped and stopped the insulin. She is well controlled, sugars only with vildagliptin metformin. So this is how it affects the patient care. And this is an article published about the stability of C-peptide and insulin in room temperature and cold temperature. So we can see the red one is a serum oil and violet is a EDTA. There is a progressive fall in the peptide hormones level when it is left in the room temperature. And over a period of hours to weeks, so if it is not processed immediately, if it is not stored in, not taken or stored or transported in cold chain, there will be loss of peptides. So it can happen with ACTH, it can happen with PTH. So we'll get a wrong report. If we expect a high PTH or high ACTH, instead we'll get a low PTH and low ACTH if it is not taken or transported in the cold chain. So coming to the immunoassay. So most of the hormones nowadays we perform with immunoassays, what we call as E-CLIA or CLIA. So immunoassays basically uses a principle called antigen-antibody reaction. So normally they have a measuring cup where it is coated with a capture antibody, and what we measure is an antigen, usually a peptide, prolactin, FSH, LH, or analytes or antigens. And we have a capture antibody, and we have a detection antibody, which is tagged with biotin. Biotin is nothing but vitamin B7. So vitamin B complex, most of the vitamin B complex preparation will have biotin. And this biotin, why it is used? Because it can bind to luminous complex, what we call a streptovidin horseradish peroxidase. So this will, on stimulation, this will reduce light. So the light energy is picked up by the luminal detector, and this is how we record the concentration of the analyte. So what are the interferons? There are two types of assays. It can be a competitive assay, or it can be a sandwich immunoassay. Sandwich immunoassay is basically for large molecules like TSH, and competitive is for small molecules. So what happens? So whenever there is an impurities or there are external factors that can alter these antigen-antibody reactions, either if the excess of biotin by vitamin supplements or an antibodies that can happen because of viral infection or asymptomatic, even general population can have an anti-heterophil antibody or anti-streptovidin antibody. See, any antibodies present in excess can to some extent affect the values of the patient. So I just put one problem. Biotin problem is very common. So anybody who is on biotin and high doses can develop altered reports. So normally interaction with the streptovidin and biotin is utilized for immunoassays. So these immunoassays are susceptible for biotin interference. There are some immunoassays where their biotin is not used. So whenever we have a doubt, we need to repeat the sample with the non-biotin immunoassays. So the patient on biotin can have even elevated or wrong values. So biotin can interfere with the sandwich immunoassay or competitive immunoassay, alter either increase the value or decrease the values. So it can alter any platform, Roche or Siemens or Beckman. So these three are the most commonly used immunoanalysis in our clinical setup. So biotin can alter the T4 and TSH values. So what to do? So when you suspect a biotin, so generally we keep on increasing when the patient is on biotin, the lab gives TSH high. Whenever you keep on increasing the thyroxine to 200, 250, at last 300, and TSH is still not suppressed. We have we inquire compliance is good, and we have crossed weight-based dose. There is no clinical evidence of malabsorption, and patient is not missing any dose. So why even we are keep on titrating the thyroxine, and TSH is not coming down? So always suspect then biotin. So in which case, hold the vitamin tablets or a biotin-containing tablet for 3 days and repeat it, or you can put it in dilution. So if you dilute the sample by 1:10, the biotin levels will come down, and we can multiply the analyte levels into 10. Or you can use a different assay which does not use biotin. Or there are some manufacturers, they do have the biotin depletion protocols. So only thing we need to aware of such biotin can interfere with immunosis. So these are the case reports that have been published, how the biotin leads to wrong diagnosis. So there are case reports where a normal patient been diagnosed as Graves' disease because of high T4 and low TSH, or diagnosed as hyperparathyroidism, Graves' disease. And there are some biotin assay where they found high testosterone and high beta Hcg that leads to a wrong diagnosis of testosterone secreting tumor. All these leads to clinical implications, clinical decision making. So when you suspect there is a discrepancy about lab parameter and the clinical parameter, always repeat in a different platform or go for a dilution and after withdrawing the biotin. So it can alter any parameter. So these are the list of parameters, all the hormones. The most important thing is if it is an elective OPD patient, we can always call them after a couple of weeks and repeat it. But it is an emergency, like it can alter the troponin T, it can alter the BNP. So where we need to make a clinical decision making. So whenever your lab parameter is not matching the clinical parameters, always try to think about biotin and try to repeat in a different platform. So this is a case where the biotin, where I have seen recently, this is a 32-year male with history of infertility and decreased libido and erectile dysfunction. And he does not have any chronic medical illness. So examination is tall and testis was small, is 8 ml. Normal testis is 10 to 25 ml. And pubic hair was P3, that is Tanner stage 3, and axillary was present, and there was no gynecomastia. He was referred for evaluation of infertility and erectile dysfunction. So hormone test was done. So FSH-LH was high, and testosterone is very high, and prolactin was normal. Some analysis already done, it was showing azoospermia. So clinical impression was high testosterone, high gonadotrophin. So AIS, androgen, partial androgen or mild androgen sensitivity was made. But the patient was already prescribed all antioxidants for azoospermia by an infertility center. So I had when I see the when the testosterone was high, when I see the clinical scenario, it doesn't look like androgen sensitivity, because androgen sensitivity usually have normal testicular volume, and generally they don't have axillary and pubic hair, and usually they present with gynecomastia. The clinical scenario is not matching with the lab report. So I stopped the biotin supplement for a few months, and we repeat the testosterone to come as 200. So initially, it was 1,200. It was reduced to 200 after stopping the vitamin supplements. Now the diagnosis is low testosterone, high gonadotrophin. This is hypergonadotrophic hypogonadism. The diagnosis is Klinefelter syndrome. So treatment is entirely different for Klinefelter syndrome and androgen sensitivity. So we have to suspect the assay. When your clinical features are not matching with the lab assay, always feel free to discuss with the biochemist. If possible, we can repeat it in a different platform. So next comes the most important thing for during estimation, that is heterophile antibodies. These are the antibodies can present up to 40% of general population. It can occur after a viral illness or an infectious mononuclease, that is Epstein-Barr virus infection. But generally, these don't interfere with immunosis, except in rare situations like 3% of cases. So heterophile antibodies are suspected when there is a discrepancy between clinical and lab finding. It is mostly with thyroid assays. We keep on increasing thyroxine dose and TSH is not suppressing. Or we have started, the patient is appearing euthyroid and the TSH is extremely high or a T4 is extremely low. So when the patient is clinically normal or clinically euthyroid, but the lab shows different thing, always suspect these antibodies. So this can be a blocking antibody or it can be a stimulating antibody. So these are the case report published where they found there is an increased TSH on biopsy, but on assays, and the patient were titrated with the thyroxine. At last they become thyrotoxicosis, and they identified this problem with the lab, and they compared. And the most important thing, we need to do a sample in dilution, or we need to change the assay method. Instead of Usually they use anti-mouse antibody. We can change it to a different platform where they use anti-rabbit antibody. So we should change the assay platform and then decide on things. Next thing is, most commonly we come across changes in prolactin. In prolactin, the assay principle is sandwich immunoassay, where the two antibodies are used, capture antibody and the detection antibody. So whenever there is an excess prolactin, so normal prolactin is 25. So if it is like 100 or 200, it will be detected. If it is like 2,000 or 10,000, 20,000, it will not be detected in the same rate. So when there is an excess prolactin, so there will be changes in the detection. So the excess prolactin will bind to the detectant antibody, so it will be show us low value. So I can show you with an example. So for example, if there is an excess, very high excess in hormones, if it is like mild elevation or moderate elevation, it will be picked up by the assay. If there is a very high, extremely high elevation, normally the dose concentration is proportional to signal. So over a period of concentration, when there is a progressive increase in concentration, the signal reduces, what we call as high dose hook effect. So this happens when there is excess concentration of analyte. Though this can happen with any hormones, but most commonly in clinical scenario with prolactin. So this was a patient who is a 25-year woman who was evaluated for headache and amenorrhea for 6 months. She was not on medication. Because of headache, she was evaluated by neurologists. They found a pituitary macroadenoma and the prolactin was slightly high. Normal is 25 and the patient had a 38. So she was diagnosed with non-functioning pituitary adenoma. So she came for evaluation. So I did, since there is a macroadenoma, I suspect a prolactinoma because he has an amenorrhea. So we did a dilution, it came into tumoral range, it comes around 6,000. So the diagnosis is prolactinoma and she was started on medical management instead of surgical management. So non-functioning pituitary adenoma, we should go for surgical management. Functioning pituitary adenoma, prolactinoma is medical management. So entirely treatment is changed. So this case report recently published. So where they found a prolactin level of 31 in a pituitary adenoma and they put it in dilution 1:10, 1:100, 1:1000. At last they found the value of prolactin is 2,80,000. So this is because of high dose hook effect. Very high excessive analytes, they block the antigen antibody reaction and they show a falsely low value. So next clinical scenario is macroprolactin. So macroprolactin is nothing but very big prolactins. Normally we measure monomeric prolactin. There are certain clinical scenarios, that is in 10% of individuals, where we found macroprolactin. Usually it is attached to antibody, so it has a long half-life, but they are biologically inactive. They can be picked up by the lab assay, but they don't have any effects on the any hormonal effects. So very high prolactin, patient is asymptomatic, so no galactoria, no amenorrhea, or no erectile dysfunction in males. So very high prolactin, always think about macroprolactin. It can happen in 10% of individuals. So MRI is not required in this patient. Always go for a polyethylene glycol, PEG precipitation. This is a screening test. If we precipitate the macroprolactin, we can identify only the monomeric prolactin, so original value of protein. So this patient requires only reassurance, no need for a cabergoline or no need for a MRI, no need for a surgery. So this is how the lab, so this is how the prolactin, polymeric prolactins look like. It's a big prolactin, big prolactin and monomeric prolactin. Monomeric prolactin is the one which has a biological effects in our body. The big prolactin, though it will be detected by the assay, it will not have any effects. If the patient is asymptomatic, very high prolactin, don't treat, just there are certain labs, they do PEG precipitation, you can request for them, and if you found it is a big prolactin, so no need for treatment, just reassure the patient. Just coming to the analytical interference, due to cross-reactivity, so many of the steroids, which we use clinically, hydrocortisone or prednisolone will interfere with cortisol assay. So anybody taking steroids, if you do a cortisol, it will come as high. Except for dexamethasone. Dexamethasone will not be measured by the cortisol assay. So this is what known. So what is the clinical implication? If you have a patient with suspected adrenal crisis, the textbook says take a serum cortisol and then take an emergency serum cortisol and then give hydrocortisone. Suppose if you are not in a position to take a sample for cortisol, give a dexamethasone. This is a clinical implication. If you give a hydrocortisone and then you repeat if your patient get a hydrocortisone and if you do a cortisol, it will come as very high. So because it will be detected by the assay. So that's why it is very important to know why, how the analytes interfere with the assays. So it is important to, just in this last slide, sir. So important to identify and eliminate the error. So all clinicians may alert about the mismatch of the clinical and biochemical data. So we should not be carried out by a numerical value of the lab. So it can be a error. Labs, even quality control labs can give an error in its values. Always talk to your biochemist if you have a doubt, or if you have a doubt, you repeat it with the standard precautions. And to summarize, immunoassays are prone to interference, means errors. So correct reporting is responsibility of error. Many of the labs, they do specifically in dilution. When they get a high value, they do repeat checking or dilution values by themselves. So if they have not done, we should ask for a thing. Single testing may not be sufficient if you find an interference. Unfortunately, half of these patients with these erroneous reports go for clinical decision making, and they go for further management. So the clinicians should talk to the biochemist and the lab technicians to know how the assay is processed, whether there is any problem with the assay before go for a conclusion. Thank you.
What is the role of a lactograph axis test?
Pardon?
Yes, a lactograph axis test is a lactograph axis test in assay. Anything?
Lack of?
Lactograph axis assay. Any test is available for assessment of the prolactin?
Prolactin, usually it will be measured by sandwich immunoassay. So if you have a prolactin, it is easy, sir. If it is a macroprolactin, it is PEG. If you get for example, if it is because of a high dose hook effect, you can put in dilution. Just put in 1 in 10 dilution and 1 in 20 dilution. Most of the labs, they do either manual dilution or automated dilution. Machines, nowadays, the automated machines comes with the fully automated dilution. Just they have to press the numbers, how much dilution they require. So machines have fully automated dilution system, or you can tell our lab technician to 1:10 dilution. So that is possible.
Thank you, sir. I thought the topic was a little bit more theoretical, but you made it a very practical lecture. And so one of the take-home message of what I took from it is that when we are prescribing your hypothyroid patients, don't prescribe any B complex. Suppose they are taking B complex, ask them to wait for 3 or 4 days, then you do the routine assay of T3, T4 and TSH. That was a take-home message I took from myself, sir. Thank you for a scripted lecture, sir. So next topic to be discussed on this stage would be adult growth hormone deficiency. To deliver this lecture, I invite Dr. Usha Ayyagari, a consultant endocrinologist from Apollo Hospital, Chennai. Over to you, madam.
Thank you very much. Now, in the interest of time, I'm just going to launch into my topic without any delay. I want to start off by saying, actually, most of us will never start a growth hormone injection in our life. And I think it's more important to understand that there are certain preconditions to treating with growth hormone than, sorry, can I have my slides, please? Okay, when you project. That there are certain preconditions to treating with growth hormone, and it's as important to know when not to treat as it is to know when to treat. Now, the second thing I'm going to say is, unless you're a pediatric endocrinologist, even as an adult endocrinologist, you'll probably never start a growth hormone injection in your life. So on that caveat, growth hormone, it's a single chain polypeptide. It stimulates growth, cell reproduction, and cell regeneration. You might ask, what is the role in an adult? And we'll come to that. It affects everything from your nervous system to your cardiovascular system to your immune system to your muscular system and skeletal health. It's secreted by the somatotroph cells in the anterior pituitary under the influence of growth hormone regulating hormone, and its secretion is inhibited by somatostatin. But there are a lot of other factors including ghrelin, your gonadal hormones, leptin, and your thyroid hormones that can influence growth hormone secretion. Once secreted, growth hormone acts on the liver to produce IGF-1. Now, a little bit of basic science is important because when I talk about measurement and assays, we need to talk about IGF-1. So it produces IGF-1 primarily from the liver, but also from the brain, adipose tissue, kidney, and perhaps the skeletal tissue and muscle. IGF-1 acts on the tissues as a messenger for growth hormone activity, but growth hormone also acts locally in an autocrine and paracrine fashion in the adipose tissue and in the skeletal system and muscles. So with this brief introduction, We then come to the adult scenario. I'm not addressing growth hormone therapy in children because this is purely about growth hormone therapy in adults, growth hormone deficiency in adults. So in the adults, growth hormone is not an isolated hormone that we treat as one. If you look at growth hormone, it has quite a complex interaction with all your other pituitary axes. So growth hormone promotes the deiodination of FT4 to FT3, and therefore in growth hormone deficiency, you will have less peripheral deiodination of T4 to T3, which is the active hormone. Growth hormone also has an incredibly intricate interrelationship with your HPA axis, and a relative cortisol deficiency can be present in growth hormone deficiency. And if you have cortisol deficiency, replacing with growth hormone may unmask it in quite a severe fashion and precipitate a crisis. Women generally need higher doses of growth hormone because estrogen decreases the levels of IGF-1, and men generally need less because estrogen, androgen increases the levels of IGF-1. So it's quite complex and interrelated. If you look at growth hormone deficiency in the adults, one, you could have childhood onset growth hormone deficiency, which is going on into adulthood. You could have idiopathic new onset growth hormone deficiency in the adult. But actually most growth hormone deficiency happens because of structural abnormalities in the pituitary or cellular or hypothalamic region, or due to traumatic brain injury or post-intervention like surgery or radiotherapy. So coming to this complex interaction of the growth hormone axis with all your other axes, systemically it has quite a lot of effects. So it can affect your psychosocial well-being and neurocognitive function. It can affect your cardiovascular well-being by affecting your dyslipidemia, endothelial dysfunction, your cardiac output. It has an effect on your metabolic health with insulin resistance and abdominal fat mass. It has an effect on your skeletal health with reduced muscle mass and bone mineral density. Now, treating with growth hormone, yes, it does improve all these parameters, but the reason we don't universally treat with growth hormone is because changing these parameters hasn't really shown an equivalent improvement in your cardiovascular outcomes or mortality. So how do we look at the growth hormone in the setting of pituitary dysfunction? If you have a mass effect from a pituitary tumor, almost always the first to go is the growth hormone, and then your gonadal axis, and then your TSH and ACTH, which if you think evolutionarily is a wonderful mechanism to preserve your most important hormones till the last. And this is why isolated growth hormone deficiency is very rare, and you generally tend to see growth hormone deficiency in association with 1, 2, 3 or multiple pituitary hormone deficiencies. And this is why when you're looking at testing growth hormone, you always look at other hormones with it, because isolated in adults is extremely rare. Now, lots of guidelines, but this is the most recent and most up-to-date, the ACE guideline from 2019. And effectively, you look at growth hormone. Who do you test for? In people with hypothalamic or pituitary pathology, as we've said, structural or post-intervention, post-irradiation or traumatic brain injury, or in those who have verified childhood onset growth hormone deficiency. Because remember, in a certain small number of cases, even if it's diagnosed during childhood, they seem to grow out of it, especially if it's been diagnosed as idiopathic, and you must always reassess at the end of full skeletal growth. Now, how do you assess? I will talk to you in a minute, but in general, if you have multiple pituitary hormone deficiencies and a low IGF-1, that is enough to diagnose growth hormone deficiency in an adult. In those who don't have multiple pituitary hormone deficiencies and a low IGF, you can then test further. But the most important takeaway from this slide is, who do you not test? If you have multiple pituitary hormone deficiencies, please don't go on to test any further. IGF-1 is good enough. If you have congenital causes, so not idiopathic childhood onset growth hormone deficiencies, but congenital causes that include genetic mutations and midline defects, there's absolutely no need to confirm growth hormone deficiency in an adult. You treat as per usual protocols. But in all other cases, an insulin tolerance test is your gold standard. Here are the cutoffs. You can use an arginine growth hormone GHRH stimulated test, but usually what we go for is a glucagon stimulation test because it's well tolerated and it's outcomes are dependent on BMI, but we do have BMI specific cutoffs. The Masimorelin is quite expensive and not yet available in India. So if you look at the ITT, as long as you achieve adequate hypoglycemia, this is blood glucose levels, you actually should see a good increase in your growth hormone, and therefore the ITT is the gold standard. Now, why am I talking about doing growth hormone stimulation tests rather than just IGF-1? Because if you look at this data, this is IGF-1 in growth hormone deficient and the healthy population. Not much to choose between the two. Mean growth hormone levels over the course of 24 hours, also quite a huge overlap, as also your IGF binding proteins. But a growth hormone peak on an ITT clearly separates your healthy from your deficient individuals. And so the stimulated tests are the gold standard. Now, if you look at ease, convenience, safety, and cost, as I said, the ITT is the gold standard, but doing it is cumbersome and it is associated with certain risks to the patients, including the hypoglycemia. The glucagon stimulation test is reasonably accurate, correlates well with the gold standard. It's relatively safer than the ITT, and it's relatively more simple, and cost-wise is not much more costly, especially now that we have glucagon at 700-800 rupees in India. It's quite an affordable test. The Masimorelin, as I said, not yet available in India and very expensive, although it is an oral agent that you can use to stimulate growth hormone and correlates well with the ITT. So then what do the guidelines say about having tested, whom do you replace? In terms of guidelines, NICE are the most definitive in terms of telling you whom to treat and whom not to treat, and it's simple. If you use growth hormone in adults with growth hormone deficiency only if they fulfill all three criteria. They have severe growth hormone deficiency on a stimulatory test. They have perceived impairment on the AGDA, which is your quality of life questionnaire for adult growth hormone deficiency, and they're already receiving treatment for other pituitary hormone deficiencies. So you need growth hormone deficiency, multiple pituitary hormone replacement, and your AGDA score. Now, having started it, you reassess 3 months of dose titration, 6 months of dose stabilization, and unless their quality of life on the AGDA score improves by at least 7 points, certainly in the UK, the recommendation is not to continue replacement. Now, for people who've been started in childhood, somebody else is controlling my slides from somewhere else. Go back, please, right. For patients who develop growth hormone deficiency in early adulthood, the criteria are no different. You treat it as if it was childhood onset, but you repeat at 25 years, and you do not continue unless they fulfill all three criteria. So if you start in childhood or in early adulthood, you do need to repeat and reassess at the age of 25 once they reach peak bone mass. After adult bone mass has been achieved, the growth hormone replacement therapy is based on the same criteria. Now, ACE basically just says test for severe deficiency and replace as appropriate. They're not as rigid as NICE in terms of cutoffs, 6 months, 9 months, reassess, stop. But they do say that if it's, once you've started, you do need to reassess periodically and look for benefit. Now, approximate doses as you get older, natural growth hormone levels decline and your replacement requirement is less. And in transition patients, so when you're going from adolescence to adulthood, if they have stopped, you can start at 50% of baseline and then go on. Remember, people with diabetes or obesity, people who are older in age, do require lower doses of growth hormone therapy. Once you start, you dose titrate at 1 to 2 month intervals, and then you reassess based on IGF-1 levels. Now, IGF-1 is useful for monitoring replacement therapy, not useful for diagnosis because of the huge overlap between healthy and deficient individuals. Now, what they say is you should, once you've stabilized them, the first 3 to 6 month period, you reassess approximately every 6 to 12 months. This reassessment should include clinical criteria, your weight related indices, and your waist hip circumference as a marker of visceral adiposity, your serum IGF-1 levels. Yes, bone density markers do improve with the growth hormone replacement, but you cannot use growth hormone replacement alone for bone density markers. And along with your growth hormone, you periodically reassess your other pituitary axis to see where they're at. Because remember, if you have started someone as an adult or as a transition for isolated growth hormone deficiency, there is a chance that they may go on to develop other pituitary hormone deficiencies, and therefore you need to reassess. The appropriate length of therapy is unclear. In theory, the benefits can continue indefinitely, but if there is no apparent benefit, and these guys are a little bit more relaxed, 12 to 18 months you could consider discontinuing. Now, they do say though that in those whom you discontinue, go back and reassess at 6 months, because the improvement in symptoms might be so gradual that patients might only be able to tell you in retrospect that they benefited from growth hormone therapy. So go back and reassess. But again, remember, they still have to tick all the boxes for replacement therapy for you to restart that growth hormone therapy. So in terms of side effects, it's mainly related to fluid and water and sodium retention, a little bit of musculoskeletal muscle stiffness, myalgia, arthralgia kind of symptoms. There is an improvement in insulin sensitivity, but again, like with the bone markers, you cannot use insulin sensitivity as the sole index for starting growth hormone therapy. There is a worry about potential induction of cell growth and proliferation and starting growth hormone therapy, especially post-cancer therapy, whether it's CNS related or peripheral. And there is a theoretical concern regarding tumor recurrence or de novo neoplasia. Formulations wise, we have daily preparations, which are the most frequently used. Long-acting growth hormone analogs are coming onto the market, but they come with certain caveats and still ongoing reservations, including safety and reversibility and the long-term outcomes in terms of cardiovascular and cell proliferation. So, if you're looking at growth hormone replacement therapy, yes, deficiency impacts bone, muscle, general health, heart, adipose tissue, and potentially longevity. Replacement improves bone and muscle strength and quality of life. This, while it's impaired with deficiency, or the risk is increased with deficiency, and the risk decreases in terms of cardiovascular risk and fat mass, the reason we don't use cardiovascular risk as a marker for initiating growth hormone therapy is, with growth hormone substitution, we have not actually shown a decrease in cardiovascular outcomes or cardiovascular mortality or all-cause mortality with growth hormone replacement. So you cannot use just these risk indicators to start treatment because the outcomes do not correlate. So the strategy is literally assess for baseline hypopituitarism, check if the patient is eligible for growth hormone therapy, assess other pituitary hormone therapies, replace pituitary hormones before you check for growth hormone stimulation tests, because you will not get an accurate result unless their cortisol and thyroxine replete. Then do your stimulation tests as per local protocols and guidelines. If necessary, and you're looking at neuroendocrine deficiencies, please do look at your imaging for your pituitary. Make sure that you do your quality of life assessments and see how they improve. And severe growth hormone deficiency will require stimulation testing in the absence of multiple pituitary hormone deficiencies. So on this slide, I'm going to stop. Summarizes the same thing. Adults with clinical suspicion, if they have multiple hormone deficiencies and a low IGF-1, go ahead and replace. If they have few hormones, you may want to test further, which may include a stimulatory test. On the other hand, if they have a history and you have a low index of suspicion, no, stop right there. And if they have a normal IGF-1. But if you have a high index of suspicion and a low IGF-1, you again need to stimulatory test. So either in multiple hormone deficiencies with a low IGF-1, or with low suspicion and a normal IGF-1, you don't really need to test any further. But all other pathways really come down to at least doing a glucagon stimulation test. And if you don't have multiple hormone deficiencies, you may want to do more than one stimulation test. I'm going to stop here and I'm happy to take questions. Thank you.
Thank you, madam.
Not yet, I'm afraid. I'm afraid you are all standing between me and lunch, but thank you for asking.
Thank you. And about this stunted growth children around...
I don't do children. I'm not taking any questions on pediatric growth hormone deficiency. Adult growth hormone deficiency.
More than 14 years.
It is not pediatric?
But we do have people who deal with pediatric growth hormone deficiency. So I'm sure one of my colleagues might be happy to answer that question.
More than 14 years, does it?
More than 18, our territory, adult growth hormone deficiency only.
That is according to Indian.
I have a couple of colleagues who can take your question.
Indian Voter or Marriage Act. But
I think we can take up that question, madam, instead of wasting our time.
Stunted growth children more than 14 years, can we do for any good thing with growth hormones?
So I think I can answer that question, although I'm not a pediatric endocrinologist. In various syndromes, including Turner's and Noonan's and just growth hormone deficiency or people with children with short stature, growth hormone has been shown to improve the height to a limited extent. But again, once they reach adulthood, you reassess as usual once they finish their skeletal growth. So once skeletal growth is finished, we come back to what I just presented.
But before losing, before becoming adult, if we can give growth hormone, they will be increased in height.
No, it's not as simple as that. They will still need to be assessed for any growth hormone deficiency. They will still need to be referred to a specialist endocrinologist who deals with children with growth disorders or short stature. They will still need to be reassessed periodically for linear growth, and only then can it be continued.
Kyphosis, any kyphosis?
I can see nods from my colleagues there.
If they have any kyphosis?
Pardon?
Kyphosis.
Okay,
I don't think that's an indication at
sir,
all for
further
growth hormone
clarification asked
replacement.
during the lunch time, sir. Further clarification can be added to the lunch time, sir. Thank you for your question.
Thank you very much. Thank you.
Let us move on to the next session.
Thank you.
Next, let's move on to the next topic, sir.
Dr. Nidin Kapoor, Associate Professor of Department of Endocrine in the Christian Medical College.
So this is over to the speaker actually. We extremely thank the audience who are waiting for the lunch, and it is a paradox. At the lunchtime, we are all hungry and we are going to listen to a lecture that is place of anti-obesity medications in the clinical practice.
So very good afternoon. I understand I'm exactly before lunch and I'm talking about obesity, but I promise to keep on time. In the next 15 minutes or so, I shall take you through this topic of the role of anti-obesity drugs in our current day clinical practice. I'll briefly cover this by highlighting 5 points in this lecture. First, I'll talk about the relevance or the importance, why we need these drugs in our day-to-day clinics, in our clinical practice. I'll mention about the different classes of drugs that are available, the drugs which are already there in the market, the drugs which are likely to be there within the next few months, and more importantly, what is the evidence to bank these drugs. When do we start? We have a lot of patients with obesity, but who do we start treatment? When do we think of initiating? The follow-up, the role of other medications, which is equally important. And just before I close, we'll just touch upon the very important emerging role of genetics and drugs that are specific to certain genetic disorders in obesity. So starting straight with the relevance of obesity, I'm sure all of us here know that there's a huge prevalence of obesity globally. It's a pandemic. When you look at data from India, and this is data we published last year from the National Family Health Survey, where we know that about 35 to 40% of the Indian adult population has obesity. When we look at the same figures 10 years ago, these were in early 20s, and today it's 35, 40%. When you talk of our state here in Tamilnadu, we have about 50% of people who are either overweight or obese. So that's a big number. To complicate things further, what we also know is that the Indian phenotype of obesity is very different from the West. We tend to have metabolic problems at a much lower BMI, and we also have this concept of normal weight obesity, where we know that not only it's common, but these people who have this huge amount of fat, despite the normal BMI, have metabolic problems, which are at par with people who are obese by BMI criteria. So I know I've started on a very gloomy note, and all this sounds very distressing, but what is good? What is something good that has happened also across the last few years is our knowledge and understanding of obesity has improved several-fold. Today we consider obesity as a disease, and we no longer think of it as an equation of energy intake and energy expenditure. Rather, today obesity is considered as a disease with several neuronal pathways which are altered, pathways which alter the appetite, the importance of gut peptides, the importance of adipocytokines, the importance of metabolic, behavioral, and environmental cues. And all of this put together gives a lot of options for developing drug therapy in obesity. When we look at the current guidelines for obesity management, and this is from the Canadian Obesity Network, which was published about a year and a half ago, today we focused not on reducing weight alone. Today we talk about improving the quality of life of our patients. When we actually looked at data from our own center looking at quality of life in women with obesity, we find that it is the experience with dieting, the experience with lack of food, which is a major component that adds on to poor quality of life. I'm not saying that diet and exercise is not important, but what often happens in clinical practice when we start treatment with patients with obesity, they would lose weight, but they would come back after a while. Doctor, we've lost 5, 10 kgs of weight with very strict diet and exercise, but we're not losing any more. We're stuck. And that's when probably the role of medications comes into place. Whenever we look at data, this is long-term data, including from the Look Ahead trial, the maximum amount of weight loss that we can achieve with good diet and exercise is about huge, 15 kgs on an average. But what really happens is if we do not follow that up, the long-term maintenance of data of weight loss is just about 3 to 5 kgs. So that's the exact point when patients come back to you, when you've done a good trial of diet and exercise and lost weight, they would come back, and that's the point when we need to start on medical therapy, otherwise they will be back to square one. So this takes me to the second aspect of my talk, talking about what are the different targets of weight loss medicines that we have and what is the evidence to support them. Just the way we talk of diabetes, today we also have the Omnius octet for obesity. We have a couple of drugs which target at least 3 of these factors, whether it's the brain, the pancreas, and the gut. 5 of these drugs are approved by the US FDA. Let's look at very briefly these drugs, talking about phentermine. In India, what is available is just a 37.5 milligram preparation. The biggest problem with this drug for obesity is it increases blood pressure, increases the cardiovascular risk, and that's a problem which is there in most of our patients with obesity, except in very young people, where this drug can be used, otherwise very difficult. But when you look at literature, large studies tell us that the weight loss to the scale of 10 to 12 kgs can be seen with the use of phentermine. Talking about combination of phentermine, topiramate, this is not available in India, the combination, but these drugs are individually available. As I said, phentermine 37.5, but topiramate 25, 50, and 100 milligrams are available as separate drugs. These are used as anti-seizure drugs, and if used in a patient with obesity, may help to lose weight. The big problem, apart from the problems with phentermine, which I mentioned, peripheral neuropathy is a big problem with topiramate. Again, the evidence, when you look at clinical trials, the weight loss is to the scale of maximum 10 kgs. When we talk of orlistat, and there's another drug which is available in India, it is a pancreatic gastric lipase inhibitor, weight loss to the scale of 6 kgs. It's not so helpful, but it's only in settings where people consume fat, and you have patients from certain sects who have to follow their customary family norms of eating a particular fat-rich meal on some days, and that's the culture that they have to follow. It's very difficult for them to have something cooked separately, and in those people you do see weight loss to the scale of 6 to 8 kgs. Otherwise, it's a weak anti-obesity drug. Talking about the fourth drug, the naltrexone-bupropion combination, again, both of these drugs are not available, but individually, naltrexone in India is available as a dose of 50 milligrams, bupropion to the dose of 150 or 300. It is shown to have weight loss to the scale of 5 to 6 kgs. Currently, we have a study which is ongoing using bupropion with zonisamide, and that should be in the Indian market very soon. Again, weight loss to the scale of 5 to 6 kgs helps to cut down appetite, but since this combination is not yet available, again, difficult to use. GLP-1 analogs, liraglutide 3 milligrams, we know the weight loss is to the scale of 8 kgs. We don't have 3 mg again in India. So cutting a long story short, of the 5 drugs that I've shown you, practically not much is available in India. What we have is orlistat, what we have is GLP-1 analogs that do not in the dose which is available. Semaglutide is the latest in the addition. So what are the drugs that we have or are likely to have in the next few months? And probably there are 4 things that I could highlight. we know about the oral semaglutide that was launched recently in India. Unfortunately, the oral semaglutide, the doses which are marketed currently in India are 3, 7, and 14 mg. The scale of weight loss is only about 5 kgs. Currently, the Pioneer Plus trial, which is going on, we at Vellore are a part of it. There, the same oral semaglutide is being given as 25 and 50 milligrams. And believe me, all the patients who are in the trial, I have about 12 patients in the trial, have lost about 15 to 20 kgs. The A1Cs, which were 10, are all down to 7. There is no placebo in the trial, so I know that is working. But till the time that is marketed, what we have very shortly, the next 3 drugs, I'll have a slide on each. What we will have, hopefully, within the end of this year is injectable semaglutide, 2.4 mg, weight loss to the scale of 15% over 68 weeks, very effective, already in the US markets. Tirzepatide, this paper was published earlier this month, again coming into the market hopefully soon. Weight loss to the scale of 21% in this trial over 72 weeks. Again, a very effective drug. And the third is a combination of cagrilintide and semaglutide, and we at Vellore just started the clinical trial with that. This weight loss is at par with bariatric surgery. So yes, we have different combinations which are coming in with semaglutide, with tirzepatide and injectable semaglutide. And hopefully at least what we see is this should be available in Indian markets before the end of this year. A very promising drug. So overall, there are several drugs in the pipeline, and I think what we used to talk about the gap between lifestyle and bariatric surgery, today drugs are going to be far beyond into the realm of bariatric surgery by having weight loss to the scale of 25 to 30%. And this takes me to the third aspect of my talk as to when do we initiate drugs or when do we initiate treatment. Again, looking back at the Canadian guidelines, today we do not depend on BMI alone. Many years ago, when we used to talk of only bariatric surgery or drugs, we used to say, okay, BMI of this to this, you think of starting drugs, but things are changing today. We stopped talking about BMI as an indication for starting drugs. Simple clinical staging systems are more in use. This is something simple called the admittance staging system, wherein I may have a patient who's got a BMI of 40, may just have pre-diabetes. I would put that patient right at stage 1. Whereas I may have a patient who's just BMI of 35, severe debilitating osteoarthritis, maybe diabetes with retinopathy, would directly be in stage 3. And why is it important to use this against BMI? And when we look at this data from NAINS database follow-up of over 15 years, we find that BMI doesn't really help in predicting any kind of mortality, but it is the staging system which clearly tells which patient will follow well or not. Today we have staging systems which are available which tell us that it's probably stage 3 where we have to use medical therapy in our clinical practice. This is data from our clinic in Vellore. We have about 38% of people who belong to stage 3, so there is definitely a huge market for using therapy, anti-obesity therapy in Indian patients. This takes me to the fourth aspect of my talk, talking about follow-up and the role of other medicines. I think today obesity is classified as a disease. And like in diabetes, it's not that we've just started treatment today and then we forget about it. We need to follow them up. Recommendations at least monthly for 3 months and thereafter every 3 months. But the important take home here is that if in 3 months your patient has not lost 5% of weight with the anti-obesity therapy that you're using, it's probably not working in that patient, you need to change the drug. It's also important to look at the other drugs which are being used, and that's also important because there are drugs which increase weight for comorbidities, like for diabetes. I would like to avoid sulfonylureas, maybe use other, at least weight-neutral drugs, if not weight-promoting drugs. And it's really, really important, and especially from a psychiatry point of view, it is important to look at these drugs because people with obesity often do have a lot of psychological problems. Again, this is data from our clinic where we find about 30% of people who actually walk into the obesity clinic have an underlying psychiatric illness. So yes, it's important to follow up, and it's important to also look at the other medicines. And just before I close, probably will take you through this last aspect of what is the role of genetics. I think we all stay in an obesogenic environment. It is probably the genes which tip off where somebody becomes morbidly obese, whereas somebody remains thin. despite eating less or more. We have several studies to tell us that yes, genes play a very important role in obesity. When we looked at this interesting study of mothers and their daughters in the community, these are postmenopausal mothers and their daughters who are married and settled elsewhere in a different environment, there is a strong correlation of the amount of fat that they carry. But really, what really compounds these problems of genes, especially in our southern states of Tamilnadu and Andhra Pradesh, is the consanguinity, which is still quite prevalent. When you look at Western literature in consanguineous populations, just 3 genes could contribute to about 30% of the causes of obesity in children. When we looked at our data from Vellore, about 16% of young onset morbidly obese people have a genetic cause of obesity. Today, this is easy to detect with the help of next generation sequencing system. We can do a genetic panel test for about 10 to 12,000. And when do we suspect somebody to have a genetic problem? Any of 2 of these criteria, if there is somebody who has young onset morbid obesity, somebody who has family history of consanguinity, family history of young onset obesity, history of hyperphagia, or if they have mild to moderate developmental delay. What we found in Vellore is the most common mutation is MC4R. And believe me, these patients who have this MC4R mutation are just young and morbidly obese. They really don't have any of these mental impairments and visual impairments and developmental delays. So sometimes they may be missed off as just constitutional obesity. But why is it important is today we have drugs which are helpful to target these specific mutations. When you look at literature from setmelanotide, about 30 to 40 kg weight loss can be achieved by just giving this drug which handles the specific mutation which may be defective. So yes, the role of genetic testing is also coming back. So with this, I would stop. The key takeaways from this lecture would be, yes, obesity is a big problem and anti-obesity medications are important after having given a good trial of lifestyle. The way we have an omnious octet for diabetes, similarly for obesity, 5 US FDA approved drugs, but the drug that really stands out with respect to the quantum of weight loss is GLP-1 analogs, several of them in the pipeline. It is important to think of starting these medications not just based on BMI, but looking at comorbidities and simple clinical staging systems. And yes, there is an upcoming role of genetics as well in managing obesity with drugs. So I'd like to stop here. I'd like to acknowledge the team of obesity management at CMC Vellore, and we'll be happy to take any questions.
Thank you, sir. Thank you for a very informative lecture, sir. Because we have finished 4 minutes earlier, we can take 2 or 3 questions from the floor, if at all anybody wants to interact with the speaker. Regarding this medications for the GLP-1 analogs as anti-obesity drugs, these drugs are employed after this lifestyle modification or?
After lifestyle modification.
So lifestyle modification is a base for all trials and all those things.
Absolutely.
So unless otherwise we stick on to the lifestyle modifications, no anti-obesity drug is going to work, it seems.
Right. People do use it upfront. When I was in the US, they used to sometimes prescribe. So what is important is if you prescribe diet exercise with these drugs, patients will lose weight. They'll come back in 3 months having lost a particular quantum of weight. But if you use diet exercise first, and patient comes at 3 months, and when they say, doctor, we are not losing any more weight, and then you add this drug, the total quantum of weight loss would be much more than if you had started both of them together.
Yes, yes. And these drugs are to be continued for how long they are supposed to continue? Once they stop it, what will happen to them then?
Right. So we use these drugs as weight maintenance drugs. The way we manage diabetes, we don't say that we start the drug A1C is 7 in 3 months and you stop it. The way it is for obesity, like any chronic disease, it needs long-term management.
Thank you, sir. Thank you.
Thank you.
Sir, is there any data about these GLP-1 analogs in children for weight loss, or like how we have a type 2 diabetes,
Right.
and how early can we start?
Right. So the earliest evidence of what we've used and what some of the other reports tell for liraglutide is earliest at the age of 12 years. I've used it in Prader-Willi, and yeah, so the earliest is 12. There's yet to have more data on younger age groups.
Okay, thank you, sir.
Thank you. Thank you.
Thank you, sir. I think we can close the session, sir.
Thank you very much. In fact, thank you very much for staying back, audience. And we've actually started 45 minutes late, but due to the excellent succinct lectures we've had, we've actually made it up to 13 minutes. And that's a great show, in fact, from the speakers. Thank you very much for actually making up time. It's an excellent session. And to felicitate the speakers and also the chairpersons, may I request Dr. N.K. Narayan on stage, please. Thank you very much all. We can now disperse for lunch, and we will have another session in Hall B after lunch, which will be a very interesting session on discordant thyroid function test by Professor Krishna Chatterjee from Cambridge. So 2:25 post-lunch, Hall B. Thank you very much. Good afternoon.
one of the co-chairs.
Have you managed to travel anywhere, Prof, or you're with the COVID situation?
Not yet. So the first meeting is European thyroid meeting in September. Actually, no. Well, travel within the UK. We had the British thyroid meeting in May in London. So we're taking it gradually.
Okay.
There's a lot of flight cancellations, and the travel industry is not back to normal by any means. So,
yeah.
So it's not so much COVID. It's the disruption of the airlines and the airports and things of that nature.
Because at our end, it seems to be opening up, although we have increasing cases.
And have most people been double or even 3 times vaccinated, or?
Well, most people are 2 times, at least medical professionals are 3 times vaccinated. The general public, most of them are dual vaccinated. Not everyone is triple vaccinated yet, because we don't have any mRNA vaccine over here, so we use the AstraZeneca vaccine. So that's the predominant vaccine which we have here.
Yeah. So actually, I've been, in my spare time, I've been doing vaccine trials. So,
oh, really? Okay, that's interesting.
So I know a little bit about all the different vaccines.
Okay.
And one of the studies that we did showed that if you'd had the AstraZeneca vaccine first, and then you have an mRNA vaccine as a booster, your T-cell memory immunity is better. So.
Okay, that's interesting.
Yeah, it's interesting. So mix and match is apparently.
It's really good. It's a way forward. Yeah.
Prof, the AV people are asking whether we could shut the window behind you or dim it. It's just giving a brightness from behind so that it's dulling your face.
I can. Well, yeah. So the sun is shining outside. So I've drawn the blinds.
Good time for UK.
I can turn off my lights.
Yeah.
But I don't know.
You can turn on your lights. Turn on your lights, Prof. No, Prof, sorry, turn on, I said. Turn on the lights.
Turn on, yeah.
Yeah, please.
No, I'm sorry, my office is not ideal, it has two large windows, and when the sun shines in, it's even worse.
We need to take advantage of the UK sunshine.
I thought of trying to do this from home, but then I decided that the internet connection would be risky. So.
Oh, okay. This is from MRC, is it, Prof?
No, this is actually from IMS. I'm on the 4th floor.
4th floor. Yep.
Two floors above clinic.
Okay.
That same building.
Prof, can we kickstart?
Yeah, whenever.
So, good afternoon, delegates, and good morning, our beloved Professor Krishna Chatterjee. It's a great privilege and honor for both of us, Anand and myself, to be here. to be talking to you, and of course you need no introduction, but we are duty bound to tell a few words about you. For people in the floor, Prof. Krishna Chatterjee is the professor at the University of Cambridge in the Department of Endocrinology. He's a fellow of Churchill College in Cambridge. He's also the director of the Cambridge Clinical Research Center, which is part of the NIHR. He is a multifaceted personality who has got many hats to his credit: a clinician, academician, a researcher, and a great teacher. We feel proud that we've also been part of his team, sorting out difficult to find out what is happening with the thyroid function test. We used to have these weekly meetings with him where we used to sit and get the referrals across from the UK and try to tease out. And we used to find out at the end that there are so many rare disorders that can give rise to discordant TFTs, which is what we will be hearing from Professor. He's distinguished for his discoveries. Without further ado, I hand over the session to Prof. Krishna Chatterjee, and we are all keen to hear from you.
So, thank you, Anand and Dr. Narayanan, for the very kind invitation. Thank you for the audience. And what I'd like to do in the next 45 minutes or so, using a series of illustrative cases, is to take you through some examples of patients exhibiting discordant thyroid function tests. So this introductory slide comes from an article which I co-wrote with Professor Gunnell, who I believe has already spoken at this symposium. It's several years old, but I think it's still completely valid. And what it illustrates is the common patterns of thyroid function tests that we see associated with various diagnostic entities. And I won't go through this in any detail, but simply point out that this quadrant at the lower right is the one that I'm going to focus on. I'm going to focus on patients in whom, when you do thyroid function tests, you see this unusual picture where the free T4 and or the free T3 is raised. And in the face of that, instead of the TSH being suppressed, it's either inappropriately within the normal range or it's slightly elevated. So the first case, a 78-year-old man who presented to the clinic with tiredness, together with cold intolerance and dry skin. And here you can see a picture, and maybe I can convince you that the outer third of his eyebrows are missing, and he has this sort of pasty complexion, suggesting clinically that he may be hypothyroid. When one did the thyroid function tests, the TSH was raised, but unexpectedly the free T4 was also elevated. We measured antithyroid peroxidase antibodies, and the measurement was strongly positive. Again, strongly suggestive of Hashimoto's thyroiditis. Anti-TSH receptor antibody was negative. So what we did with this sample from this particular time point was simply to measure thyroid function tests in a whole range of different common immunoassay platforms. And what you can see is within the margins of plus or minus 10%, all these different platforms consistently show that he has a TSH which is raised. Where they disagree is with the free T4 measurement. And these platforms are recording a low free T4, consistent clinically with the hypothyroid state, whereas these are giving very discrepant values that are all over the place. And in short, this is an example of a patient who undoubtedly clinically has primary hypothyroidism due to Hashimoto's thyroiditis. But on that autoimmune background, we know that rarely, perhaps not that rarely actually, maybe as many as in 30 or 40% of cases, individuals can also develop antibodies against T4 or indeed T3, anti-iodothyronine antibodies. And these antibodies can interfere with the architecture of immunoassays. Now, as this case illustrates, the immunoassays can be broadly classified into one-step or two-step methods. And in the one-step methods, you incubate the sample with the assay materials in one step, and then it does the analysis. And in that situation, these antibodies have a much greater propensity to interfere with the architecture of the assay. A two-step assay, I won't go into the technicalities, involves a situation where from the sample, you capture the thyroid hormone in the sample using capture antibodies. And then there is a so-called wash step where you wash the plate. And that wash step can eliminate the presence of these interfering antibodies and perhaps gives you a better chance of giving a true measurement. So that's my first example. Now, to give you a local perspective, this was a case, a family, in fact, that was referred to us by Dr. Kamalanathan at Jipma Hospital. He was looking after a 25-year-old South Indian lady who presented with some constellation of symptoms, some of which could be hyperthyroid, but she had no goiter, pulse was only 90, and on a technetium isotope scan, the percentage uptake into the gland was normal. Now, here I've depicted in his local assay, the various hormone measurements that he identified in this large family. And I don't want to dwell on the details, but simply to show that many individuals exhibited a raised FT4. Some, in addition, had a raised FT3, and in all of these cases, TSH was not suppressed. He also measured total T4, and that was also elevated. So he provided me with a very helpful pedigree, and here you can see in red all these individuals who have this discordant thyroid function test pattern. And there was a dominant mode of inheritance. So he said, I think, Dr. Chatterjee, this is a case of thyroid hormone resistance because it's a genetic condition and both T4 and T3 are raised. So he kindly sent us a sample of serum, and one of the first things we did was to verify the biochemistry using our two different assay platforms that we have. Siemens Centaur, and also a method from a company called Wallach Delphia. And in Centaur, we reproduced what he had found, a raised FT4 measurement, raised FT3, raised total T4. But then in Delphia, the picture was very different. The method comparison showed a completely normal T4 and T3 and a raised total T4. We also went on to measure thyroxine binding globulin, and that measurement was normal. So that's not the explanation for the raised total T4. So moving on a bit, this is the crystal structure of albumin, one of the binding proteins for thyroid hormones. And in fact, it has 4 binding sites for T4, and a high power view here of one of those binding sites shows the T4 molecule in the middle of this cavity and some surrounding amino acids. And it turned out that in this family, individuals have a genetic variant in the albumin molecule, changing this amino acid from an arginine to threonine. And that amino acid variant change creates more space inside this cavity, allowing T4 to bind the variant albumin with increased affinity. And that in turn gives us the diagnosis that in fact in these individuals, they have familial dysalbuminemic hyperthyroxanemia due to this variant in the albumin gene. So this is the broader context. In fact, variants in the albumin gene can be quite common in the population, ranging from as frequent as 1 in 100 in a series in Spain, maybe to about 1 in 10,000. And of course, being a genetic variant, it is inherited in a dominant manner. this is a summary of all the variants that have been recorded in the literature. And you can see that definitely the different variants come from different ethnic backgrounds. So this is the commonest in the world, an arginine to histidine change at position 218. This is been identified in people of Swiss and Japanese ancestry. And interestingly, we find that people with this variant not only have extremely raised T4 measurements in immunoassays, we also showed recently that this abnormal albumin interferes with cortisol binding and cortisol measurement as well. So you get a really bizarre endocrine picture. At this position, a serine mutation has been, a variant has been identified in South Asian, people of South Asian ancestry. We described an isoleucine change in individuals from East Africa, and Dr. Kamalanathan's patients have a slightly different amino acid change at this same position, again, from a South Asian background. And the thing that I want to point out is that not only do these people have raised T4, but they also have raised T3 in some assays. And in fact, a couple of years ago, we took about 30 individuals with genetically proven FDH with this common variant, and we took serum samples and put it into a range of different assay platforms. And what you can see here for FT4 is this is the reference range for the individual assays. And you can see that many of these individuals exhibit falsely elevated FT4 in many of these platforms. And then they also exhibit raised FT3 in these measurement methods. So this biochemical picture really could confuse you and lead to a misdiagnosis of either thyroid hormone resistance or TSH secreting pituitary tumor or some other entities. And it used to be said that like anti-iodothyronine antibodies, that the two-step assays were less susceptible to interference. We find that actually that's not the case. Here you can see that this Beckman method, which is a two-step method, shows a very high degree of interference. And conversely, this method, Vitros, actually is least susceptible to interference. And it turns out that the reason that the Vitros is so protected from interference is because they don't use chloride in the assay buffer. So the bigger point that I want to make is that actually the reasons why the variant albumin interferes with the different assays is not at all clear. It's something to do with an interaction of the albumin with the chemistry of the assays. And given that manufacturers are tweaking and optimizing their assays all the time, it's very difficult actually to authoritatively say that one particular assay is going to be devoid of interference from FDH, from here and evermore. It's an ever-changing situation. And this is the picture when we did this study in 2020, and I dare say that in the years to come, the patterns of interference from the different manufacturers and the assays will change. So sticking to this theme, a 22-year-old male who presented actually to our clinic, again, with some symptoms that could fit with hyperthyroidism, but no goiter, again, a raised free T4 and a raised total T4, not quite as high as in the FDH cases. We undertook biochemical and genetic testing for FDH, and it was negative, and I'll come on to what we did later on. And in fact, in this individual, we found that he was heterozygous for a variant in another circulating thyroid hormone binding protein, namely transthyretin or thyroxine binding prealbumin. And this is the variant that he had. So this, again, I think is an important entity to draw to your attention. Transthyretin, as this structure shows, is a molecule that forms a tetramer in the circulation. And when it does that, it forms a binding cavity that binds to T4. And if individuals have changes in the amino acids that surround this binding cavity, that can lead to an increased affinity of that transthyretin molecule for T4. And from the published literature, this is from a review from my colleague Sam Refetoff, he has described that there are really 4 variants, common variants, like in albumin, that can present with transthyretinemia or hyperthyroid, raised T4 measurement due to an abnormal transthyretin. And in this particular patient, again, we went through the same exercise. We put his sample into a lot of different assays, and we found that T4 was raised to a greater or lesser extent. And there was only one assay platform that was devoid of interference. And to make matters worse, this entity not only interferes with FT4, but it can also give you a slightly raised FT3 measurement as well. So again, like dysalbuminemia, on the face of it, this could easily be confused with thyroid hormone resistance or other genuine entities. So how do we go about trying to pick these entities up? Well, as I've illustrated, the simplest thing that we do is to take the same sample of serum and measure the hormones in different assay methods. And if you see a very discordant picture, then one should suspect this. Abnormal binding proteins, usually if you measure total T4, it'll be raised. If you have access, your laboratory, to radio-labeled T4, you can actually incubate it with a sample of the patient's serum and show that it binds to the albumin or the transthyretin with high affinity. And then if that is the case, you can go on and do genetic testing. So moving on, another vignette, a 67-year-old female who's an inpatient. She has a fractured neck of femur. She's awaiting hip surgery. And after the hip operation, she develops atrial fibrillation. So the team do thyroid function tests. She notes she's in AF, but she's euthyroid otherwise. And when they do thyroid function tests, the TSH is not suppressed, but the free T4 is raised. And they went on to measure total T4, and they found that the total T4 in this sample was normal. So when we see this picture, then what we suspect is displacement of T4 from the binding proteins. And this can occur through a number of drugs, principally heparin. And of course, this patient had been on low molecular weight heparin thromboprophylaxis. So to show you how this works, when you administer heparin, and this can be, as I said, intravenous infusion or low molecular weight subcutaneous, what that does is to activate endothelial lipoprotein lipase. And that leads to this enzyme hydrolyzing triglycerides in the patient's circulation, releasing free fatty acids. And as these authors showed, in vitro, what those free fatty acids do is to displace free T4 in a linear fashion from one of the binding proteins, from albumin. And this phenomenon occurs in vitro. So it happens actually when you take the blood sample and then there is a delay in getting it to the lab, or in the lab there is a delay in spinning the sample and putting the supernatant serum on the machine. So the way to avoid this assay artifact is, well, either to take the sample a very long time before the heparin is given, or rush it to the lab and analyze it straight away. A word about very sophisticated methodology to overcome assay interference. Often in specialist laboratories, one can measure free thyroid hormones by a technique called equilibrium dialysis. And in principle, this technique is very straightforward. You take a sample of the patient's serum and you dialyze it overnight against a semi-permeable membrane, a bit like we used to do in chemistry class. And this dialysis step theoretically separates the free thyroid hormones away from iodothyronine antibodies or heterophilic antibodies or these variant binding proteins. And then when you measure the next day the free thyroid hormone in the dialysate, it should give you a true result. As I say, we have used this methodology, and yes, indeed, it can be very helpful in eliminating these sources of artifact, but it's not perfect. And for example, in the heparin case that I just showed you, the displacement effect would cause a raised free T4 even by equilibrium dialysis. And even in these some cases of FDH, we find that you get a raised free T4 even by ED. So this technique is not 100%. And lastly, I just wanted to finish with showing you in this particular picture, this is not an assay artifact. This is a genuine entity. So here is a patient who genuinely had a raised free T4, but a normal T3 and TSH. And this biochemical picture, on the face of it, one of the causes can be due to a failure of the deiodinase enzymes to convert T4 to T3. Now, in the common thyroid literature, there's a lot of argument about whether there are, in the common population, there are people who have variants in the deiodinase enzymes which inhibit T4 to T3 conversion, and maybe there's an argument for these individuals having combined T4 plus T3 combination therapy. I'm not going to get into that discussion. I'm just going to share with you that at the very rare end of the spectrum, probably about 15 individuals described worldwide, they have mutations in this factor called SECIS-BP2. And this molecule is responsible for incorporating a vital amino acid, selenocysteine, into the deiodinase enzymes, but also into a whole range of other human selenocysteine-containing proteins. And the way that this condition manifests, on the one hand, is biochemically with this picture, but also in the serum, if you measure it, the patients have a low plasma selenium, and that's due to the fact that they are unable to make these circulating selenoproteins. Unfortunately, due to a lack of all these other selenocysteine-containing proteins, this is a multi-system disease. A defect or lack of this protein, which is expressed in skeletal muscle, gives you a muscular dystrophy. These proteins, which are expressed in the testis or in sperm, are lacking, so the patient is infertile. And then a whole group of antioxidant enzymes are lacking. And so these patients' tissues are subjected to increased oxidative stress. And in the long term, that results in consequences like sensorineural hearing loss, photosensitivity, and then, as we've found recently, thoracic aortic dilatation. So I just wanted to show you just a couple of other lists, I guess, just to be comprehensive. So as I said, if one sees this pattern, one should think about perhaps FDH and transthyretin variants causing interference with these measurements. Of course, as I'll show, it's also possible that the T4 and T3 are genuinely raised because the patient is thyrotoxic, and the problem is not with these assays, but that the TSH is falsely not suppressed. And I'll show you an example of that. And if you exclude all of those things, then you have to think about thyroid hormone resistance or TSH secreting pituitary tumor. As I said, if you see an isolated raised T4, then there are a few other entities that come to mind. This picture is often seen in individuals on exogenous thyroxine replacement, and in the discussion, we can go into the reasons for that. Displacement of T4 from the binding proteins. Heparin does this. Frusemide does it as well. Amiodarone can produce this picture. Again, I don't have time to dwell on it now. Importantly, non-thyroidal illness or acute psychiatric illness can give you this picture. We've talked about anti-iodothyronine antibodies and the binding proteins, and I've shown you what this selenoprotein deficiency disease looks like clinically. Okay, before I move on to sorting out cases where the TSH is falsely not suppressed, I just wanted to show you this sort of entity. So in the pediatric setting, we're often asked to investigate cases that look like this. So this is a 14-year-old child who has autism spectrum disorder. And as a way of managing that, he's on a highly restrictive diet. And when they did thyroid function tests, they found this unusual picture, a raised T3, but a lowish T4 and a non-suppressed TSH. And I'll show you the numbers here. You can see that the T4 is just below the low end of the reference range, and the T3 is just above. So we went on to do some further investigations in this case. We noticed that the patient had a goiter, and in fact, on ultrasound imaging, it was a diffuse enlargement with increased vascularity on Doppler. Again, I've shown you the biochemistry. This is genuine. This is not due to measurement interference. And then when we measured thyroglobulin, it's extremely raised. And then we measured urinary iodine, and it's very low. So in fact, here are a couple of other examples of adolescents on a very restrictive diet with goitrous enlargement, this altered T4, T3 ratio as the common theme. And then, in fact, in some instances, the gland can even be nodular. And in every instance, it was due to iodine deficiency. So that's an acquired cause, but I want to emphasize that actually that sort of biochemical pattern with a low or normal FT4, low normal FT4, and a high or high normal FT3 should bring to mind a couple of other genetic uncommon entities. One is individuals with resistance to thyroid hormone due to a defect in the alpha receptor. And the alpha receptor, because it's expressed in many peripheral tissues, actually these children actually present in pediatric practice with growth retardation, autism spectrum disorder, many features of congenital hypothyroidism, but with near normal thyroid hormone levels. So if there are any pediatricians in the audience, when you see children in your practice with developmental delay or growth retardation and borderline thyroid biochemistry, I'd like you to bear this entity in mind. And then my colleagues in the Netherlands have collected and described a number of patients with another rare genetic entity, mutations in this X-linked gene, which is responsible for transporting thyroid hormone into the central nervous system. And failure of that entry into the CNS results in a devastating neurodevelopmental disease, which is eponymously called Allan-Herndon-Dudley syndrome due to a defect in this molecule. And here you can see these children are very disabled. Peripherally, because T3 is raised and the peripheral tissues are not dependent on this cellular membrane transporter, these patients actually can have very many thyrotoxic symptoms. And some nice papers in Lancet Diabetes Endocrinology have described both the phenotype of a cohort of these patients, but also trials of treatment with a thyroid hormone analog called Triac to ameliorate these thyrotoxic symptoms. And again, I know certainly a colleague in Mumbai has identified patients in the Indian subcontinent with Allen-Herndon-Dudley syndrome and been able to obtain Triac therapy for them. So yes, so I put together these entities as sharing this genuine abnormal biochemical pattern, all of them characterized by an abnormal T4 to T3 ratio. And actually, if you do a few extra measurements, like serum thyroglobulin or urinary iodine, or if you have access to a reverse T3 assay, then this table illustrates that you can actually, at least on the basis of the patterns, you can separate out the various entities. And sorry, I neglected to mention that apart from environmental iodine deficiency causing this dyshormonogenic state, my colleague Nadia Schoenemakers, who researches the genetics of dyshormonogenic congenital hypothyroidism, would tell you that children who have mutations in genes like DUOX or thyroid peroxidase or thyroglobulin can sometimes present not at birth, but in adolescence with this dyshormonogenic biochemical picture. Okay, so switching gears then, another case, a baby who was identified on the blood spot screening program with a high TSH, but actually had no other features suggestive of neonatal hypothyroidism. And the measurement remained raised on successive sampling on day 11. And on day 18, they started this baby on thyroxine. And the consequence was that the TSH really didn't normalize, but the T4 and T3 became very raised. And mother commented that the baby was very jittery and tachycardic, not feeding. So clearly the thyroxine therapy was not the right thing to do. So one went on to investigate the mother, who's completely asymptomatic. And mother also had a very raised TSH, but with normal T4 and T3 and negative antibodies. So further analyses were undertaken on a sample of serum from the mother. And what we did was gel chromatography. So this is a technique where you put the sample of serum down a column, and the column separates out the substances in that sample on the basis of molecular weight. So the high molecular weight proteins fall through the column quickly and come out first, and the low molecular weight substances come out much later. And when we subject, so here is an example of exactly this sort of analysis. And in red is the profile that you get from a control subject. So this is a patient who genuinely has a raised TSH, let's say. And when you put their sample down the column, the TSH elutes in this position at the authentic molecular weight of 28. And you can measure the immunoreactivity of the TSH at exactly the right expected position. And then to calibrate this, you can see where albumin, purified albumin elutes, about here. If you put immunoglobulin down the column, it elutes in this position. So on that background, if you now put a sample in blue of the serum from this mother, it elutes in this very abnormal position where the TSH immunoreactivity is eluting at a very high molecular weight. And essentially that gives you the diagnosis. So what this patient has is something that is familiar to you if you're measuring prolactin. The patient has developed an antibody against the TSH molecule here, forming macro TSH, very similar to macroprolactin, an antibody TSH complex, which is physiologically inactive, but is nevertheless detected as TSH in your immunoassay and gives you a false result. A Japanese researcher called Hattori has really published a lot of papers in this area, documenting that actually perhaps as many as 1 to 2% of cases of apparent subclinical hypothyroidism in our practice. In other words, people who present to us in clinic with a raised TSH and a normal T4 and T3, that slightly raised TSH may not be genuine, and it may be due to antibodies, either macro TSH or, as I'll show you in a cartoon, people developing this other species called heterophilic antibodies, which interfere with the TSH measurement. And he also showed that if you want to rule out this entity, what you can ask the laboratory to do is to remeasure TSH after you add a substance called polyethylene glycol, 12.5% to the sample, and then precipitating and then remeasuring TSH in the supernatant to see how much of that TSH is still there. If you find that a very high percentage of the TSH is precipitated by the PEG, then you should suspect interference due to either macro or heterophilic. So what is heterophilic? Just to sort of show you a cartoon. This is the TSH molecule in cartoon form. And here is a typical assay where that TSH molecule is captured in a sandwich between one antibody that's immobilized to the plate and another antibody which is coupled to a tracer, a detection moiety. And that's the principle of the TSH assay. And to illustrate simply that you can get antibodies that either then bind to this antibody on the plate or an antibody that cross-links. And this is what we mean, a heterophilic anti-animal, because these antibodies that are used in the assay are typically mouse immunoglobulins. And if you develop an antibody against those antibodies, you can get interference. So how do we simply try to rule this out? I want to show you two maneuvers that you can ask your laboratory to do. One is to take the sample of serum and just dilute it 1 in 2, 1 in 4 progressively. And then as you dilute it to measure the TSH, and it should fall in a healthy normal subject with a raised TSH. If that TSH is genuinely raised, you should see a dilution series like this. And then when you multiply up the diluted value by the dilution factor, you should get a relatively constant measurement. On the other hand, if you take a sample, let's say from the patient with macro TSH or with heterophilic interference, and you create a dilution series, then it doesn't dilute out linearly. And so when you do the calculation, you get numbers which are really all over the place. So that's assaying TSH in dilution. And then this is a real life example of the PEG precipitation. So here's a separate case where we took a sample of serum, we put it into one particular assay, assay A, and we measured a number of 45. We put it into a different assay and we got a very different answer, 3.2. So that was very helpful because that discordance told us that there's probably a problem with the TSH measurement. And then when our scientists went back and took a sample from that patient, added polyethylene glycol and precipitated it, and then remeasured TSH in the supernatant, you can see that most of that TSH is gone. So in other words, the percentage recovery of TSH is very, very poor, and meaning that the PEG has precipitated this high molecular weight antibody TSH complex. And that, again, is a sort of ready test that can lead you to suspect this entity. So, okay, moving on, another vignette, a 2-month-old baby from the neonatal intensive care unit who's having persistent seizures, but actually has hardly any thyrotoxic symptoms. They measured thyroid function tests at day 5 and found very abnormal values. It persisted at day 6, persisted at day 10. They said, okay, let's measure a T3 now. And that was also very raised. And then at day 28, they measured a TRAB, and the TRAB was also positive. So potentially in this infant, they were making a diagnosis of neonatal Graves' disease. But as I said, this baby really had a paucity of thyrotoxic signs and symptoms. So they sent a sample to us. This is a colleague of mine, Arya, in one of the London pediatric hospitals. And this is what, these are the measurements that they documented using a Roche platform. We took the same sample and we measured thyroid hormones using Centaur, which is our method, and the T4 and TSH abnormalities completely went away. And then we measured TRAB using not Roche, but a Brahms method, and the positive TRAB also completely disappeared. So by now, you probably know what the diagnosis is here. This baby, because they were suspecting an inborn error of metabolism causing the seizures, was being supplemented with high-dose B vitamins, including biotin. And normally, we're supposed to ingest 30 micrograms of biotin. You can buy it on the internet, and some people take it in very high dose because they think it improves your hair and your nails. But as I also said, in clinical practice, people also give high-dose biotin in the pediatric setting, as has been published here, in cases where they suspect an inborn error of metabolism. And the biotin can interfere with assay architecture in a way that I'll show you in a minute. And it can interfere not only with measurement of thyroid hormones, but also with measurement of TRAB, measurement actually of all sorts of substances, troponin, ferritin, all sorts of analytes, which rely on this particular assay architecture, which I'll show you in a minute. And so you can end up either misdiagnosing Graves' disease or generating some very fancy, bizarre endocrinology where multiple things are off the scale. So how does this come about? So here is an assay method, Beckman, where they take a sample and they use an antibody which is linked to biotin to capture the T4. And then to capture that complex, they add to the sample particles that are coated with streptavidin. And streptavidin has an extraordinarily high affinity for biotin. So this is a very efficient way of capturing this species and then going on to do the rest of the assay. Now, the problem is that the way they've set this assay up, if the patient has ingested biotin and there is free biotin in the sample, in the circulation of that patient, that species has the capacity to interfere with the formation of this complex. And so you can end up with a weird result. And on the other hand, here's another manufacturer, Siemens, where they also use streptavidin and biotin in their assay in order to bring down the complex. But just because they've set the assay up in a slightly different way, where the T4 is being captured by a streptavidin biotin antibody conjugate, which is preformed, and you do this thing first, the free biotin in the serum, doesn't have the capacity to interfere. So as I said, again, I don't want to give you any kind of hard and fast rules. Many manufacturers use streptavidin biotin linkage in their assays. Sometimes they've taken it out, and in which case their assays are no longer susceptible. But every now and again, we do see this picture. Okay, so moving on, a 62-year-old man who presents to a cardiac clinic in AF has mitral regurgitation, and on account of that, thyroid status is checked, genuinely raised T4 and T3. We did equilibrium dialysis, and the T4 is indeed raised. We did dilution studies. So we have every reason to believe these numbers. Pituitary imaging was undertaken, and a lucency was found in the hypophysis, and a diagnosis of TSH secreting pituitary microadenoma was made. The patient was started on treatment with short-acting somatostatin analog, and at day 7, you can see that the T4 and the T3 look as if they're coming down. So at that point, the patient was transitioned onto the long-acting analog and was treated with this for about 5 months. But then when they came back to clinic 5 months later, there was absolutely no change in the thyroid biochemistry with the long-acting analog. So then the diagnosis was revisited, and they did a TRH test. They took the patient off analog, did a TRH test, and found that there was a brisk TSH response. A hepatic protein, sex hormone binding globulin, which is a marker of thyroid hormone action in the liver, was measured, and the levels were normal. And glycoprotein, pituitary glycoprotein alpha subunit levels were normal in this case. Now, for comparison, I will just show you the results of the same sort of testing in a case of proven TSHoma, a different case. And you can see that in the TRH test, the TSH response is quite blunted, almost flat compared to this. Here, SHBG is definitely raised, and here alpha subunit is very raised. So on the face of it, when you look at this, you can say, this is all very different to this, and actually this cannot be TSHoma. Let's go back and reinvestigate for an alternative possibility, which is indeed resistance to thyroid hormone beta, the beta receptor, which is expressed in the pituitary and the hypothalamus and is responsible for negative feedback action of thyroid hormones. And when they analyzed the beta gene in this individual, they found a mutation in the beta receptor, a very well recognized mutation that causes RTH, and that is indeed the correct diagnosis. And on the face of it, the case that I've shown you, it ought to be quite easy to make the differential diagnosis. However, what I'd like to go through carefully on this slide is that actually in real life, it's not that easy by any means, for the following reasons. First of all, the height of the elevation of free T4 and free T3 and the pattern of thyroid function tests are very, very similar. So you cannot distinguish the two entities on the basis of that. What about pituitary imaging? Problems on both sides. As this case illustrated, 10 to 15% of healthy individuals, including people with RTH, can have minor lucencies, low attenuation regions on pituitary imaging, which are probably incidentalomas. On the other hand, in the old literature, when the diagnosis of genuine TSHoma was quite delayed, patients often used to present to us with macro tumors, big lesions, 1 centimeter and bigger in size, which are easily visualized. But now that we do thyroid function testing an awful lot, I think we're detecting this entity at a much earlier stage in its clinical evolution, at the microadenoma stage. And there, often you can't visualize the lesions on imaging. All right, what about genetic testing? Well, there are issues there. We know that 10 to 15% of individuals who have what looks like RTH biochemically and with negative imaging can have a normal gene sequencing. Some of these cases we have found are due to somatic mutations in the gene. So mutations that are not expressed in all the tissues of the body, and in particular are not expressed in peripheral white blood cells. So when you extract DNA from the peripheral blood, you don't find a mutation, but if you were to extract DNA from other tissues, accessible tissues, like for example, a hair follicle, or take a skin biopsy, or a buccal smear, or epithelial cells that are excreted in the urine, you might find a mutation. On the other hand, if you want to argue it the other way, if you're facing a patient who has thyrotoxic symptoms and you think it's a TSHoma, and you do thyroid hormone receptor sequencing, because of the existence of mutation negative RTH, you can't be entirely sure about that. Alpha subunit measurements are very variable. And for example, in postmenopausal women, you get secretion of excess alpha subunit from the gonadotrophs, and that can confuse the picture. The TRH test, I've shown a cutoff here that above fourfold, probably RTH, a blunted below fourfold, probably TSHoma, but unfortunately there's a gray zone between 4 and 7 where we're not really sure. Yes, people have described doing the T3 suppression test over a period of 10 days. The problem with this is that it has relatively poor specificity in distinguishing these two entities. And then in addition, as in this individual, he had a cardiomyopathy and atrial fibrillation. Probably the last thing you want to do if he has those cardiac consequences is to make him even more thyrotoxic by giving him exogenous T3. And sex hormone binding globulin, well, there are many entities, notably estrogens, HRT, or the oral contraceptive, which can raise SHBG. And then in TSHoma, often these tumors are mixed and co-secrete growth hormone. And we know from our own practice that these mixed tumors, if they do co-secrete growth hormone, SHBG can often be falsely within the normal range. So actually, the message I'd like to leave you with is that this therapeutic maneuver, or diagnostic stroke therapeutic maneuver, probably is one of the things that we find to be quite helpful in these very difficult cases. And importantly, this trial of somatostatin analog, you need to look at the response after the long-acting analog treatment. It's not the short-acting analog that is used to do this test. And what this paper showed very nicely in a small number of cases, but I think has held up in centers, including our own, where we use this test quite a bit, is that in general, the patients with thyroid hormone resistance escape from inhibition from somatostatin analog. So when you measure the thyroid hormones after 3 doses of long-acting analog, there is really no significant diminution in T4 or T3 compared to baseline. Whereas in contrast, the majority of patients with TSHoma do show a very nice biochemical response, which can be diagnostically helpful. Of course, we all know that there are patients who are somatostatin analog or with genuine TSHoma who are analog resistant. So I guess that we have to accept that this test is not completely perfect. And last but not least, drawing it together very nicely with my colleague, Professor Gunnell, who may have alluded to this in his talk on endocrine imaging, but he may have talked about adrenal. Just to say that Professor Gunnell has shown that this administration of somatostatin analog is also very helpful in localizing the TSHoma. So this is one of his patients who on conventional dynamic MR, really one couldn't visualize where the microadenoma was, but then they administered 11 carbon labeled methionine and undertook imaging, identified a hot spot here in this part of the gland, and then after administering analog for several doses, one can re-image the patient with this tracer and show that there is extinction of activity. And then, of course, if it's appropriate, you can direct your pituitary neurosurgeon to go in there and remove the microadenoma. So I think I'm virtually out of time, so I'm going to stop at this point. I've just shown here a table illustrating the various genetic entities that we can make a diagnosis of, showing that they all have slightly different discordant patterns of thyroid function tests, which form a pattern where you can guide your genetic testing based on all these measurements if you happen to do all of them. And just again to say that if you were to send us serum samples, these are the sort of things, assays that we can do and our laboratory can do. And then these are the sort of genetic entities for which we can do genetic testing. I need to acknowledge my colleagues, my co-workers, very important. So in our assay laboratory, these two individuals are very, very important. Over 20 years or more, we've had a very productive time in developing assays, thinking about these problems and how to navigate them. And Professor Gunnell particularly has brought to this table the differential diagnosis of TSHoma. So if you would like to refer cases to us, our email addresses are here. Mark, I think it's fair to say, is principally interested in the TSHoma entity. We're interested in helping with our colleagues navigate assay interference, and then I'm interested, as I've said, in thyroid hormone resistance. So I'm going to stop there, and I'm very happy to take any questions, and thank you for your attention.
Thank you very much, Prof. There was a masterclass in discordant thyroid function tests. It gave us pleasant memories, actually sitting back in Cambridge, actually going through these cases and working them with you. So before we start audience questions, I'd like to kickstart with one question with relevance to the macro TSH. And specifically in relevance to, obviously, these are individuals who are clinically euthyroid and they have basically a TSH which is elevated. You also mentioned that, in a cohort of even subclinical hypothyroid, there were certain instances where, this macro TSH is detected. So with your experience, do you have a particular ballpark figure? Because, it obviously doesn't have a particular thyroid biochemical signature, I presume. So is there a particular point where you would think that, or would you just look at the clinical picture and then, subject these samples to a pegylation?
Yeah, Anand, I think that's, it's a very difficult entity because, as you say, finding individuals with a slightly raised TSH and normal thyroid hormones is something that we encounter very commonly in clinical practice. And my approach is to sort of gather as much ancillary evidence as possible. So, of course, measuring antithyroid peroxidase antibodies to give evidence there's Hashimoto's thyroiditis. Sometimes one might want to go beyond that and do an ultrasound of the gland, looking for abnormal echo texture, because the TPO antibody test is, not perfect. And then, as I say, when one embarks on treatment and you find that TSH is not responding as you would expect to thyroxine therapy, that's probably where the lab can go back and revisit that TSH measurement and look at it very carefully with dilution studies and with PEG and tell you, that TSH is unreliable. So then you have to rely on your clinical acumen or your clinical assessment plus the thyroid biochemistry.
Thank you, Prof. Thank you, Prof. I think we've learned through this after some time from Cambridge. One more question with regards to people with FDH, familial dysalbuminic hyperthyroxanemia, women who undergo pregnancy, obviously nowadays with the tight targets, especially in women who have a bad obstetric history, difficult to conceive, where we think this could be a contributory factor. We want to target the TSH to a certain level. How do we go about treating these individuals? What should we be using as a target for treatment? The TSH, T4, T3?
Yeah. So, okay, so in case I skipped over that point, the important thing to say about all of those binding protein entities is that indeed, they're entities, that they're not disorders in that sense, okay? So these individuals are completely clinically euthyroid. And in short, once you've made a diagnosis of FDH, really, you cannot rely on any particular immunoassay platform for measuring T4 and T3. You have to be guided really by TSH. So yes, over the years, we've collected really unusual cases of what I would call, double entities. A patient who has an FDH variant and then, as you say, has to be managed through a normal pregnancy, or they've then gone on to develop Hashimoto's hypothyroidism, and then you have to face the prospect of how do you titrate thyroxine therapy. And the short answer is just ignore the T4 and T3 nut values and be guided by the TSH.
Also, with regards to the RTH, do we still have the concepts of a generalized hormone resistance, pituitary, the peripheral, which we used to have traditionally, or has this field moved on to decipher this into different entities completely?
Yeah. So as I showed with that particular patient who had RTH, he was a 68-year-old man who presented with AF and thyrotoxic cardiomyopathy. So given that many peripheral tissues express TR alpha, the normal receptor, we now recognize that if you look hard enough, most of our RTH patients have some symptoms of hyperthyroidism. Minimally, they may just have a resting tachycardia. But beyond that, some of them develop in the pediatric setting. They can present with increased appetite, hyperactivity, failure to thrive. In the adult setting, they can present with tremor, palpitations, anxiety, insomnia. And yes, when that occurs, we give them this label, which I think is still helpful. We call it predominant central or predominant pituitary resistance. Whereas another group of patients, for reasons that we don't understand, they may be completely asymptomatic. They just have a goiter and they have no thyrotoxic symptoms. And the distinction is useful because for the generalized patients, our advice is leave well alone. Don't do anything that interferes with their pituitary thyroid axis. Whereas with the thyrotoxic individuals, you could either give them beta blockers if it's tachycardia, or we use the drug which I mentioned for MCT8 patients, Triac, the analog Triac.
Thank you, Prof. We'll just move to the audience. Any audience questions, Prof?
Thank you, Professor Chris Chatterjee, for a brilliant talk. As Anand said, it was a master class. I had the fortune of listening to Professor Mark Gurn 11 years back, 2011, in Indian Thyroid Society, where he spoke about interpretation of the thyroid function test. That was more of a clinical one, and you have given us the background of the genetic background and others. The problem what we face today is, most of the patients come with a thyroid report, and these are all part of the regular checkup. Hundreds and thousands of labs. Every city has 100 labs. Now, I can't afford to do in Beckman and Abbott and 10, because most of us, either we have radioimmunoassay or we have got the other ones where we do. So we can't afford, all right, I can agree some dilution and others we can do. I feel ultimately all this knowledge is good, but when you see 30 to 40 thyroid function tests, we know most of them are routinely, you don't know even the background also. Why did you get part of it? And it is so affordable, available, that anybody can afford thyroid function test today in India, maybe even free also. The problem we face, they do T3, T4, free T3, free T4, and TSH, maybe not even 1 pound or 1.5 pounds. That is the problem we face. Many times we know there's a discordance. I go to clinical history examine, I don't find anything. My, after 4 decades of it is, let me follow up 1 month, 2 months, 3 months, nothing changes. And what was abnormal, later on the same lab becomes normal. And follow up with the patient I feel. Maybe 0.1% of the patients, okay, think of RTH or you think of a TSH tumor. And many of the subclinical, we see so many subclinical, maybe diseases in the laboratory rather than in the patient. So serial follow-up where we know it's not going to matter much. I mean, frank hyper we treat, maybe TSH tumor with 30 years I might have seen 2 or 3. Even if we have missed some of the genetic things, I don't think we have done any great injustice to the patient. It may be a good academic exercise, I agree with that. I was also a professor 30 years. So this is what we feel. And also reverse T3, we heard so much about reverse T3, its role, and today we hardly talk of reverse T3, thanks to you said. It is also one of the armamentarium rather than one thing which makes a diagnosis. What's your comment on that?
Yeah, so, I think we face the same problem in the UK as well. In our population of 60 million or so, they do 10 million thyroid function tests a year, and it gives rise to the same propensity to pick up these interference entities. One thing I think is worth commenting on, in one of the articles in Endocrine Reviews on this subject, the authors actually made some calculations about the financial risks of misdiagnosis. Well, financial in terms of unnecessary cost of additional investigations, and then also for the patient, the risk of inappropriate therapy, let's say thyroid surgery or radioiodine ablation. So I think for that reason, it is worth doing simple investigations to be really confident that the abnormal biochemistry that one is seeing is genuine and not due to measurement interference. So yes, so if one were to do simple investigations like method comparison, by which I mean measure the same hormones using a different assay. And in fact, despite my comments, I think if you have access to a one-step method versus a two-step method, that method comparison is actually very helpful, because many of these entities will cause interference in one step but not in two step. And if you see a free T4 which is 4-0 in one platform and 15 in another, it makes you stop and say, okay, maybe this is not correct. So method comparison, measurement in dilution, and PEG precipitation, these are things I would argue a good laboratory should be able to do. With regard to genetic testing, another thing that I didn't point out, all those variants in the albumin gene are in one small part of the gene. And likewise, all the variants in transthyretin are also in a very small part of the gene. So in terms of genetic testing cost, it's only one portion. You only need to set up one PCR reaction in your lab, and you can identify all these genetic entities with sequencing. So actually, if you I would argue that, and that's what we find, that once you've set the assay up, it's not that expensive to do. And being a genetic test, it's pretty black and white. So once you find the mutation, you know, you can just set it aside. So yeah, so I think those would be my comments. And then as you say, the clinical context is also paramount. You know, if the numbers that you see in front of you are discordant with the clinical status of the patient, or there is something else in the environment, like non-thyroidal illness, a psychiatric condition, medication, and then you take those influences away, and a couple of months later, the thyroid function tests come back as normal, then that's a relatively inexpensive way of sorting it out.
Thank you very much for the answer. And 99.9% of all the assays we do is only one-step free T4, except few research centers. Nobody is doing two-step of free T4. And as you said, I'm happy with that for the lab. For a clinician, that's good enough for me, even though there are few cases where you said it may. And you showed some slide to show how one step is good enough. Thank you very much.
Thank you, Prof. The other question I had was with regards to biotin. I mean, you projected a particular patient with the high free T3 and free T4. So could it be the other way around also? Could you get a result with a low free T3 and a low free T4 with the biotin? That's number one. And number two, if we were considering that as an interference, if we were to stop the medication, would we say that, you know, a 3-day period of, you know, off the medications would be enough, or would it be like at least a week to actually, you know, sort this problem out from the clinical standpoint?
Yeah. Yes. So again, I skipped over that. Yes, the different manufacturers use streptavidin and biotin in their assays in different ways. So it's quite possible that the biotin can cause not only positive interference, so to speak, but also negative interference. And, which I emphasize again, I dwelt on misdiagnosis of thyroid entities, but the biotin thing can also lead to misdiagnosis of a whole plethora of things for which the manufacturer's autoanalyzer uses the same architecture, you know, all kinds of analytes. With regard to avoiding the biotin interference, I would guide people to a very recent paper, I think in thyroid, where they took healthy subjects and administered biotin, and then they did thyroid measurements and thyroglobulin measurements over a long period of time. If memory serves me right, I think avoidance of biotin for 48 hours is okay for the thyroid assays, but for measurement of thyroglobulin, which is what you would be doing in a thyroid cancer setting, you might even have to stop the biotin for a lot longer. And there's also a dosage threshold. I think something like about 5 or 10 milligrams of biotin above that is when you run into this problem.
Thank you, Prof. Thank you very much.
So it doesn't have.
Sorry. Prof, you're muted. Sorry, Prof, we can't hear you. I'll just check from my end, sorry. Can you hear me, Prof?
Yeah, I can hear you.
Oh, yeah, we can hear you now. Yeah. Sorry, I just missed the last bit. You were talking about, the interference with the other hormones too, so.
Yes, yeah, and yes, I was saying that 48 hours may be enough avoidance of biotin, but thyroglobulin, they've said it may need to be longer, and also in terms of the dosage of biotin, vitamin replacement doses like 30 micrograms don't cause this interference. It's if you're taking mega doses of biotin, several milligrams of biotin.
Yeah. So thank you very much, Prof. That was a fantastic session. I think everyone enjoyed it, and clearly, as I said, it was a masterclass in thyroid function tests and discordance. It made us understand and actually unravel the complexities involved. From a personal front, thank you very much for accepting our kind invitation to be here at Trendo 2022. I look forward very eagerly to invite you very soon in person back to India at some point in the near future.
Thank you again to you, the organizers and the audience for your attention. And last but not least, feel free to contact us, as I said, over any difficult or interesting cases. We're very happy to help.
Thank you very much, Prof. Thank you so much. Bye. So with that, I think we'll draw an end to this particular session, and this would be the last session from Hall B. Thank you very much, all of you, for your kind attention. Thank you.
கத்திட்டே இருக்கீங்க காதில் வாங்க